And I want to welcome everyone to this Transparency and No Surprises Act Summit. What I would like to do is you're going to be hearing shortly from my colleagues about to really set up the topic and to hear in more details from our panelists. We have a great number of highly qualified speakers today, and I want to thank them in advance for their commitment to bringing this discussion to everyone, and for each of you for wanting to hear more about the No Surprises Act. What I want to start with is an example of how items get brought to the attention that would, in fact, through a work group discussions or multiple work group discussions. This item was brought up, and we started then investigating further what we could do on the educational front to further discuss transparency, no surprises, and as a result, working through our work groups and through a task group, and then coming together to within the educational structure to develop this agenda. And you'll hear from my colleagues in a few minutes for those who were putting everything together. So at WEDI, I talked about how the work groups are essential to making things happen. And with that, I wanted to just cover a few items for those who are not as familiar with WEDI as others. Just to remind you, we are about 30 years old. We were started by an instrumental and being brought together by innovators, visionaries who wanted to address administrative simplification, issues of joint concern between payers, providers, vendors, government, and when you think about it, that was 30 years ago. And what we see today is an opportunity to demonstrate how we are continue on this task today as a trusted advisor to the Secretary of HHS, as a leading authority on the use of health IT efficiency to improve health information exchange, enhance care quality, and reduce costs. A focus on standards for electronic administrative transactions, promoting privacy, security, data privacy and security, and aligning the industry in an effort to harmonize administrative and clinical data. There are key focus areas of administrative simplification, value-based reimbursement models, data standards compliance, the MACRA key implications for health plans, providers, vendors, health IT, cybersecurity issues, business and regulatory issues, interoperability and data sharing, telehealth, revenue generation strategies, automated attachments, and other operational efficiencies. As I mentioned, we work through the great efforts of our work groups, and we have about 15 that are listed here. I don't need to go through what each of the work groups do, but I hope you will take the initiative to go on our website, click on work groups. There's a description of what each of the work groups do, and plan to, if you haven't joined a work group, please do so. There is a link from the website, and our colleagues within WEDI will help get you organized and involved with WEDI. With that, I think, Rob, I have want to turn it over to you to give us all an overview of today's summit. And again, thanks to all of our faculty for agreeing to help us with your presentation today.
Thank you, Charles. And let me just add my welcome to the participants. And a special thank you as well to our faculty. We are very pleased to have some of the greatest experts in the nation on these issues join us today. So next slide. So I wanted to give you just sort of an overview of what we'll be discussing today. We'll start off with, I'll give a high level, sort of 60,000 foot perspective of the issues. And then we'll move into the issue of hospital price transparency, followed by health plan transparency. So you'll get a good sense of what's happening in today's environment and in the forthcoming requirements for health plans. We'll take a little break, give you a chance to grab some lunch, and then in the afternoon, we'll kick off, next slide please, with a discussion of the No Surprises Act. A lot of us have looked at this and seen it as it's going to be an interesting journey, to say the least. So we'll talk about the advanced explanation of benefits. And then in the 2:30 session, we'll focus on a number of the other provisions that haven't gotten a lot of attention, but could prove to be challenging for the industry. We'll wrap up. We've got some really smart folks to join us for the last session. We'll sort of summarize what we've heard from the panels. Then we'll look at sort of the top challenges, some of the issues related to timelines, and then really look at identifying some recommendations for the go forward, both for the industry and also potentially for the government. And I did want to mention we are expecting to have some representatives from CMS at the summit today. I think they're going to be interested to hear what you all have to say. Obviously, we're virtual, but I want you to take advantage of the chat feature. If you have questions, you've got comments at any time, please enter them there. The moderators will be watching the chat and be able to either incorporate your question or wait till the end of the session to address it. So please take advantage of that. Next slide, please. So I wanted just to walk through each of the areas so you've got sort of a high level understanding. Next slide. So in terms of hospital transparency, I've hyperlinked the rule. You know, if you're looking for beach reading, we've got links to final rules throughout the deck here. But in November 2019, the final rule required hospitals to make public 5 types of charges: gross charges, discounted cash prices, payer-specific negotiated charges, de-identified minimum negotiated rates, and de-identified maximum negotiated rates. Next slide. And they were to present them in 2 ways: a machine readable file and a consumer-friendly display of what they call shoppable services. And we're going to talk a lot about these machine readable files throughout the day, because as I think you all know, the aim for the government here is not just to allow access to the information by patients, but also by third-party apps to come in and gather the data, curate it, and present it back to the patient. Next slide, please. Go ahead, next slide, Michael. So the final rule on the health plan side came out in late 2020. And again, the same aim is to make healthcare pricing information accessible, but again, consumers and other stakeholders. And again, they specifically identified third-party app developers. And again, the idea is to make information about the patient available to the patient, with the idea of, at the end of the day, it's going to improve patient outcomes by engaging the patient in their own healthcare. And of course, this health plan rule built off of the hospital transparency rule. Next slide, please. So I won't go through this too much in detail, but there are 3 phases of compliance. The first deadline is coming up in January, which requires the health plans to update on a monthly basis in-network provider negotiated rates, historical payments to out-of-network providers, and in-network negotiated rates. And again, the idea is these machine readable files are meant more so for these third-party apps than consumer use. Next slide, please. So the next 2 phases begin in 2023 and then 2024. Again, an online shopping tool giving a personalized estimate of their out-of-pocket costs for what they say are 500 of the most commonly used items and services. And then by 2024, all of the remaining services, including procedures, drugs, DME, things like that. So next slide. And so along comes the No Surprises Act. And again, it was driven by a desire to protect the patient from these surprise bills. So you go in, God forbid, an emergency situation, and you're discharged, and along comes this surprise bill because perhaps the facility, one of the physicians, one of the services was out of network. And so the idea was, is there a way to protect the patient? And while they were crafting this, and it was not easy, there was a lot of negotiation between health plans and provider organizations, they came up with sort of a compromise approach, but they also came up with some other concepts, which is what we're going to focus on today in the summit. And again, the bill itself didn't pass, but it was incorporated into the Consolidated Appropriations Act of 2021, and we've included a link here. Again, if you're interested in reading the actual law, which again was passed in late December in a bipartisan fashion, which is not an easy thing to do, as you all know, in today's environment. Next slide, please. So many of the sections go into effect starting in January, but it's a rolling start for many of them. It sects with HHS, Treasury, and Labor, so we could see regulations and guidance come from all 3 departments. Some of the provisions, the regulatory provisions, are required to be released by July next month. And toward that, we did see that one of the NSA regulations has been received by the Office of Management and Budget, which is the last step before publication. They do have by law up to 90 days to review a regulation, but they are not required to take that full length of time. So that means the regulation could come out virtually any day. Next slide, please. So I wanted to highlight our claims sub work group, in particular the co-chairs. You'll hear from 2 of them today, Beth Davis and Stanley Knockomson, but Rose Hodges as well. They identified the No Surprises Act as something that would be of impact to WEDI members, and help craft a letter to the HHS secretary outlining a number of key issues, including advanced determination of benefits, concerns about how the workflow would enable that the data to flow, what services would be impacted, what payers would be impacted, issues around some of the requirements with the ID cards, and of course, compliance timing. Can all this be done in the time frame that Congress and the administration is anticipating? So I encourage you to have a look at the letter. It won't be the last one. I guarantee that Weedy sends on this topic. And again, we're going to be very active in this area. So with that, next slide. So I think what we want to do is move to our first panel, and I'm very pleased to introduce my friend Stanley Nachimson, who will be moderating the session on hospital price transparency. Thanks so much, Stanley.
Oh, Rob, thank you. Pleasure to be here, and I want to compliment the folks at Weedy for scheduling this as the first session today. They were smart enough to recognize that these were the first set of price transparency requirements that are already in effect. Hospitals were required to meet the requirements of the price transparency rule on January 1st of this year. So we're beginning to get some experience with price transparency. Today, we're fortunate to have on the panel sort of both sides of the equation for this data. From the producer side, so to speak, from the hospitals, Terry Cunningham, who is the director of the Administrative Simplification Policy for the American Hospital Association. And from the consumer side, the folks that actually use this data, Cynthia Fisher, the founder and chairman of the Patient Rights Advocacy.org. So we'll talk today a little bit about the experiences from both sides, some lessons learned, and perhaps the next steps along this path to price transparency. So Terry, let's start it off with you from the hospital side. Take it away.
Thanks so much, Stanley, and thank you all for joining us today on this important issue. Just give me 1 second. I'm going to share my slides so that we are able to see what I'm talking about. Okay. As I said, thank you all so much for having me. My name is Terry Cunningham. I'm the Director of Administrative Simplification Policy with the American Hospital Association, and I'm happy to join this group to discuss the hospital price transparency rule. So to kind of level set as we jump into this rule, as Rob really already covered, this is sort of one of three types of healthcare price transparency policies that are in effect, that are on the table currently. Obviously, this is the hospital price transparency rule. There's also the transparency and coverage rule, which is the insurer rule, and the price transparency policies that are included in the No Surprises Act. All of these together are all kind of, while they approach the issue differently, they're all focused on attempting to get the transparency in the prices of various items and services in healthcare. This specific rule, the hospital price transparency final rule, I think I'll start by saying, kind of level set this session. This rule has been discussed quite a bit over the last couple of years, and it's been contentious with certain people disagreeing as to its merits and others, pushing for its merits. I'm not here to discuss the merits of the law. This is the law of the land currently. This is what hospitals are required to meet. And so what I'm here to discuss is really what some of the experiences hospitals have had in attempting to come into compliance with this rule. So with that said, I'll give you a brief overview of the final rule. The rule implements section 2718 of the 2718E of the Public Health Service Act, and it requires hospitals to make a list of their standard charges publicly available. Prior to the final rule, there had been some guidance as to specifics, but really what the final rule did is it went a long way to specifically define some of the key terms that are required to come into compliance. It defined standard charge hospital items and services. CMS defined standard charges in five different categories. Hospitals, in order to be compliant, have to make available their standard charges, which are their gross charges, which is basically a hospital's charge master rates, their payer-specific negotiated charges or rates, the de-identified minimum and maximum negotiated rates, and the discounted cash price or walk-in rate for the hospital. They also defined hospitals, and the hospitals is essentially all institutions licensed by a state or local law as a hospital that serves the general public, which includes critical access hospitals, IRFs, and various other kind of flavors of what a hospital entails. Additionally, CMS defined items and services as all items and services provided by a hospital, including facility fees and professional charges, obviously what physicians would bill, for all professionals employed by the hospital. So in order to be compliant with the rule, this data that we just discussed needs to be displayed in two ways. The first is there needs to be a list of all 5 types of standard charges and item services, generally like a spreadsheet that would have this information. And they're also, this is the machine readable file that Rob discussed. The file needs to include a description of each item and services, the corresponding standard charges, and any hospital accounting or billing codes. The second way this information needs to be displayed is in a consumer-friendly website for 300 shoppable services. And what the 300 shoppable services entails is 70 services specified by CMS. And this is really categories such as evaluation management, laboratory, pathology, radiology, and medicine and surgery, kind of some of the common things that you would expect a hospital to have. There's also the other 230 are really at the discretion of the hospital, and it's really based on kind of volume of what they have, but there's 230 at hospital discretion. Now, one thing that's important in this area is the rule did establish that a hospital's out-of-pocket cost calculator would meet the requirements. And this was what this rule did. What was important for this is that these were kind of already gaining popularity. There was a lot of hospitals working to try to develop out-of-pocket cost calculators, but this really lowered barriers to entries and really accelerated the adoption of these policies. As I said in the beginning, this is the requirement, the law currently required of providers. It went into effect on January 1st, 2021. And in order to ensure that hospitals are abiding by its terms, CMS has begun proactive audits of hospitals and a review of complaints on the hospital price transparency website. The audits began with kind of large hospitals, and now they've expanded to include a random sample of all acute care hospitals. And then basically what happens is if a hospital is out of compliance, they'll receive a warning letter. And upon receiving this, it's a non-compliance letter. Upon receiving the non-compliance letter, hospitals have 90 days to address the identified issue and become compliant. And then CMS will re-review. And then depending on the findings, the hospital's case might be closed, or the hospital may be issued a second warning letter or a request for a corrective action plan. And ultimately, if the hospital does not submit a corrective action plan and do not follow by basically the terms needed to come into compliance, a civil monetary penalty of up to $300 per day can be issued against them. So what are some of the challenges that hospitals faced in trying to come up to compliance with this law? The first is the COVID-19 public health emergency. Obviously, this is how we view everything that's happened over the past 15 months. But specifically as it relates to the incorporation, the implementation and the development of the things needed to be compliant with this law, there was a difficulty in this area. And really what that is that IT and revenue cycle staff are really important to the development of this. Obviously, IT are going to have to develop a lot of the web interactions and the build outs. And then revenue cycle staff are going to be the folks who are really essential to helping calculate these numbers. These were also these resources and staff were extremely essential to meet the demands of the public health emergency. You had telehealth that was expanding extremely as a result of it. You had the vaccine rollout, and you had a lot of unique billing situations. For example, I know CMS had, it was hundreds of pages on all of the different waivers they had. And these are really things that your, in order to kind of address a lot of the unique billing situations, there was a lot of time and energy and resources that had to be focused on meeting the demands of the public health emergency. As a result, I think there were some hospitals that kind of the resources were so committed to public health emergency that it was a challenge to becoming compliant with some of the regulations, what it was calling for. The second is there was a bit of a lack of guidance and clarity. What I mean by that is, although the law stipulates kind of the information that needs to be provided, there's a lot of ambiguity contained in there. And really hospitals, they didn't exactly know what does a compliant spreadsheet look like. CMS established that it needed to include all standard charges. And I discussed what those standard charges entail, but it kind of left the hospital to determine the format of the spreadsheet and kind of how to calculate some of the figures contained therein. One of the areas that, for example, is how to calculate negotiated rates. For a lot of you who are involved in the negotiation into the adjudication of claims, you'll know that certain items and services do not have one set of negotiated rate. There's certain things that could impact what that rate might be. For example, if you're setting a rate that is supposed to be inclusive of providers, of physicians, do you include in your rate the physician charge? What happens if the hospital doesn't employ their physicians? And so there's this kind of ambiguity, and there was kind of a need for some additional sub-regulatory guidance that never came. And as a result, a lot of hospitals have been working to kind of arrive at what their compliance spreadsheet is. But in order to do so, there's a lot of decisions that have to be made in terms of how am I going to calculate this? And really what that could result in is a potential for not having apples to apples comparisons on the end. You could have one hospital that decided to arrive at what a negotiated rate is in one manner, and another hospital that decided to arrive at what that negotiated rate might be in another manner. And then again, you've got various factors in terms of setting and some of the resources that might be necessary. You know, what type of, if you're getting a knee replacement, what type of supplies are needed by the individual? What types of supplies does the particular physician in this case want to use? And there's some variance that could arrive in there. And in order to kind of arrive at that, there is really there's the risk of having different hospitals calculate this in different ways. And again, the challenge being you might not at the end arrive at an apples to apples comparison. In terms of lessons that the hospital kind of has and really are currently learning as hospitals are either under compliance or working to get under compliance, whatever it might be. We don't have a specific number, but we know majority of hospitals are attempting to comply with this law. And some of the lessons, I've discussed some of the challenges that might have been at issue. Some of the lessons learned that might be beneficial as this relates to, we're talking about all these things through the lens of the No Surprises Act. The first is really not much to learn from. It's the COVID-19 public health emergency. Really, the only thing you can learn from that is this, in order to develop something like this, it really does require a lot of internal resources on behalf of the hospital. And so, to launch at a time when there's other demands is very difficult. So not much of a lesson learned, but it's really, I think it helped accentuate how much resource intensity might be involved in something like this. The second would be a need for piloting and testing. And again, this is really, as hospitals tried to become compliant with the rule, there was so many issues where they were trying to figure out exactly what is the government looking like, what is the government looking for, what are some of the issues that could arrive. I think this is something that, had this been piloted and tested at length prior to kind of going live, these are maybe some of the kinks that might have been worked out. And so I think it's important for when we're moving down the line with developing future price transparency requirements, there's really such a benefit to having sufficient piloting and testing. The addition, and this is something I talked about on the last slide, is the importance of sub-regulatory guidance. Again, a lot of hospitals were kind of throwing their arms up in the air, trying to figure out, I produced a spreadsheet. I don't know if the way I calculated is exactly what CMS was looking for. And so I think there was a need for sub-regulatory guidance. I will say that it appears, based on what the health plan transparency rule is looking like, that there is, I don't want to say lesson learned, but there was a significant additional sub-regulatory guidance in that rule. And so it does seem as the rules are coming, as future rules have been coming out, CMS has been issuing additional assistance to help those who are required to become compliant with the law, kind of giving them some assistance in order to arrive at that compliance, which again will ultimately help the usability of the final product. And then the final thing is the need to streamline price transparency efforts. I think this will be something we talk about throughout the day, but I think it's extremely important to ensure that patients receive their out-of-pocket costs and can really make educated decisions as it relates to their care. As an industry, I think it suits us to identify which of these, kind of streamline and make sure that we don't have multiple ways of arriving at the same data. And the reason that is if you've got multiple ways, you've got kind of additional resources. These tend to be resource intense things to develop. And so it's important to ensure that we're not building something that arrives at the exact same information that another regulation might arrive at. That's the end of my conversation. That's the end of my presentation. And I think Cynthia is our next speaker, and happy to take questions later, but I'll kick it back to Stanley. Thanks, Stanley.
Thank you very much, Terry. Appreciate the presentation from the hospital side. Just as a note, we've got a number of questions in the chat. We'll take all those questions and try and answer them at the end of this next presentation. The second member of our panel to present, as I mentioned, is Cynthia Fisher, the founder and chairman of patientrightsadvocate.org. We are going to now hear from the other side of the equation, from the consumers, what hospital price transparency has meant to them, what their experiences are, and perhaps some next steps. Cynthia, welcome, and please take it away.
Cynthia, you're on mute.
Thank you, Robert, for the invitation to be here today. Thank you, Stanley and Terrence as well. It is an honor to be here today to represent the voice of the American consumers of healthcare. Who are the consumers of healthcare? Well, the consumers of healthcare are the patients, as well as employers, workers, union members, and taxpayers. So patientrightsadvocate.org has come to Washington to bring the voice of the collective American consumers of healthcare to the table to effect change. One of the most pressing issues in our country is the ever-increasing costs of healthcare, both of care itself and of the ever-increasing high single-digit and even double-digit rise of insurance premiums. Why is that? Well, the reason being is that we do not today have a functional competitive marketplace in healthcare. It is a lopsided and not a market at all. In fact, because the patients have been blind to know prices before they get care. And then oftentimes, and in most cases, blindsided by medical bills they never expected to have to pay. Follow that by penalty of law, when they get their care in hospitals and register for care, they're held accountable to pay whatever the hospitals charge with a blank check. And then if they cannot pay that, they've been sent to collections where nearly 58% of the debt in this country faced has been claimed to be medical debt. That said, the imbalanced equation through healthcare and hospital price transparency is a huge win for the American consumers to, for the first time ever, be empowered to know prices before we get care and to be able to see the competition. And from competition, it will be consumer choice to be in the driver's seat where we look and we'll search for also ushering in knowledge of quality differences. And when shopping and seeing competition for both price and quality, the consumers will shop for the best quality of care at the lowest possible price. And we know it works. We've seen it work. And we've seen it work from innovative employers and their plan members and union members that have found a new way, and that is to seek and steer their plan members to price transparent physicians and providers that provide the financial certainty upfront of what the true cost, what the true price will be in its entirety before they get care. These wide price variations that exist across our country can in fact be normalized to fair prices through real price transparency and a real functional competitive marketplace in healthcare. And in fact, empirical evidence has shown us from employers from Pennsylvania to Texas to Ohio who have contracted directly with price transparent primary care docs, direct primary care physicians that post their prices up front, surgical centers that have left the hospital system and independently provide price transparent means, cutting out many of the administrative waste, have been able to lower their planned costs for healthcare by nearly 30 to 50% for their plan members. This can happen for everyone in our country, where we see nearly a $4 trillion budget in our national economy is nearly double of every other developed nation that competes on a global scale. The impact of the opacity that has been rampant in healthcare has devastated small businesses and medium and large businesses, but most importantly, the individual and their families. Let me give you an example, because Patient Rights Advocate hears from thousands and thousands of patients, and many times each day we struggle to help them remedy overcharges they've experienced in their care. Price transparency, even though right now what we have seen across the board reported by the Wall Street Journal, Anna Wild Matthews, showed that many of the over 6,000 hospitals are not in current compliance. I disagree with Terry's presentation that this has been a burden to the hospitals. These negotiated rates are part of the hospital billing process in order to conduct business. It's merely pulling back the curtain and posting them online so that technology innovators can get every single data point of the actual prices by code, by plan, by payer. And on top of that, to allow the consumers to the first time ever see that curtain pulled back so they can see what is that discounted cash price and what is their insured rate and what is every other insured rate or plan rate for their plan procedures. What we have found is for someone like Mason out of Colorado, a 20-year-old college student who had his first experience at a nut allergy, went to the emergency room. And thanks to the doctors and nurses that have helped him through that care and the hospital frontline workers, many thanks. However, when Mason got home, he was given before he left a prescribed EpiPen that the hospital provided with him in leaving the hospital. What he was charged months later was a huge $18,372 bill, $15,000 of which was billed for the EpiPen itself, which only had 2 weeks of date left until it expired. On top of that, his insurance eventually covered $3,845 as their negotiated rate. However, Mason's high deductible plan was $5,000. And from his explanation of benefits, he showed us to help him with the charges that he was left with, a total of $4,697 from his having to pay out of his high deductible. We went online and we looked at the exact hospital prices, the discounted cash rate, as well as his plan negotiated rate. And we found that his plan negotiated rate was $368 for that EpiPen. Because we took it to the C-suite, the CFO and the CEO, to show them these erroneous bills, they admitted to a glitch in their system and in fact forgave the entire bill. These types of situations happen every single day. In front of me today came in a young man who got an MRI at a hospital emergency room, and he's facing $11,000 in charges, $6,500 of which was simply a 3 Tesla non-contrast MRI for his lower back. Coincidentally, his good friend went 15 minutes away to Acumen to another out clinic, independent out clinic for the same quality 3 Tesla non-contrast image MRI. She paid discounted cash price at $450, including the radiology read. $450 versus $6,500 for his MRI, all within 15-minute drive. Had this young man known by searching online, maybe a Google search, maybe an application like Turquoise Health or Firefly out in Los Angeles, or many others that are looking to be in healthcare, what we benefit from as consumers in the airline industry, the uses of Expedia, Priceline, Kayak, all sorts of Orbitz, these types of tools enabled all Americans to be able to shop and compare prices of airlines and flights that, like hospitals, Terry, also have many variables facing those airlines every single day in the complexities of getting flights up and down and landed across our country. And yet, in the same way, the airline industry has posted prices, and in real dollars, since President Carter allowed for the deregulation of the airlines, what we're seeing in real dollars today, a 50% reduction in the cost of air travel, and hundreds of millions of people have broad access to fly, especially now post-pandemic. Thank you. And also, what does that do when consumers have power of information and power of choice to make their decisions? It improves quality and safety. We can expect the very same in healthcare price transparency. And what we have found, quite frankly, Robert and Stanley, we have found that in just this week's Journal of American Medical Association article looking at a random study of the hospitals across the country, only about 20% were complying in their report. And the remaining 80% either were doing nothing at all or posting some information but incomplete, with many, many steps of obfuscation, also reported by Anna Matthews in the Wall Street Journal. And what we know is there is wide price variation. And consumers' choice, like Anna's Wall Street Journal Sutter article, where she shows that a C-section for one woman in the same hospital facility could be $6,000 and another woman $60,000 for the same procedure, no complications. Why would any woman or family bringing a newborn child into this world want to or accept paying 10 times more? They wouldn't. You know, any one of us, I bet, is guilty of going that extra red light and turning our car around to shop for gasoline at 3 cents a gallon less than a competing gas station who might not have changed their price to that competitive level. We'll go to that extra mile to get that cheaper gas. And none of us would tolerate in a grocery store having someone ring up a gallon of milk in front of us 10 times less than we pay for that gallon of milk. When we see price transparency system-wide, wherever we get care, and I give great thanks for the American people bringing great thanks to many leadership administrations. We first applaud past President Obama and now President Biden for the Affordable Care Act, which gave us patients this power, this right to know prices, straight up, upfront prices before we get care. And then we applaud the Trump administration for actually taking the law in the Affordable Care Act and putting it into rule. And now we applaud Secretary Becerra and President Biden for embracing price transparency in making the affordable put back into the Affordable Care Act through broad enforcement of these rules. We're sorry to say that we did go through this intense COVID crisis. However, the actual calculation from HHS was that its cost was de minimis, estimated to be $11,868 in the courts when the hospitals sued to not show their prices. We won in the courts. We won in the lower courts, and we won in the appellate court. Why? Because we have the right as patients to be well-informed rather than ill-informed or uninformed as we seek to preventively protect our health, both physical and mental health, as well as protect our financial health. So as we look forward with such poor compliance at this time, which is really a de minimis cost, not even pencil dust in some cases, one could joke, as even the penalties that were put forth to hospitals, only $300 a day. Because the hospitals have not been compliant and yet know that what this will do to healthcare is so transformative. Technology exists today to unleash this data and enable, for the first time ever, consumer-driven healthcare to drive down the prices of care while driving up quality and safety for all of us. And what does that do? It makes healthcare broadly accessible for so many that today, 64% of Americans decline or deny themselves going for care for fear of financial ruin. So if hospitals and insurance companies can see the model is one to evaluate that they can enable trust, honesty, integrity, and getting straight up upfront prices, just like any other marketplace in our economy, then patients will go again to preventatively take care of their health, take care of getting those mammograms every single year, rather than coming in with stage 2 or 3 breast cancer. But that said, we are finding that hospitals are also obfuscating getting the discounted cash prices when patients want to compare them to their negotiated rates. So many patients have high deductible plans, and so many of their first monies are spent from out of pocket. But let's not forget that it's all of our healthcare costs as consumers are not just out of pocket. It's out of our wages. It's out of our earnings. We share in the cost of premiums, and we forego increased salaries and increased bonuses because of the runaway costs of coverage premiums. The only way we can actually be competitive as a US market on the global scale is if this huge burden to the American consumer is lifted. And so we are so excited for this time. And we would seek, because hospitals do not comply, we would ask them to comply. And when we looked at the top 10 hospitals in this country by net revenue and net income from their 2017 990s, we applaud the Cleveland Clinic and the University of Michigan for being the two that have stood up and completely are compliant. That's game changing. And we encourage all other hospitals to come online as timely as possible. And if not, we seek that Secretary Becerra and this administration enact much higher penalties that are actually significant and real, and perhaps per bed per day, so that the smaller and rural hospitals are fairly treated. And when you look at that, actually smaller and rural hospitals are quite competitive when you look at seeing their prices versus perhaps a large oligopoly within a major metropolitan market. We ask that penalties be enforced robustly and timely, and that a new novel thing could be that HHS and all of the hospitals actually notify their patients and make it very easy for us to know that we now have this right. No one knows. There were no public service announcements that all patients now have the right to know these posted upfront prices and to be able to shop and drive down the costs of their care and have financial certainty. And then we ask for very easy implementable standards. And I agree with Terrence that, it would be very helpful if simply all of the data fields would be completely filled in, and that there would be an easy standard that as of January 1st, 2022, we could simply cure that the data's being presented in so many different ways and have it be in one simple file type, perhaps JSON or a CSV type of file for consumers to be able to easily see it, as well as technology developers. And then finally, we would say, please eliminate the price estimator tools. They are not real prices. They are not accountable. They do not hold hospitals accountable. In fact, there are many disclaimers not holding hospitals accountable for these prices. And in fact, what we have seen with the price estimator tools is a big game, it appears, to be collecting much personal identifiable data for patients to even seek a price, giving up cell phone numbers, email addresses, credit card numbers, all sorts of things, when in fact the rule asks that any consumer can seek these prices without any burden and without giving away any personal information. And then finally, we ask that we all envision the revolution of healthcare through consumer-driven care. And again, remember, consumers are employers, unions, workers, and patients. But can you imagine, and I think very soon with robust enforcement by HHS, that we can have healthcare work functionally, competitively, like the rest of our economy, where envision that patients will get straight up upfront prices. We choose where we go for that knee replacement or that MRI. And then the bill actually matches the price. And if it doesn't, we have 24/7, easy to access recourse and remedy by the hospital services that don't put us in a maze, don't require us to hire a lawyer and a patient advocate to fight confusing bills that don't match our medical experience. So when we have this, it's game changing, and it can happen with straight up upfront prices and price transparency, both in healthcare from hospitals and from insurance companies and system-wide, wherever we get care. Thank you.
Thank you, Cynthia. Certainly a vision that I think we all strive for, and that CMS has taken the first steps with hospitals, and in the future with health plans and perhaps other types of providers will all be able to see that information. Appreciate the views from both sides. We've gotten a number of questions in the chat, so I'm going to bring those up and ask you guys as the experts to answer them. The first question was, does the law require use of a spreadsheet or just a machine readable file? The commenter said spreadsheets are not typically considered the most machine readable of file formats. Terry, do you have any comments on that?
Yeah, I mean, I think I use the term spreadsheet, but you're right. It's just a machine readable file is really the more accurate term. But yeah, forgive me for using that term, but yeah, whatever format, and I think Cynthia touched on this, it'd be great if there was a set format, but however you're populating this file, whatever file that might be, if it's a spreadsheet or other manifestations of the data.
Right. So there's certainly one of the lessons or the things that we can take forward is that there needs to be better specificity as to the outputs that hospitals and others have to produce so that they can be used much more effectively by both vendors and consumers. I think both of you sort of made that point, and that's an important point. Next question, does this apply to hospitals only, not payers as well? Now, this particular rule does apply only to hospitals. The future rules will apply to payers. I'm going to mention that I thought the rules that apply to payers only apply to the CMS regulated payers. Is that correct or not correct? Terry or Cynthia, are you aware that for the payer requirements, is that for all payers or just the CMS regulated payers?
You know, I know that's our next panel. I'm sure they can get into the specifics of it, but I don't have it right in front of me right now. I look forward to learning quite a bit from the future panel.
All right. Cynthia, do you know if the rules apply to all payers or just the CMS regulated payers?
My understanding is it requires the next rule, which is the Transparency and Coverage Act rule, would apply to all payers and plans so that we can have system-wide transparency wherever we get care.
Right.
And then allow for the technology innovators to parse this information and provide amazing mobile apps and shopping tools for all of us.
I just have to, I do this often. Those of you that, and Cynthia mentioned the Priceline and those other tools. I'm fortunate that my brother-in-law happened to found and run the company. I won't mention either the company or his name, that actually developed the algorithms to produce those matrices that you see to help you shop for flights. An amazing accomplishment. He's an extremely smart person. We need somebody like that in healthcare to produce the kind of matrices that Priceline and others use for airline. I certainly agree that consumer-friendly output is something that's very important.
Yes, and I think, Stanley, there's an opportunity here to say why cost estimates really don't work. Consumers want to know what's that total bundled upfront price for knee replacement, for instance, or an ACL repair. And, a lot of these surgical centers are actually doing it, who are competing with the hospitals. They're putting an all-in price, some of them even including the entire rehabilitation process as well. And, this is what can be done. Those software tools are online. You can look at Texas Free Market Surgical or Surgical Center of Oklahoma. Those user-friendly tools are online, and patients really want, and consumers, being employers and unions, want to see these types of tools for actual straight up prices, both at the discounted cash price and their negotiated rates for their members.
Yeah, and I think that's what the No Surprises Act requirements sort of move towards. Terry, were you going to say something?
Yeah, I was going to say, I think one of the difficulties in arriving at where you've got this true cost comparison is that different locations define what all the services that are part of, let's say knee replacement. What are the services that are part of that, right? And so there's not really a standard definition, and you've often got times where, and so that's again, it's as an industry without a standard clear picture of what are you talking about. If everyone's got the same, these are the services that need to be, then you can obviously understand what that would be. And I think to the extent that something like Orbitz is possible, that's great. I will push back, and I don't think that the medical billing is that the airline pricing is as complex as the health insurer and the hospital pricing indices. I think there's a lot more players involved in here, and there's a lot more factors that go into it. But I understand what your point is. You want to ultimately arrive where you do have this truly shoppable and be able to compare. But I do think it's undercutting how complex a lot of these people on the line's job is to navigate this intricate pricing system that is healthcare to say it's the same as the airline industry.
Well, I think it's a great opportunity, Terry, for hospitals to have to compete and insurance companies to have to compete like any other business in our economy. Any company that looks to manage its supply chain does have complexities. Look at building an automobile, for instance. But I mean, you can look at the fact that knowing how you run and drilling down to your costs and cost efficiencies and quality metrics, being able to deliver the best service at the best price can be done in healthcare. It is being done. And so when hospitals compete with these ambulatory surgical centers that are price complete and bundle prices, that's a win for the American consumers. And it can be done. This is where the future is going. And, none of us shop for a movie at Blockbuster today. What did that do when Netflix came in and disrupted is, it saved a lot of people time and cut out many of the middle steps to get there, to get that downloaded film, right? It cut out a lot of steps and unnecessary administration and unnecessary time and travel and bricks and mortar. That said, this can happen in healthcare very easily because as well as I, so many middle players are between that patient's experience in your hospital to when they're billed. And many of those middle players can be efficiently eliminated when we have management like supply chain management in any other company and mitigated to that patient price, bill matches that price, experience and quoted price, and ta-da. This is our future, and we look to hospitals to efficiently get it done. And again, applaud those that have gone ahead and are changing the game and complying with these wonderful rules.
And I think we'll get to this later, but I think that's one of the beauties of the No Surprises Act is that you really are truly getting an adjudicated rate as opposed to, but anyways, that's for later discussion, but I do think there's an opportunity to get to somewhere where a patient truly has what their out-of-pocket expectation is. I think it might be more, I think the No Surprises Act might get at it in a more efficient and really accurate manner, but that's kind of, but we'll talk on that at length later, I know.
Yeah, and Terry, could we just get away from out of pocket? Because, it's really out of your wages. It's out of your earnings because it's the entire coverage and any other costs associated with it. And quite frankly, the easiest remedy for no surprises, is really for hospitals to show anybody who works in their hospital, with any radiologist, pathologist, any private equity owned physician practice, all of them can simply post and provide their prices also in completion, and then you bundle those prices so that it's all in, no matter where you hire or contract hire your employees. This can be done, and it's done in every other business in our economy.
But I think when you're talking about, can we talk about how it impacts your wages, you're talking about the cost of health insurance and how they set their premiums. That's not part of this law, right? Like how health insurers set their premiums is completely separate. I understand you're saying that eventually there could be a trip, but like there's no guarantee that this is going to lead to, this is going to directly impact your wages are lowered by this much because the health insurer, like that's not the case. This isn't speaking to the actual wages. I understand there's a broad healthcare comes from your wages. It also comes from your out of pocket, but this law is really truly devoted to looking at how your health insurance interacts with your out of pocket costs and what your final bill will look like. It's not about the manifestation of how costs that are coming into the health insurer are put forth and developed into a benefit structure.
Well,
I think that's an important, just one moment.
Excuse me, Stanley. I disagree with that because let me give you an example. Osceola School District outside of Orlando, Florida, Osceola School District had challenges with being able to have among the lower teacher rates in the state of Florida because of their ever increasing in the past 5 years rates of their premiums. And in fact, they want to pay their teachers more and attract quality teachers to their school system. And for 2 years now, they left their previous plan, their previous insurer, and went to a new system that went to this price transparent model. The first year they saved $6 million. Right now they're on target to save $15 million of what was $75 million they were paying out in previous years. Those $15 million are going to be looking very much so to increasing teachers' wages and affecting that union in a big way.
We can have agree to disagree here, but I don't see any provision in this that are actually saying health insurers are going to now tell you how their benefit structures are developed. I don't think that's part of the law. That's all my point.
Yeah, that's, I do want to point out that we'll move along to another questions, but I think, Cynthia, you're bringing out the point that out-of-pocket costs are probably the thing that an individual consumer is most concerned with, but the total cost of any set of procedures is something that employers and health plans and others are concerned with. So that there are sort of two sets of prices that people are looking at, and I think we might have to have some work done in educating folks about their out-of-pocket costs, how that impacts them, and then what the total cost does.
I don't know about you, Stanley, but when I buy a car, I look to know the total price and not just the price of the floor mats, So, if you look at what is the total price, is it a real price? Is it egregious? Have I been way overcharged? What is the comparative? What is the fair price? What is the Medicare price? What does government pay? People shop. They're not ignorant. They're not informed that they can be in charge of this once they see the prices. So just know that all they need to know is that they can have this power now. And we welcome HHS by making that happen for hospitals to notify patients up front, and also for HHS to know this is game changing. We all now have this right to know prices for hospitals.
Great, I understand. And here's a great question that I think both of you and I'm certainly concerned about. How do we work with consumers or patients that are not comfortable with technology and they need the education or advocacy to help them both navigate these new systems and even understand that they have the right to this information? Cynthia, I believe you said, or maybe Terry said, that there were no PSAs. The hospitals have, they put a lot of work and effort into coming up with these, the websites and the comparisons and the machine readable files. How do we best educate consumers and patients on navigating all of this?
Well, first of all, you could let all of your patients know with signs up front whenever they check into your hospitals that they have the right to know prices, both the discounted cash price and the negotiated rate. The Epic and Cerner or systems can also make sure that if you pay the discounted cash price, they don't make you register that you can also double bill your insurer, which right now those systems still say by penalty of law, they're going to send your data to the insurer, even if you want to just pay cash. And then finally, I think the websites, I'm glad you mentioned that. Most of our economy does run on data and banking. Look at, I can tell you that we know so many 80-year-olds and 90-year-olds that we've surveyed that even know how to use Venmo with their grandchildren. So when you look at mobile apps, people know and have been shopping for flights for years. That's the only way you actually book a flight today. And people can also get it printed out at the hospital or in paper form by a family member or loved one. But the reality is that when we've gone on and we've just looked at 500 hospitals recently, and we clicked and timed the amount of time it took for 3 technologists and consumers to shop for prices online. And it's average of 5 clicks to try to get to a pricing site, and then usually 10 to even 20 minutes to try to find the actual file and decipher the information. So hospitals could put this right up front on their homepage, make it very easy that we can now shop for healthcare. And just like the airline, Stanley, when it first became deregulated, and I'm old enough to remember, we had to go to individual airlines to shop for their flights. And then we had to compare going to each individual airline. And then these tools like Orbitz came out and revolutionized it to shop across globally, the airline system. This is a step-by-step process. We're asking expeditiously now for hospitals to get it there. And quite frankly, administratively, it's really pencil dust, because so many hospitals, even during this time of great merger and the bailouts of billions of dollars, were doing pro formas and getting all of these numbers for many of the mergers and acquisitions that were going on in these past 2 years. So we know it can be done, and now we look to you to have it done and will be done.
Yeah, no question that it can be done. I think there's certainly a question of the requirements, the standards, and the priorities for something like this. There's certainly a lot of things that hospitals are required to do. We read the Federal Register on a periodic basis, and the rules keep coming out and coming out and coming out. Terry, from the hospital standpoint, how do you feel that we should be educating consumers and patients and helping them with all of this price transparency information?
I think that's probably the reason, the machine readable formats and how to use that stuff, that really is, those are not very useful for an individual patient. I think that comes down to where there's app developers who need to figure out how to use that. I think that's why so many hospitals have utilized the provision of the law to develop the out-of-pocket cost estimator as to how you present this to their patients, because it is an easier platform to interact with. And one thing Cynthia's right about, yeah, you can inform patients that they have the ability to obtain this information. But in terms of how to use the machine readable formats, I mean, I think it's a good question. And it's not, I think hospitals they're struggling to figure out exactly how those are going to look. And so if one doesn't look like another, and that gets back to the standardization, if one doesn't look like another, it's really hard for a patient to get a true picture as to what the cost is. And so I think there's work to be done in terms of standardizing, streamlining what is coming out and figuring out, this is what is expected. These are how, this is how you develop that information. And until that's done, it is going to be difficult, because you can draw the patient to, here's how you can obtain it, but it's difficult to decipher unless, again, I think this is why a lot of hospitals have utilized the provision of the law that recognize that out-of-pocket cost estimators are good, can satisfactorily meet the need to, make it patient-focused, friendly website, whatever the specific provisional name is. But yeah.
Sure.
Well, we
Yeah,
still
and
feel
we
as
have-
patient rights, Stanley, we still believe very firmly that the price estimator tools are heavily burdensome. They're actually collecting a lot of personal identifiable extreme amount of data from the patients themselves. And if you don't put it in, you can't even get the estimate if you're just trying to shop. So if you're just trying to shop from out of state or anywhere else, just searching, it's obfuscated. And then many of those tools, just after spending 10, 15 minutes entering all of your information, it says, please call your provider or please call your plan to find out your estimate. I mean, it's absolutely ridiculous. And what we would say is we actually need the actual straight up prices from any tools, and the complete price, not an estimate, the all-in complete price. Otherwise, this is just another form of obfuscation and delay of game of delivering real and true price transparency to the marketplace.
And I will say that,
I disagree with that idea, but that's fine.
well, I will say that it certainly took the banking industry quite a while to standardize the ATM network and their websites. It took the airline industry. Cynthia, I don't know how old you are, but you said you remember way back in the beginning. So it's been a number of years for the airline industry. I think what we're doing here in healthcare is hopefully taking the first steps to that ultimate goal, that vision that you laid out, Cynthia. And unfortunately, we're going to need some patience, not the people patients, but the patients to get there step by step as we move through innovation and all of these additional acts that to get us to where we really want to be. So,
Actually, we interviewed so many tech people on this, and we also interviewed a lot of private equity folks that looked at acquisitions, and we found that these insured rates are looked at all the time and assimilated and parsed in order to know what price to pay for another hospital, because they have to optimize and look at where there's revenue stream coming in. Well, this is actually so doable, and we can do it by not killing by delay. We can actually expeditiously do it. And for all of the parsers that we've spoken to and all of the tech folks, they said all the hospitals have to do is post in a simple standard file and comply, and it will be a matter of months. We're not talking years, we're talking months to be able to deploy mobile apps.
Got it. Okay.
I think those tech people should get more familiar with the internal workings as to how this works. That's great, but that's fine. I think everyone knows this is a very complex area, and I think to paint all hospitals this is nefarious actors is incorrect. They're trying to become compliant.
20% have complied, and 80% have, 13% are doing nothing of those, and then the rest are putting up partials. So we applaud the first step, and we look for the rest of the year to see more come on board. Thank you.
We're making progress, and I remember in the initial days of the HIPAA administrative simplification, we did have a single date that everyone was supposed to be exchanging standard transactions. And it took a while for the industry to ramp up for any number of factors. And I think the timing of these requirements and the interference with other priorities and sort of the glide path for getting to where we need to be is an important consideration. Certainly there's a regulatory date, but whether that's reasonable or not reasonable is something that we all have to deal with. I want to move on to some other questions.
I mean, come on, let's be real. I mean, this rule came out well before the pandemic. So hospitals had plenty of time, as did insurers, to comply with the rule well before the pandemic. And this is not a high hurdle. You know, this is so actually doable. So this has been and then hospitals fought in the courts to keep patients in the dark. And I have to say,
no. We don't. I don't want to get into
about that today.
I don't want to get into the lawsuit. The lawsuit is settled.
Yes.
The lawsuit is settled. Where I really want to move on because there are quite a number of questions here.
Well, to do no harm, right? If the Hippocratic oath is to do no harm.
Understood.
Everyone has a story, Stanley. Everyone has their own story of either being overcharged themselves or a family member or friend. And so the only way we can get at true and real pricing and what is a fair price for that consumer, because otherwise they are totally disadvantaged, is to honor the Hippocratic oath to do no harm of not only their physical and mental health, but their financial health. And that is through enabling, timely, and empowering that consumer, being fully formed with straight up upfront prices.
And that's where everybody hopefully is going. Just move on. I want to take some other questions. There was a question about the impact of physician group practices, hospital and non-hospital based. Terry, is that, do you think that this has an impact on the physician group practices, or is that some of the other requirements that we'll be dealing with later?
I'm sorry, Stanley, can you repeat the question? I was trying to read one of the questions in the chat right as you were reading.
Sure. The impact of physician group practices, both that are hospital and non-hospital based.
I mean, I think that comes down to the definition. I'm trying to pull the specific definition. This rule is specific to hospitals, and so.
Okay.
But yeah, this rule is specific to hospitals. I think the No Surprises Act, which we'll talk about later, is broader in terms it does get to all providers who would be involved in care. But I do think that that's an example of where. But I'll just leave it at that. I think we'll get more to it later because I know we're running short on time. I want to make sure we get a chance to get everyone's questions.
No problem. Yeah, there was a question about, for emergency room services, what's the best way to check in advance the rates for emergency rooms? You certainly don't want to do that when you're in the midst of an emergency. So it's just, is there any suggestion for patients to handle those types of situations?
Harry?
I mean, I don't think, no one's going to go and say, I think I'm going to have a ruptured appendix next week. Let me look and see what it's going to cost, right? So there's not a way of necessarily shopping. This is specific to shoppable services. And, when you're going to the ER, it's best, if you have a true emergency, trying to shop at that point is probably not your best interest. So I don't know how this benefits patients in terms of prospectively looking up what emergency room costs would be, but Cynthia might have a better answer than that. I'm not sure.
Yes, thank you. You raise a great question, and over 90% of care is planned care or non-emergent care, right? And so when most of your healthcare can be priced and planned in advance, that's a huge win for the consumers. It also, having these prices gives us reference-based pricing on what are fair prices and appropriate prices from emergency rooms. But think about what price transparency is going to do. When patients and their employers and workers shop, they want to know the differences in quality. They want to know the differences in care services. And also importantly, patients want to know, what is the standard of care? What is the standard of care for treating strep throat? And what would a strep test standard of care cost on a reference-based price? So when we can see all of these different prices and we can see from claims data how strep throat is treated, then we can see comparatively how that should be ranked. But also from an emergency room, whether it's a trauma center or an urgent care or an emergency center, if it is not a trauma, patients could avoid being overcharged based upon a trauma center price coded incorrectly by knowing what the standard would be for just showing up to get low back pain MRI taken care of. And actually stay out of the ER because they'd be better to go to an ambulatory standalone center than fill that emergency room and get it likely at a much lower price. So we can see emergency care also change and shift because it will be a great information when patients have real access to all of this information combined with their health data. And if you really think about it and get up 30,000 feet, you have to wonder why we're narrowed into narrow networks as if we live in little homes and little villages and don't live in a transient society where our mobile phones and our mobile devices and our care and coverage should be able to be gotten at a fair price everywhere and anywhere, broad access to everyone in this country. So there's a new model out there, and we encourage the insurance industry too to look at this revolution for where they can play a much different role than the paternalistic role that has dominated and obfuscated through keeping patients in the dark. So now patients will be in control of not only their health decisions, but their wealth decisions to lower the cost of care.
So price transparency has an impact well beyond just shopping for the different hospital. Interesting.
Absolutely. Absolutely.
Another question, perhaps for Terry. One of the listeners is interested in understanding what drives price variation from your hospital perspective. Is it primarily your contracts with payers and how they vary from payer to payer and hospital to hospital?
I think the specifics as to how is the question how are hospitals able to arrive at their prices versus someone else who might. Yeah, I mean, I think a lot of it has to do with your contracts rates, which again, I think a hospital contract, you have to look kind of at the totality of the contract and just how they price things in terms of how to meet the needs of meet all of their care needs. But in terms of what are the differences? Yeah, a lot of it has to do with the health insurer. A lot of it has to do with the level of service in terms of, she talked about a trauma surgery center and some various the settings. But yeah, I think in terms of how prices, I mean, it's the internal, as I'm sure a lot of people on this call know, determining the contract status of the contracted rate is a long and arduous process. And I can say I'm thankful that I'm not in the room with the attorneys sitting there and the regulators developing how things are met. But I do think a lot of it has to do with the insurance and discrepancies and the need to arrive at those costs.
Excellent. I'm just going to pick out a couple of questions. We are getting towards the end. It's been a great discussion. If obtaining price for surgery, a hospital will be able to provide their prices, but what about the physician costs who did the service? They will have the surgery that was performed as well as follow-up visits. Terry, this is the hospital price transparency rule is only for the hospital costs, correct?
Well, that's where there's the kind of apples to oranges. If they're an employed physician of the hospital, their cost is included. If they're using a non-employed physician, someone who has privileges, you have a different cost. You're not going to include it. So I think that's where you don't have. There needs to be a little. I think that's where some regulatory guidance would be helpful because, there certain hospitals might have, for example, surgery. I think is an example. You might employ the surgeons. Others might not employ the particular surgeon who's providing the care. And obviously, the professional cost is going to have a significant difference in what it costs. So you're right. The cost of the surgeon is included. I think the regulation is if the surgeon is an employee of the hospital, they're supposed to include it. But if they're not, you obviously wouldn't be able to. You don't have information as to the particular provider's rates. That's the particular provider who has been chosen to provide that surgery.
So
I would
I'm
say,
sorry, go ahead, Cynthia.
Terry, I would say that hospitals, any other business, if they contract consultants, like look at Uber. I mean, Uber hired consultants or drivers that were on contract, and they were able to easily digitally price alternatives for consumers to go to an Uber or a Lyft based on contracted employees. There is absolutely no reason other than obfuscation to not include the contracted employees to the hospital as part of the total complete upfront price for that hospital.
But that's not part of this law. I mean, I think you can pie in the sky envision, but I'm telling you that there's nothing that says that someone with privileges at a hospital has to tell the hospital, this is how I do my charges, in terms of that's not part of what this law is, and that's not how this works. Everyone's going to bill their, the provider bills their own thing, and I'm not sure that this law does not get at it. You might have visions as to what could be done, but this law doesn't get at it.
You don't need the law, Terry. You don't need the law. You need to do the right thing.
All right, well, that's great, but I'm just telling you,
completely
that's not
bundle
what
the
we're talking about
price
here.
by anybody service that comes to your hospital. You don't need the law to do the right thing.
I think you're oversimplifying this.
And I think that's where some of the No Surprises Act items come in, by requiring providers to gather all of the services that are involved in a service. But that's, I think we pointed out perhaps an issue with hospital price transparency, in that it's not apples to apples at every hospital. And how do we make sure that patients understand those differences between hospitals that employ people and hospitals that don't employ people? I think under the No Surprises Act, as we understand it, that probably will come out a little bit, but certainly under hospital price transparency, which everyone agrees is a noble goal, I think there's still some questions that need to be raised about how do you make those comparisons. So I'm just going to try.
Stanley, I love your analogy, Stanley. I want to give you credit for that, because price transparency, let's admit it, it has upset the apple cart. And now the consumer actually is picking that cart up as a shopping cart. And the only way to compare apples to apples is to have this complete information. And it will be those hospitals and those ambulatory surgical centers and every independent doctor that's out there providing services that posts their prices up front, provides financial certainty in completion. And so those winners will be those that actually manage their cost efficiently, cut out all the many layers of middle players that are unnecessary, and allow apple to apple comparisons of those knee replacements, of those MRIs, of their care, and also allow for anybody who's contracted to be part of that total complete price packaging. And that competition will actually benefit the hospital, because they will earn the trust through their reputation, and they will have repeat business from customers and consumers that will know before they go.
That's an ideal, and I certainly hope we get there.
You don't need the law. You don't need the law to do the right thing. And quite frankly, surprise billing adds a whole layer of arbiters and lawyers and backroom deals that only add to the cost, maximizing yet again, capitalizing on that patient's misfortune. So if everybody just does the right thing and creates a functional competitive marketplace through transparency, we all win as a consumer and as a country.
Great. Okay, well, I'm going to wrap it up now. I want to thank our panelists, Terry and Cynthia. A spirited discussion, wonderful questions. And I think what we'll try and do is, if we can record those questions, have a record of them, the ones that we didn't get to answer, and handle them either later in the day or perhaps in some follow-up emails to the participants. Thank you very much. Michael, I'll turn it back to you.
I'm happy to take it, Michael. And yes, that was a wonderful, and again, as Stanley said, a spirited start to our program. Many thanks to Terry, Cynthia, and Stanley for kicking us off with such an interesting debate. It's time to move on to the health plan side of the discussion. And I'm pleased to introduce Eileen Lee, who will act as our moderator for this session. Eileen, take it away.
Hi, Robert. Ann, can you hear me? It's Ann Phelps. If it's helpful, I can
Great.
jump in.
Thank you, Ann.
I know I was having a little trouble. And I was wondering if Michael could actually show my slides for me. And because I'm having a little internet trouble.
Sure. Yeah. Hey, Anne, I'm sorry about that, you guys. I wasn't able to unmute myself. So
Oh, there you go.
just,
Okay.
I'm here now. This
Welcome.
is Eileen. I'm going to get myself set up, but Anne's going to jump in and give us a level set on the health plan impacts of transparency and coverage.
And this is Michael. Give me a second. I'll pull your slides up.
Thank you so much. I'm sorry for the technical difficulties. There we go. And I will just quickly, for everyone, I was listening. I heard the tail end of that lively discussion. So I'll just do a brief introduction. Good morning, everybody. My name is Ann Phelps, and I'm a partner based at Deloitte, based in Washington, D.C. Been in Washington, D.C. for 32 years in healthcare. So I'm really excited to be here today with you all and with Weedy, and really appreciate being invited. I serve as our U.S. healthcare policy leader at Deloitte, and so have watched many of these issues working with Weedy over the years in Washington on these issues around electronic exchange of information, including price transparency. So if we can go to my first slide, I just have some. The Weedy team asked me maybe just to provide some perspective as a regulatory leader around these issues, which is, so my slides, I'm going to just provide a little bit of overview and context, and then we're going to jump in with Eileen on some of the specifics and Stephen on some of the impact to consumers. So this slide I have for you here, and these slides will be made available to you for anyone that would like them. One of the things, sort of our point of view at Deloitte, and I think it's also in talking with my colleagues at Weedy, that we really look at these rules all together. You really have to look at, we clearly just had a lively discussion around transparency for hospitals. We're now moving to transparency and coverage for payers and employers, and that's important. Several different hats. Sometimes if you think of a hospital or a health plan, you have to respond as a hospital, as well as sometimes a plan, as well as an employer. So it's important to look at these rules in conjunction, as we see what the hospitals did in 2021 and what the plans and employers are going to do as we barrel towards January of 2022. There are specific provisions also for Medicare Advantage in transparency and prescription drug programs coming online in 22. And then, of course, we have the No Surprises Act, which is an additional layer, additional law, or some might think complication based on what I heard from the previous discussion. All of these rules and new laws are going live on 1/1/22. Now, we don't have the final rules or the interim rules on the No Surprises Act. They're pending at the White House, so we expect them to pop out any day, likely before July 1. And then it's going to be a quick, 6 months to get to January of 2022. So again, what I have on here is what I call the cheat sheet page of the due dates, to whom these rules and laws apply, a wide spectrum of our stakeholders listening today, plans and providers. And then what are some of the key requirements? So in our session right now, we're going to focus on that second column, which is transparency and coverage for payers and employers. The machine readable files that they have to comply with. There are 3 machine readable files, and Eileen is going to go into those in a little more detail for us, in and out of network, as well as a prescription drug file, which is new. And also the out-of-pocket cost estimator, the shoppable tools that plans and employers must provide. Similar to, but I'm going to say more expansive than what some of the hospitals have had to do. So this is sort of our overview slide. Okay, let's go to the next slide, please, Michael. Thank you. So then another sort of context setting slide that I have for you here is to show you that these rules, build over time and they expand over time. So hospitals clearly came online in 2021. We're moving towards the 2022 deadlines that I just explained, but they continue to expand in 23 and 24 to the online cost tools. More services have to be provided and shown and become transparent over time, eventually showing all covered items and services as we move to 2024. The other point that I kind of like to make on this slide is a general sort of context setting when I think about these rules is they're very dynamic. They're not static. They're not like a, ICD-10 where, you put it in place and then you're sort of set to go. In my mind, just getting to the compliance or the readiness by 2021 or now 2022 is sort of the first step. But these things, they are ongoing, particularly for plans and employers. You have to keep them updated, sometimes in a real-time basis or monthly basis. You want to be watching and sensing what the market is doing. Because what I was hearing a little bit in the discussion before is it's not just about building that tool and putting it up there. You want to watch the market to see what other plans or providers are doing. You may be, you want to, show your patients or your consumers or your members, hey, this month, in the online tool, we may waive a copay or a cost sharing requirement if you go to this provider in network or out of network. These are dynamic tools that need to be built, and you really have to understand what's going on in the market and watch the data, because a lot of this data will be made public. So other vendors might be watching it as well and sort of, targeting or steering customers and members or patients to go to a low cost or high quality provider. So again, this is over time and it's a dynamic process. Okay, let's go to the next slide. Okay, so this slide, if we put, our point of view at Deloitte is not only do you have to build the tools, so the machine readable files or the shoppable tools, but we really look at this holistically. And in talking with our colleagues at WEDI, I think we were sort of aligned in this, is that when you look at all of the new data that will be made available, some public and some not public. So some of it will just be available to you as a plan or provider, but some of it will be made public. And if you look at the rich set of data in all of these rules with interoperability, the rules, sort of against information blocking, as well as price transparency for hospitals, for payers, if you see on the left side of my column here, as well as the No Surprises Act, really as a whole, comprehensively, we're really encouraging our plans and our providers to look at the data set as a whole, the richness of the data, as you build your tools and as you think about your strategies, whether that's interacting between plans and providers or interacting with your patients, customers, or members. Because all of this data is going to allow you hopefully to coordinate care in new ways, as well as work with patients. Again, I'm going to kind of toggle back and forth between patient, member, or employee because it depends on the context that we're talking about here. But there's a richness of data that internally you can analyze, as well as candidly outside vendors will be as well. I always say on this slide, think of it as the new Hexpedia, healthcare.com, or think of your favorite website. There will be vendors that can pull down the provider directories, the quality scores, who's available, at what cost to help patients. But that is also something that you want to get ahead of as an organization or think about in terms of how others might be looking at the data that is now made public. Okay, so we'll go to my next slide here. I think I just have I think this is my last slide sort of in context. And then I want to turn it back to Eileen and bring Stephen into the conversation as well. What this slide really shows you here as we look at price transparency for hospitals, coverage for payers, and the No Surprises Act. The main point I want to make on this slide, and this is one of my favorite cheat sheets, is not only to think about that direct compliance obligation, but also where the implication is for data. So for example, if you look at my columns, the check marks are the direct compliance obligations. So we know that, a health plan, a self-insured employer, or a hospital, has the direct compliance obligation. But it's important also to look at those red buckets in terms of where there's an implication for data. So one of the things you'll hear Eileen talk about, for example, is the machine readable files. A plan or a self-funded employer has to put out pharmacy data. So the pharmacist and the pharmacy or the PBM is not on the hook to share the data. They don't have the direct compliance obligation, but information about them is going to be shared down to the pharmacy level or potentially that retail location. So there is an implication for data for them to think about. Same thing for physician practices or ambulatory care or virtual care. So while they don't have the compliance obligation, all stakeholders need to pay attention because data about them may be shared. And it's important for us to understand that both whether you're the actual one complying or whether you're part of the healthcare system and you're seeing how, plans and providers are sharing information about you. So in your partnerships or as you look at vendors and new tools that are coming online, you want to be aware of how the market is changing. So I want to just take a quick pause and see here if, Eileen, bring you into the conversation here, as well as Stephen, or if there are any questions, I want to pause for a moment and open up here about some of the context setting that, I've gone through and see if anyone would like to come in or join the conversation. And hi, Eileen, I can see you now and hear you.
We're so good with technology.
Yes, I'm embarrassed to say, Deloitte is a technology firm, but that I'm a healthcare policy geek, so it doesn't apply to me. I'm not good at technology.
Problem. Well, that was an incredible level set on the sort of your expertise around compliance and the law. I think now we're going to move into talking about the specific areas related, the sort of buckets associated with transparency and coverage for health plans. We're going to talk about each one of them one by one, and then we're going to kind of open up at the end to talk about where each of us, Steve, Ann, and myself, see the industry going. We got a really great set of perspectives here because Ann's given you her background. And she is a compliance and legislative leader. And I am the head of product at a healthcare technology company and who services both health plans and providers and payers, and a lot of experience in the TPA world. And Steve is going to give, he'll probably give a little bit of a background on himself too, but I know that he is also here to represent both the patient and provider perspective. So that's a really great panel we've got. So I'm going to go ahead and share my screen and bring up just some slides that give us some framing. So we're going to start first by talking about the in-network machine readable files. This is something that's near and dear to my heart. But basically, overview, I think everybody's got this by now, is that, they're going to be these files. They've got to be publicly available. They require the data fields that are listed here, and they also require applicable rates. One really important fact that we kind of stumbled on is this concept that these files have to be a catalog of current rates as of today. I mean, just like every other healthcare technology firm that has claims data, our first thought was that we could just back into these files. And I know that that is how a lot of estimations are done today in the transparency and the estimation world. However, in the way that the law is written, it's going to be required that we be able to provide a catalog of the rates as they are sitting today. I know that both Ann and Steve probably have comments on this, but just one little perspective we have about that, which is servicing TPAs, we found that there's a lot of complexity around trying to get those files available. So just like Ann was talking about how PBMs are not held to the law, so the national lease networks, patch networks, other directories that are often used by TPAs and self-insured plans are also not held to the law. And at first we were really worried that we wouldn't be receiving data from them to be able to bring it together and make a picture for a particular health plan or payer. But we read the gag clause in the Consolidated Appropriations Act as a leverage to ensure that those organizations will also play ball, and that they're going to be producing their data. And that's kind of what we're hearing in the marketplace, that that data is going to be available and that a particular payer will be able to collect it and use it to meet the law. And Steve, do you guys have any comments on the in-network machine readable files?
I would just add, Eileen, that, I'm sure for many of the listeners today, you're right on point here about how complicated this is. It's not like there's one plan and one network and one file. And, and I always, it's a very complicated, this machine readable file is not an easy thing to build. And you're right, it's not like just turning on the switch and we have all this data and it's easy to upload. So, I think this is a challenge, very much so for many of our health plans in particular. And as I saw a little bit with the hospitals and some of the comments, the one good thing is the machine readable file for the plan is more standard than I think it is for the hospital. And I think the hospitals really want more of a standardization of those files. My guess is over time, we will see some of this hopefully smooth out a little bit, but I don't know it's not an easy one and done thing, right? And I think many plans are really starting to understand that now, as well as the providers.
And first, I just want to thank Weedy for allowing for this great day and great panel, and appreciative of having Arthritis Foundation on multiple panels. Our VP will be on a panel later today, so I appreciate that. And then for all you jumping on and staying on during, I know, a busy morning in the health policy world, and spending your time with us. So very much appreciated. But I think I think each of these kind of machine readable file areas, and as they are publicly available, I think it's that striking that balance. I think each of you have kind of said that it is something that could be very complex, I would assume, especially for patients and chronic disease patients who we represent as they're kind of maneuvering and analyzing this and going through their care. I am often more give a lot of credit to the patients that we work with. I've seen them kind of deal with and almost become kind of master's level education in navigating the healthcare system because of what they have to do and go through each day with managing their care and navigating all of the different parties within the healthcare system. So I think I give them a lot of credit as far as being able to, if there is as easy to use system on these files as possible, I think that makes it much more easier for them. But knowing that this is something that they're having to become experts on each day is definitely something that I'll stress.
Yeah, one of the things. Oh, go ahead, Eileen.
Well, I was just going to say, we received a question over the chat about where the standards are that we're referring to. So there's actually, believe it or not, there's a GitHub site where these standard file formats are being published. They're still obviously in draft form, but if anybody's interested in that, you can always ping me and I'll send you a link. But they are coming out with standard formats for these files, which is a great, makes the whole process more likely to be successful than possibly the hospital reporting has been. Go ahead, Anne.
Well, one thing I sort of forgot to say, and I'd be interested in both your reaction, Eileen and Steve, is that one context level setting point I forgot to make in the beginning is just, I sort of think of the machine readable files as what I think of as the B2B play, the business to business. And there's been a lot of press around the machine readable files and the negotiated rates between plans and providers, right? And that's what a lot of the press is zeroing in on in the media, which is, what is that negotiated rate, right? Those machine readable files. And I think over time, hopefully, clearly that's going to be part of a negotiation. There's a lot of plans and providers on both sides that are like, wait, how come it's this price here and this price here, and it doesn't tell my true story? You can't just, it's not really an apples to apples. And or it's really having, I think, plans and providers come together more to tell their value story as well as what the rate is. But that's where a lot of the attention is. And one of the things I did want to say is I really think the shoppable tools and the comparison tools are really more about what I'll call the B2C, the business to consumer, what the consumer and the member or the employee or the patient, that's really where they are going to be more focused, which is as an individual, what's my out-of-pocket cost? Or that's what the surprise billing is what do I pay? And how do I find the provider and at what cost? And so, I think it's helpful if we kind of separate out what is those machine readable files from what the consumer is really going to look at, because they aren't really going to care as much, I don't think, about the negotiated rates. They really want to know what's my out-of-pocket spend or if I go here or there. I mean, I'd be interested in your reaction, because I think the media has really just focused in on these negotiated rates.
Well, I think we're finding that they're critical to being able to do the AEOBs and the price comparison tools. Like, price comparison tools exist in the marketplace today. I mean, there's tons of companies using them. They have some challenges around patient engagement because their estimations are primarily based, well, it depends on case by case basis, but many of them are dependent upon historical claims data. We need to know what the contract rates are in order to do an adequate estimation. So this is a critical first step for providing the cost transparency tool and also the AEOB. So, I mean, we do need to make sure that we can get this part done first.
I think transparency is kind of power, especially for the patient or consumer, as far as just having that information. I hear what you're saying, and as far as kind of the price comparison tool or the AEOB being more of the kind of focused on more of the outward facing to the patient and what may kind of be the first thing that they're going to grab onto if they're kind of really trying to determine their care and talk with their healthcare provider, and that might be the tool that they're using in that conversation with their healthcare provider and determining kind of what the next steps are. But I think there are going to be some patients that are kind of interested in diving in and kind of getting a whole picture. So I think this is part of it, but I think that is well said.
Hey, so Anne and Stephen, I was wondering kind of what you would think about this comment. So I've been talking to a lot of people about this data, and a lot of the times I'll make a brush off comment like, oh, all the in-network Mrfs going to be available, so everybody's going to be the same. But this particular organization was telling me that it's non-trivial. Like, the idea of collecting and cleansing and combining and communicating all this data is a non-trivial function, and that not everybody's going to do it as well. What do you think about that?
Well, I agree. Like, even just making sure, and I know it's like, I always call it like good housekeeping, right? You would think that you have, like, when I look at what is the associated rate down to NPI and TIN and place of service code, well, that's not always, I mean, providers change, right? Like, it's not always as easy or straightforward as one might think and I know this has been, getting these and this is just one of them, right? It's in and out of network, right? I know we have 3 files for the health plans here. Or payers, I should say. And it's not always that simple. And we spent a lot of time, after MACRA and looking at coordinated care arrangements and ACOs and just trying to make sure you assign all the TINs and MPIs to a certain coordinated care model or a certain network. As you say, Eileen, it's not always completely straightforward. It's supposed to be good housekeeping. I mean, we all know, my house is not clean right now. We all know there's a lot of dust. So it just, this is a challenge for even things that you think would be not a big deal. It's going to require some real elbow grease, I'll just say, to get all this in place. And I've had a number of folks ask me, Eileen, if I thought that the administration would delay any of these, like, would they delay this rule or would they delay anything on no surprises? And I will say, I don't really expect delays, but I could see them giving indication of where, like I said, I'll call it, they're going to smooth out. They know their glitches, where there will be some good faith, maybe a little leeway on enforcement. We could see that. But at the same time, I did just see, CMS is really starting to enforce the hospital transparency rules for the many hospitals that did not comply. And
Okay.
our clients are calling us with the no compliance letters saying, what do I have to do, to get out of the penalty box with CMS. So
Wow.
we have to really keep moving, even though I think you correctly state that this is a challenge. These are non-trivial, these are big issues.
And I will say that most of my experience comes from,
Sorry.
oh, sorry, please.
I was just saying you want to close this out on this slide, so we can move on to the next one. Go ahead.
I was just going to say quickly that I think most of my experience comes from working in the States and doing most of those types of lobbying. But I think that kind of maybe serves as, I often say, maybe it's my bias in that versus federal, is that dynamic of seeing a number of states implement a number of different other transparency pieces, from kind of formulary transparency to provider directories on their own, and different things like that. So there are, I think, a lot of plans and payers that have experience with doing this type of transparency, or different variety of different stakeholders in the process of doing that. So that serves as kind of a possible innovator as far as kind of lessons learned and processes theirs that can transfer over to this and kind of see. So, and that just kind of shows that there have been some hiccups there as well in the states that have tried to do something. So I would not surprise me if there's hiccups here as well.
All right, so let's move on to the out-of-network. So again, like payers and health plans are going to be required to produce out-of-network machine readable files. These files, though, from our reading of the law, can be based on historical claims data. They do have the 3-month rule, so it's 3 months back, 3 months covered. And there's some requirements around how many claims you need to have for that particular provider, for that particular service, in that for that particular plan, for it you to be needing to produce an out-of-network reporting for that specific service and provider and plan. And so for many TPAs, we're finding that these out-of-network files are going to be pretty slim, especially if they're regional or localized. However, this could be a greater data exercise for other plans who are trying to pull together a lot of data. One thing I did want to say, because I get this question all the time, I don't know if you guys get this question too, but the TIC and NSA rules do apply to ERISA plans as well. So that's the reason why I'm discussing TPAs and self-insured plans. It's something that some people don't realize, and that I don't want people to end up in a place where they are not complying with the law because they think it doesn't apply to them. But these rules do specifically still apply to ERISA plans.
Yeah,
I mean,
I think that's just to put a little, exclamation point on that. I am still sort of getting calls, and when we talk with some of our clients, so if you think about this, if you're, pick up any of your favorite plans, one that begins with an A or a B or a U, if you pick a plan, they have to do this both as a health plan and as an employer. So that it's like, so if you're listening today with your plan ears, or if you're listening today with your hospital ears, if you as a hospital are a self-insured employer, you also have to do this for your employees. So that's why I think I just want to really, I think everyone's aware. I'd love it if folks comment in the chat. This is you're 100% on, which is you have to think about your double, triple hatting. So I hate to say this because the hospitals be like, oh my gosh, I had to stop talking, but you have to think about the No Surprises Act, this payer rule, if you're a self-insured employer, and complying as a hospital to hospital transparency. So, don't shoot the messenger, but that's why I think it was really critical, right? Eileen and Steve, we wanted to make sure that we highlighted that very clearly, because these are multiple issues that are going to be, we're barreling towards for January 2022. So 100%. And I'm talking with a lot of folks that has not really dawned on them the level of, or the number, how all these rules apply.
Yeah, we had a lot of questions from providers too. I don't know, Steve, if you have any view on this, but about will this change the way they get paid for out of network? And the reality is, from my direct reading of the law, no. I mean, it doesn't deal with how you're going to get paid for out of network at all. These are just data files. But the reality is that these are going to have great implications on how much people reimburse, how much the plan pays for out of network, and how much plans pay for in network, because eventually, that we will come to that space.
No, I think that that's accurate as far as the fact that it's not changing the payment structure, but information is powerful and could end up leading to just more information being out there and can be used. So no, that's a great point, and all around great points.
And Eileen, we've talked to a lot of providers that, I always kind of say it, healthcare, we're different in healthcare, right? We're always different. It isn't just a race to the bottom. It isn't just who has the lowest cost. And I mean, that's the whole idea, is to, of course, to lower costs and be transparent about the costs, but healthcare isn't analogous to, everything else we buy off the internet, right? And what we've talked to some providers who are typically an out-of-network provider, but what they're doing is saying, yes, we're more expensive, maybe in this case, but here's our value story and here's why. And it's not as simple as just, who is the lowest cost. Sometimes it is, but not always. Because I always joke about this. Sometimes you want to stay in the 5-star hotel, right? And you're going to pay more. So this is upending markets, but not just the race to the bottom. And I do want to make sure that that's clear. And particularly when we think about out-of-network providers, in some cases, a patient might say, I want to go in network because it's cheaper, but in other cases, they may want to go out of network for a particular reason. And so it doesn't always follow traditional sort of buying or market rules.
No, and I was going to say that especially when we get to the price comparison section, is that I think cost is not the only factor in determining the course of treatment. And kind of it's one thing within that conversation, especially as a patient has that and is looking at the cost, or if they're kind of getting referred or to their a different specialty care with their healthcare provider, and talking with their doctor about kind of, well, here are the options, and laying all of that out. It's good to have that cost information, but it's good, I think you said it well, and as far as having the entire story and having a picture painted and having just a number of different transparency laid out for the patient, so that they can make what may make the best decision for them. And so, yeah, I think this is probably a discussion that's even more important in that kind of price comparison tool section too. But I think you're right as far as kind of in the out-of-network space, if it is something where having a complete picture when they're looking at the different options is always important.
Interesting. So moving on to the last of our machine readable files, which is prescription drug pricing Mrfs. I don't know if you guys are getting the same feedback, but I'm hearing that a lot of this data is going to have to come from the PBMs. And again, like you said earlier, Anne, you hit the nail on the head. These guys aren't held to the law. So it's going to be important that, we have all of the tools and leverage we need in order to ensure that we are obtaining the data that we need. We found that it's been useful in our conversations with some of the carriers and some of the PBMs we're talking to, that we, talk about the fact that, the gag clause removal will mean that we can back into this stuff and publish that data anyway. It's going to happen. So the best thing is for us to coordinate and ensure that you're sending the data directly to the payer so that they can use it to meet their compliance and that it's being used in the right way. And you can ensure that your data is accurate. And that's been a very successful strategy for us.
Mm-hmm. And Eileen, I have heard some rumblings that, maybe this would end up at some point becoming a PBM requirement. So not on the plan or the employer, but right now, this has been included, and it is the requirement as we've said, the direct requirement on the plan, or issuer. And so, and I think this one we really do need to focus on. I also think just what's going on around prescription drug prices in general. We all know some of the various debates going on in Washington. This is a tool that the administration now, they're going to have this information. Again, it's public. So I think we should spend as much time on this one as we do the others. And so I think this will have an impact on the PBMs. We've talked to a lot of life sciences companies now. Pharma, is now paying more attention to this as well. So this is sort of gets to that point, like we said, Eileen, about the broad impact on the healthcare community, outside of direct compliance.
And I think anyone that knows kind of the rheumatoid arthritis space that we know, that I think drug pricing, of course, extremely important for us. Prescription drugs have been life-changing. Biologics and the implementation of them have been life-changing for our population. And so this is definitely an important area for us. And I think the last panel said that, and Anne just said, as far as kind of this being a first step, that there's probably going to be, I would assume, more and more conversations, or as this gets implemented and we learn more throughout this process. I would assume that it just gives way to more opportunity just to go back and say, how can we tweak this or build upon it?
Yeah, definitely. This is incredibly valuable information. The reality is that we're finding that very few core admin systems for payers still store contract rates or prescription drug prices inside the payers' databases. So it's not like somebody just, we're going to just get one of our programmers to start collecting data and combining it. That's not a reality. This data has to come from the vendors that are doing the repricing. And, again, they weren't held to the law, but it's good to hear, Anne, that you're hearing rumblings that they may have some compliance obligations, which I think will be very useful. Some of the challenges we found around, say, for instance, the ACA and the standard transactions and getting adoption up on those, was that the practice management systems were not held to the law. So they were not mandated to support standard transactions. They did it when they needed to, but that didn't create a lot of acceleration. So we need to make sure that everything's done to encourage the usage. All right, so moving on to perhaps the more exciting stuff. I'm going to skip AEOB and actually come back to it, because we're not technically covering AEOB in this, but I don't think there's any way to cover price transparency tool without AEOB, and I'll show why in just a second. So we're going to talk a little bit about the price cost sharing tool. So this, and correct me if I get any of this wrong, Anne, because I know this is your area of expertise, but so
keep going.
The cost sharing tool came out of the Transparency and Coverage Act, which already has final rules published. So 2023, everybody's going to need to comply with this. This is a way for people to shop between services. It needs to be based on real information. The estimations can't be really wide guesstimates like they have been in the past. They need to be based on that specific member and that specific provider, and members have to have the ability to search. We did an analysis of the difference between the price comparison tool, what you need to build that, and what you need to build the AEOBs. And the orchestration layer is not that much different. I mean, the requirements are similar, have differences. Like for the AEOB, it has to start from a provider's request for billed charges, and there has to be the ability to print something, and should be in kind of an EOB format. And the price comparison tool is a little different, but you still need the same things. You still need to know if the provider's in or out of network. You need to know what their contract rates are. You've got to have an estimate for out of network. You need to know their eligibility for that particular member, and know if they are eligible. And if they are, be able to calculate their cost sharing. So knowing accumulators and maximums and their progress to maximums. Same things are going to be needed for the AEOBs. So that's the reason why I consider them similar. However, there are tools out there in the marketplace today that are doing this cost and price sharing. But from my reading of the final rule that was published in November for TIC is that those estimates, the way they stand today, don't meet reasonable estimations under the law. And they're going to have to get better, which is where the whole in-network Mrfs and out-of-network Mrfs come into play. What are your thoughts on that, guys?
Yeah, so this is where we start to get into overlap, right? We have, we have within the transparency and, for payers and coverage, we have the building of the shoppable tool, right? And so we have the shoppable tool under transparency and coverage for payers. Then we have a comparison tool, right, under the No Surprises Act, which has some overlapping elements. And I think one of the hopes, is that a word? One of the hopes is that in some, that you could eventually, you would combine those tools. You wouldn't have to have two different, a shopping tool and a comparison tool, that you could combine them. And then you also have to have the advanced explanation of benefits, which is a more of a static document, right? You have that, an EOB. Plans are used to doing, employers are used to doing EOBs, but now we have these sort of what I call those dynamic tools that they're going to have to keep updated. And I think that this is another area where plans and providers can work together to say, all right, what do we want to kind of have in that explanation of benefits kind of standard? And then how can we maybe combine tools so that we're not, having two or three. It gets very confusing, I think, for an employee or a patient or a consumer. So that's sort of what I'm looking for when the rules come out. One of the things when the rules come out on the No Surprises Act is, do they sort of, help us say, I would love to if they were to say, look, here's one tool, build it this way, but we'll see. Because I think you make a very good point that this is going to be a lot of communication, and it could be very, confusing to an employee or a patient. Steve, I would love, what do you think? And how many of us actually read our explanations of benefits? I mean,
Well, and that was what I was going to get at. I think sometimes with this, I often hear or maybe out there in the world as far as kind of, if you build this, will they come? If you build this, will the patients actually use it? And I think that comes into play as far as kind of, I think just about everyone on this call, from the payers, the providers, to the patients, if we work together to kind of really do some good education about how this can be valuable, and making sure that this is used as kind of a team effort, and like you said, coordinated care. And so I think that education part, I know that was hit on a little bit on that last panel, is how you properly do that, how you're incorporating healthcare provider and making sure that it's available. I've talked a little bit about kind of how we've been supportive of real-time benefit tools, and kind of that value in having that ability to have that conversation in the healthcare provider's office, and that just it means encouraging the healthcare providers to use these types of tools with their patients, and encouraging them and empowering them, so that the patient can then be empowered to use it on their own, and in making their decisions. And it goes back to what I had said previously as far as kind of ensuring that just not the cost information is supplemented with other information too, as far as kind of, if we're talking about the prescription drug space, that making sure that they know in real time if a prescription drug has prior authorization, has step therapy, Elaine mentioned accumulators, has all of that, so that they're not leaving that office and then all of a sudden they find out then about all these different changes or different things that weren't available with them to be able to talk with their healthcare provider, or they leave the phone in this day and age. So just making sure that we have that real time, that it's kind of part of a team, is kind of what I would say is the important factor, as far as the transparency is good, but it's about utilizing it in the right way.
I agree with that. Like, something I'm learning by talking to more and more organizations at all levels of the industry is that there's more levels to this than I thought. Like, originally when this was published, I was like, the data is going to be published. And for some reason I had in my mind that like a patient would be like downloading a file from the hospital. And that's not exactly how it's all going to work, right? There's going to be organizations who collect this data. There's going to be organizations that combine and cleanse this data. There's going to be organizations that create, communication hubs to support, giving this data. And there's going to be people who create what we call the glass, like what the member sees, the user interface aspect of it, and piecing together all of those orchestration layers in order to make sure that it gets the patient what they need in a usable format is going to be quite an undertaking.
I completely agree. And that's why, I always say, first and foremost, as a regulatory leader, I always say, compliance first, second and third. We have to get ready to comply and be ready. But I'm really encouraging, we are very encouraging of plans and providers to really think about those strategic implications that you just said, because Otherwise, others will do it. Others will tell your message or your story, or they're gonna, think can't say names, but we know they've been doing it for a while in prescription drugs, and we have where you can say, all right, if you go to this pharmacy, it's this. If you go to this pharmacy, it's this. There are going to be vendors, just like you say, Eileen, that are going to come out and start comparing and saying, Ann Phelps, go here, because this provider is really highly rated, and right now there's a sale. I mean, it's putting the retail aspect into healthcare and saying, look, you can go get it for this price. We have to think like that, and because that's what these rules over time, maybe not right away, but over time, I think are going to do. And look, we want to be able to, as plans and providers or the stakeholders, you want to be able to sort of be a part of that, and for your base, your customers or members. So I think it's a really good point, Eileen.
Okay, so I'm going to take a little bit of time and switch us back to the AEOB. I know this is not technically in our section since we're transparency and coverage for health plans, but there are some overlaps in the discussion that I think are interesting and worth talking about. So one thing that I wanted to say is that, a thought that keeps me up at night is the thought that this is a huge gift, right, from the government to health plans. It gives you the access to the real estate between when a patient schedules an appointment and when they attend that appointment. And I think it's something that all of our health plans and payers really need to be thinking about, right? There is the ability to use that to communicate messages on healthcare literacy, to help with appropriate steerage, show quality metrics, encourage patients to understand more about the care that they're receiving before they go. And that is something that I think a lot of health plans and payers are not thinking about right now, because they're more kind of focused on how do I get compliant with the law. But it's a bigger question and bigger discussion about how you can use that ability to communicate with your members between when they decide to seek care and when they go to care, to help them to save money, to get the highest quality care, and to provide them with the best plan benefits that you can.
Mm-hmm.
I think the biggest thing after that too is that not only kind of leading up to receiving that care, but even after they receive that care. And if there is kind of a situation where that advanced EOB doesn't match with kind of what the end cost was, kind of having that ability for the patient to say, hey, wait a minute, why is there a difference here? And I think that's kind of one of the biggest values that we see from that section that we've pointed and try to do some education to our patient population on is that the value in having that beforehand and it going through all the parties first and then getting to the patient and having that even afterwards.
Yeah, Eileen, we're getting a ton of questions around
I know,
this.
I'm trying to collect some of them. So I think it would be good if we asked them these questions and got our responses on them. So I've got one from Viet Wen. It says, who should in future discussions consider potential unintended consequences like additional burdens on providers and their staff to have both clinical and financial discussions with patients? How can we empower them to have these conversations? What are your thoughts on that?
Yeah, and I was going to say, we are also, this is one where I'm really curious to see how plans and providers will sort of work together on this, which is you could see it done in a couple of different ways, where when a patient schedules, and is it the kind of thing where it's a conversation that, or a transaction or communication that occurs in those 1 to 3 days, where the provider is sending it to a health plan, and it gives, like you just said, Eileen, it gives them an opportunity to communicate. And some folks have said to me, hey, Ann, is this more like a prior auth? Or is this more like, hey, we're just giving this advanced note. We're telling you what we're going to do, and you give the advanced notice to the member. Or is it something that is going to be sort of baked in, which is in general, plans and providers are going to look at all the things that are generally scheduled in advance and sort of have it all, on a chart, right? That says, okay, we've already communicated it. So how much is it going to be, we've got this on file? Or is it going to be this very kind of dynamic circle that occurs within the 3 days? And to your point, how much will this, become another friction or rub between plans and providers? Or is it a way that it maybe smooths some things out? Boy, I'm having trouble talking this morning. Smooth things out. I think this is I really would, be interested if our audience has any reactions to how they're thinking about both the operational side of this as well as, that point of communication between a plan and provider.
And I gave that example a little bit earlier, as far as kind of if the healthcare provider has some of these kind of transparent tools when they're talking with their patient, and are able to go through it with them as they're kind of talking about it, it may save time in the back end, where we know kind of I saw some friendly faces on here that I've worked with in the past on things that have helped healthcare providers on less burdensome processes, or making them a little bit more streamlined in some of these spaces, like prior authorization or step therapy. But hopefully kind of some of this transparency will help in that front end to make sure that they have everything, have all the information, have all the ability to choose kind of what course of treatment makes sense, kind of as they're talking with the patient right there in the office. And then they can kind of go, instead of maybe having the office staff and the healthcare provider doing that when they don't have the patient, have to call them back and try to get that information and then talk with the plan and then go back to the patient, but try to do that in kind of more of a real-time environment. And so hopefully the transparency would be able to assist that, and then assist with some of that burden that's on the healthcare provider currently.
Right.
I think it would almost move some of the burden back to the plan, right? Because the law requires that the plan is the person who is being held accountable for the communication to the patient of their estimation under the law. And in the past, because that was not required, in many cases, the hospital or the health system themselves or the practice had to create estimates off of what they had access to for that particular member's health plan and try and give the patient some information. But today, starting in January, there'll be a requirement for plans to communicate pre-estimates to their patients, which should help with the conversation some. We have another question, Anne, about vision, and this is perfect for you, I think. Is vision and dental included in these requirements?
Well, and I saw that question. I also want to say a word about a lot of questions about quality, but I have to, so eventually it will be, and I honestly can't, I can't remember right now if it's included up front, or eventually we're moving to all prices and services. And so I want to say yes, but I want to double check that. So for our I want to make sure if it's covered now or in the future. Like I said, we build on these things over time, 23 and 24, to eventually getting to all covered services and goods. So I might just want to come back on that one question. Maybe I can come back to it later on this afternoon for the person that asked the question. And I also wanted to talk, we're getting a lot of questions, Eileen, around quality. And so, and maybe this is a good, and maybe hopefully folks will keep asking us questions. Here's the way I've often thought about all of these rules. I used to say the trends with the regulators, Congress and the regulators, bipartisan. I used to say it was in moving towards coordinated care, it was like the 3 legs of a stool. And now I'm calling it the 4 legs of a chair. And if anyone can help me come up with a better analogy, but here is the 4 legs of the chair that the regulators are pushing us towards. One is they are encouraging plans and providers to share risk, meaning that both sides have to share in the risk, not just upside, but we know macro downside risk, right? You have to take on risk. That risk has to be tied to quality. So, and there's a whole, what we're not really getting to in this call today, but because there's so much to cover, is that it's tied to quality metrics. So you have to be a high quality and efficient provider. The third element is you have to be interoperable, right? And that's why we start with interoperability. You have to be able to communicate with each other, whether you're in and out of network, whether you follow the patient, and wherever that patient goes, you have to be able to communicate with each other. You can't hoard information. Even if you're not contracted with each other, you have to share information. And the fourth leg of the stool is you have to be price transparent. And you really need to look at all 4 to to do well in coordinated care arrangements, to get reimbursement from the government, to be interoperable, and to be price transparent. And so there is a rationale that Congress and the regulators have been moving toward that include all four of those trends: risk, quality, interoperability, and price transparency is their way of improving care and improving for patients and being transparent with patients. So that's kind of a really big picture and a very high level. We're not forgetting about quality. That's just that's all part of what we're talking about today. We're just focused on the transparency piece. So I'd be interested in your reactions as well. But those are all of the rules that I think need to be looked at from a strategy point of view for plans and providers. So I just want to make sure we weren't forgetting the quality side of it.
Yeah, absolutely. I mean, like, it's a question that comes up a lot for me too. I'm sure, Steve, you've got some feedback on that as well.
No, I appreciate you bringing it up, because I think looking at the chat, I think that is something that popped up, and it's a great question. I think we kind of hit on it a little bit earlier as far as kind of, yeah, if you're giving them transparency as far as cost, that's not telling the whole story. That's telling them kind of, and you're hoping that that's not the whole idea as far as a whole decision maker in determining what's the best course of treatment. So there needs to be that conversation and good patient and provider relationship that's going on as far as kind of being able to detail, here is the cost information that is more transparent than ever, but kind of here's the other factors to determine in care, and that education is crucial in the process. And so I think it is a fantastic point to be brought up, and as we have these tools, something that is important to keep in mind as we move forward.
Hey, Aline, my incredible colleague, Daniel, sent me the answer. So I'm going to do a little call out. Okay, accepted benefits are not subject to the transparency and coverage rules. So accepted benefits are not, grandfathered plans are not, and short-term limited duration insurance. So all of those accepted benefits not subject to this rule. So thank you to my colleague and for providing me with the technical answer. I appreciate it. And so hopefully that answers our question.
Can you define accepted benefits for us, just in case somebody is not aware of what that covers?
So there's a whole list of accepted benefits, what's kind of out in HIPAA. And actually, maybe that's another thing, Eileen, we could say, when I think about these rules, they're basically like under HIPAA or the ACA, where these are like insurance market reforms that amend, the Public Health Service Act, ERISA, the tax code. So if you think about all those ACA requirements, insurance market reforms, and this is another one. Accepted benefits are generally, the non-major medical, and there's a list of them, like vision and dental and those things that are outside of major medical. And so, we can provide a full list if anyone needs it, but they're things that are typically outside major medical coverage, and they're listed in the ACA and HIPAA.
Okay, one question, and then I'm going to take one more question, and then I think we kind of need to close out. And I'd like to give you both the opportunity to give kind of your projections for what you think is going to happen in the future based on these rules. But one additional question we had was whether or not for the AEOB, the payer has to aggregate estimates from different providers and present it in one view. My reading of the AEOB rules, that does not apply. The price comparison tool, you do have to be able to compare a certain number of providers, but the AEOB is for that specific service for that specific provider. And there is like a little bit of the rule that says that you have to point patients to where they may find more information for in-network providers if this happens to be an out-of-network service. Did I get that right, Anne?
Yeah, I agree at the high level. Yes, I totally agree. It's that's why we have these multiple layers of requirements. So,
okay.
Yeah.
All right. Well, Anne, do you want to go first and kind of give a short synopsis of kind of where you think the world's going to go from here?
Well, I will just say, look, I am, for all of our listeners today, and thank you again to Weedy for doing this, because we are all in this soup together. This is hard. I get it as a regulatory leader. I mean, this is complex and it is a lot to do in a short period of time. we are very sympathetic to that, and just getting ready for January is a huge lift. And that is, of course, the most important thing. I think what I would just say as you work inside your organizations is to think about some of the issues we talked about today, whether that is a strategy for engaging your employees and patients and customers, and what analysis you might want to think about doing, post January, because I don't think these rules are going away. They are in the spirit of improving healthcare, coordinating care, and reducing costs. So I think I heard one of the previous speakers say we do need to get on board and on the train, even though it's moving really quickly. So I'll just leave it with that, Eileen. It's moving where this is a really short timeline to comply.
All right, Steve, you want to give your thoughts?
Yeah, I think it'll be interesting to see how it all works in practice. And I think anytime you see how something works in practice, then you're able to kind of say, hey, what are the tweaks that need to be made and act accordingly. I'll just put just the last thing I'll say is kind of putting back on my state hat and kind of, I think a lot of states this year kind of seeing Supervisors Act and some of these rulemaking around it and other transparency pieces have kind of really, I think, put the foot on the brake a little bit on the state side as far as kind of what their action on is and get their read as far as in how their laws interact with this and what they could do maybe in future sessions to build upon it. So I think that'll be interesting just because, like I said, the states tend to be a little bit of a testing ground for some of this and a lot of things, especially in health policy. So it'll be interesting to see kind of as this gets implemented, kind of what happens there and what could be potentially maybe the next wave and what is happening in that testing ground.
So for me, like I've heard a lot of people tell them that these two rules are keeping them up at night. It's keeping me up at night, but mostly because I'm so excited. Like I think this is going to change healthcare. I think it's going to change the landscape for the better. I think that we're going to get a world in which a patient can adequately understand their costs in advance of getting care and be able to choose a quality that they can afford and not be surprised later. And I'm really excited about that, but it's going to be a big haul for us all to get there and in compliance with these rules.
Excellent. Well, I wanted to thank this wonderful panel, Eileen, Ann and Stephen. You brought us a lot of good information, and you touched on the advanced explanation of benefits, and that's going to be a great lead-in to our discussion right after lunch. So we are going to take a break now. We're going to start up sharp at 1 p.m. So grab some lunch and come back, and we're going to have a wonderful panel focused on the advanced explanation of benefits requirement of the No Surprises Act. So with that, we'll start our break and look forward to seeing you all back here at 1 p.m. Thanks so much.
Thanks, Rob. Appreciate the opportunity.
To say we're going to be focused again on the No Surprises Act. In particular, we're going to be focused on the advanced explanation of benefits. And we have a wonderful panel. And to guide this panel and discussion is Beth Davis. And Beth, I will turn it over to you.
Hey, Rob, thank you. Welcome, everybody. Hope you had a great lunch and came back refreshed, ready to listen and ask questions. So in this session, we'll be discussing the No Surprises Act requirements, specifically advanced explanation of benefits and its impact from the point of view of different stakeholders. So, based on what I've heard so far, I think we all agree with the goals of the No Surprises Act. But to successfully achieve that goal, all the stakeholders need to work together. So if you've done any research on the advanced DOB legislation, you'll observe there's quite a bit of ambiguity in regards to workflow, data formats, transmission methods, and so forth. The devil's in the details. Additional regulations are coming soon that we hope will provide clarity, and guidance to align all the stakeholders around interoperable solutions. And I can't stress that enough, interoperable solutions. Because without that and without an overall strategy that unites the stakeholders, then everybody risks developing one-off solutions that may be compliant to the terms of the law, but they're difficult to consume or they're overburdensome to consume. So WEDI has expressed those concerns in a letter to Secretary Bisharia, which you can find on the WEDI website if you'd like to see more about that. For this session, though, be sure to put any questions in the chat section and we'll address those at the end. Full disclosure, we almost certainly will not have all the answers, but we do hope to get you thinking about the challenges, solutions, questions that will require further elaboration or clarification so that we can help get those addressed for you. So as Rob mentioned, we do have a variety of industry experts here today. I'm going to introduce them real quick. Speaking on what we understand about the law is Kelly Schultz, is Executive Director of the Commercial Policy at AHIP. From a patient's perspective is Andrew Sholnick. He's a Senior Legislative Representative at AARP. He'll share his vision on how patients benefit from this legislation. Terry Cunningham, you heard from this morning, Director of Administrative Simplification Policy with the American Hospital Association. He'll speak to the hospital perspective, specifically the workflow and movement of data between stakeholders and where additional regulations or guidance would be useful. Heather McComas, Director of Administrative Simplification Initiatives at the American Medical Association, and she'll talk about questions and issues from the physician perspective. Aaron Weber, with Core Director at CAQH, will discuss the challenges, lessons learned, concerns, and opportunities for the industry and the potential role of standards and operating rules. And then finally, Vanessa Candelora, HL7 Fire Da Vinci Project PMO, who will be sharing about the Da Vinci Project. So we'll turn this over to Kelly Schultz to get us started. Kelly online? Kelly? Looks like you're muted.
I think you're muted, Kelly.
Okay, I think that was a triple mute. Can you hear me now?
Yes.
Can.
Okay. I thought the slides were going to be the tricky part. Okay, let me pull up my slides. Okay, hopefully you're all seeing that now. So as Beth said, my name is Kelly Schultz. I'm the Executive Director of Commercial Policy here at AHIP, and I have the thrill of having responsibility over our transparency and coverage work, including the Advanced Explanation of Benefits provision in the No Surprises Act. Today, I get the relatively easy job of teeing up what we know about Advanced Explanation of Benefits. The prior panel did get started along that path, but I'll give a brief background on what's in the law for anyone who missed that session. But more importantly, I think what I'll be teeing up is what we don't know in terms of what's outlined in statute, what we anticipate might come through guidance, technical specifications, and regulations. And that what we don't know aspect, I think, is really going to encompass most of our conversation today, if I can guess what my co-panelists will be talking about. I sort of go back and forth between using an iceberg analogy and an onion analogy for this provision. On surface level, it's a pretty basic consumer facing piece of information, really, right, to enable consumers to understand that much more about their potential costs in advance of seeking a service. But as we kind of go below the water and see the rest of the iceberg or peel back those layers of the onion, it just gets more complex with each little additional layer that we look at. So I think that's what I'll aim to tee up today. So we'll just get started with a brief overview of what's in the law. I think, as everyone should know now, this was enacted as part of the No Surprises Act and the Year-End Consolidation Appropriations Act at the end of December. The sort of marquee provisions of the No Surprises Act were surprise billing, other consumer protections, and these transparency requirements. But for those who are perhaps less familiar, there are a whole host of other consumer-facing provisions, including state APCDs, provider directories, broker compensation disclosures, adding new information onto ID cards, continuity of care. So really it's a whole host of, consumer protections around ensuring consumers have full view of, their healthcare, their costs, their quality, et cetera. And these provisions are applicable to group plans and issuers offering individual and group coverage, and that does include self-funded plans. So diving into the Section 111, which is where the advanced EOB provision sits in the No Surprises Act. This applies for plan years beginning January 1st, 2022 and beyond. So yes, that's less than 6 months away. And this section requires that providers or that health plans automatically provide an advanced explanation of benefit upon request when they receive, upon receipt of a notification from a provider or facility when a patient has scheduled a service. Again, a specific service for a specific provider. This is not like the kind of cost calculator provisions that we talked about on earlier sessions where consumers really kind of shopping and comparing by cost. It's more, I know that I'm having a knee replacement done. I've selected Dr. Smith. I schedule at that office. And this really allows me to kind of preview what those estimated costs would be for the full service or for the full bundle. And this is really triggered by another provision, Section 112, which comes right after this in the law, which is a provider notification provision. So it really kind of changes the way that services are going to be scheduled. So moving forward, anytime someone schedules a service, the provider is going to have to ask a couple of questions or take a couple of actions. So first would be to check whether the patient has health insurance coverage that they'll be using for this service. And then if they, the second would be to provide an estimate of the expected charges for a scheduled item and service. And this would apply to someone who has coverage and who doesn't, or isn't using, or has, hasn't met their deductible. So I'm primarily going to talk about this through the lens of, when someone has insurance coverage, since that kind of pulls in, right, the health plan entity as we think about how an advanced EOB is built. But there is another pathway for someone who's uninsured or not using their coverage for a service. So again, this is sort of triggered by the provider notification, and then can also be requested directly by a patient. So the law requires a lot of information and pretty specific on the information, at least types of information that must be included in the advanced EOB. So if the provider is in network, that would include the contracted rate based on the billing and diagnostic codes that are in that notification that I mentioned on the last slide that's required in Section 112. So again, the provider schedules the service and that triggers a notification to the health plan for a covered patient. If the individual is seeking out of network care, the advanced EOB has to include some information on how to learn more about in-network providers. It has to also include an estimate of the provider's estimate of billed charges, an estimate of what the plan is responsible for paying, an estimate of enrollees cost sharing. Also has to include details like progress towards any accumulators that apply, whether this is subject to medical management. They specify a concurrent review, prior auth, step therapy, and first fail. A disclaimer that this is an estimate, that it is an estimate and can change. So some acknowledgement here, like we've also seen in some of the other transparency rules, that any number of things can happen between scheduling a service and actually having that service furnished, whether it's more charges accumulated toward a deductible, a change in network status, which doesn't even address prior authorization. So giving a little bit of protection around this being an estimate and not a guarantee of what the consumer would owe. And then finally, any other information or disclaimers that the plan thinks would be appropriate or helpful for a consumer. So we'll move forward. I have a really simplistic diagram of sort of how the law envisions that this would work. Again, as I said, beginning in 2022, all healthcare providers or facilities would be required to ask patients when they schedule a service if they have healthcare coverage through a health insurer or group plan. And then if they do have coverage, the provider or facility has to then provide a notice to the insurer of the estimated cost of services, the billing and diagnostic codes that can then be used to turn around this estimate. So the timelines in this workflow or pathway are really for an insured patients. They didn't wade into kind of the other uninsured turnaround times. So if the service is scheduled at least 3 days in advance, it's much tighter turnaround timeline. The provider has 1 business day to send a notification to the health plan, and then the health plan in turn has just 1 business day to turn around the advanced EOB. I think a lot of folks on this panel would agree that this and the next timeline are extremely tight, potentially unrealistic. For a service that's scheduled a little bit further out, so at least 10 days in advance, a provider or facility would have 3 business days to turn around the notification to the plan, and then the plan would have 3 business days to turn around the notification to the enrollee. And I think on face level, this seems sort of simple, or at least that's how it seems Congress envisioned this process, right? Not obviously diving into the technical and operational details that we all see. But as you, again, begin to peel back those layers of the onion, it gets so much more complex. And that's what I think we're going to spend a lot of our time talking about today. This is just a short list of some of the ambiguities or complexities around data to be included or data that's required to support notifications, what that flow will look like, what transactions will be used. So kind of every step in that process just has more and more question marks as we start to think about it. So the law would ostensibly require this for all items and services that are scheduled. Does that make the most sense? Is that going to provide utility for consumers? Do I want or need, or am I going to know what to do with a advanced EOB for something that has a $0 copay, or does a copay only doctor's office visit? Is every provider going to be included? Thinking more about that triggering event, is it for every scheduled item or service, or should there really be more kind of opt-in or action from the consumer to say, yes, I do want this advanced EOB, and I know what to do with it, rather than kind of a deluge of paperwork coming patients' ways. Again, we have to sort of think about what the pathway looks like for those who are insured versus uninsured. There are a lot of different considerations there. If we think about the complexity of services and coordinating multiple notifications that a plan might receive, right? So if a hospital or facility sends a notification that may not include the provider piece of the service, how do we think about sending an EOB when we're receiving multiple notifications from multiple providers for a bundled service or for kind of a complete end-to-end unit of care? The notification itself, I think many are going to talk about in this panel, is one of the biggest question marks out there. There's no existing standard or no existing pathway that fits exactly the requirements of this rule. We can sort of kind of retrofit existing standards. We can look through at kind of alternative technologies, maybe a both and approach, but that has to clearly be outlined and has not been yet through regulation and guidance. And that's probably going to be the biggest part of working towards this implementation deadline. Timelines, not only for implementation, but those turnaround timelines that I talked about, 1 business day or 3 business days, is going to be really complex to get the right picture and the right cost estimates to enrollees so that they have meaningful information coming through in these advanced EOBs. And then just as touched on in the prior panel, but I want to really emphasize it for anyone who missed it, is really what's the utility for consumers here? I think, again, on face level, it does make sense to say I've scheduled back surgery or a knee replacement, or I know I'm having a cesarean section. It can be helpful to know in advance what those costs are going to be. Some consumers might use it just as a check the box to get a gut check on or confirm what those costs are headed their way. Some, especially if a service is scheduled further in advance, might use it as a shopping opportunity to say, oh, I didn't realize, or maybe I can find a higher value provider, or maybe I'm requesting this for multiple providers. But to really get to that point, there needs to be a tremendous amount of consumer education around this new piece of paperwork that's coming your way. What's it going to mean? How is this going to change the questions that I'm asked in a provider's office? And what do I really do with, or am I going to be confused by this advanced EOB when it comes to me. So I don't want to lose sight of that piece of it to make sure that the tremendous amount of work the industry is going to do to get these out the door really means something for consumers. And I'm sure we'll kind of touch on this throughout our conversation too, but this is just one piece of the transparency puzzle that's being launched. In prior panels today, we talked about the hospital transparency requirements. We talked about the issuer's requirements, both in terms of machine readable file disclosures to support third-party app tools, as well as health plan cost calculators. How are all of these different tools kind of fitting together, and how are consumers looking at estimates that they get at different points in the road and making heads or tails of it, wanting to make sure that we're always providing value to consumers and providing data that actually helps them make the right decision for them rather than potentially undermining or confusing that decision-making process. And then on this lower level here, I think I've touched on this a little bit, but the timelines to implement operational readiness and just the real need for guidance and regulations to come out from the tri-agencies. We know that they have a huge number of regulations on the horizon to implement No Surprises Act, but it's really difficult to begin work on this piece without some of those signals or more specific requirements in place. So I don't have to spend much time on this slide, but I had just wanted to kind of connect this with the other statutory and regulatory requirements around different transparency provisions, but we spent a lot of time on that earlier today. So with that, I think I can pause and hand it back to Beth and the rest of the panel.
All right, thank you very much, Kelly. We do have a lot of questions in the chat. I'm going to hold most of these and to ask toward the end to give our presenters the opportunity to kind of answer them in some of the discussions. So the next one to speak is Andrew Sholnick, and he's going to talk about his vision for how patients benefit. So great segue, Kelly. Andrew?
Thank you. Again, I'm Andrew Sholnick with AARP. We were and continue to be big supporters of the No Surprises Act. From a consumer perspective, we think this is landmark legislation. I mean, my own family is one of the many who have sought medical care within our insurance provider network. We only to get a bill months later from an out-of-network provider who we didn't choose or had no control over. When implemented, the new law will hopefully end those situations, which unexpectedly cost families hundreds, if not thousands of dollars. While most of the attention has gone to the ban on surprise billing, as we've talked about, there are a number of other provisions that will also have a significant benefit for consumers. One in particular is the advanced explanation of benefits. As Kelly described, the law requires plans to tell individuals how much their service is going to cost, as well as their individual liability for it. This could be game-changing. But I recognize that there's a lot we don't know right now. We don't know how it will affect human behavior and purchasing. We don't know if people will look at the estimate and choose not to get care. We don't know if people will look at the estimate and choose to seek less expensive care or providers. We don't know how much of the advance notice people actually understand. We don't know how accurately the cost estimate will compare to the actual cost. These all have implications for spending, quality, and outcomes. Nevertheless, providing an advanced explanation of benefits is the right thing to do. I mean, really, how often do you buy something, use it, and then find out the price? Consumers want to know how much something is going to cost them, particularly when it comes to their health and well-being. But an advanced EOB is more than a cost estimate. And this goes to an earlier question that Kelly touched on as to what it provides for the individual. It provides peace of mind for people. I don't need to tell you that scheduling a medical service or doctor's appointment is stressful. You're probably doing it because you think something is wrong with you. You could be concerned that it's something serious. You could be in physical pain or discomfort. You're worried about recovery, missing work, or finding transportation home from the hospital. You could be wondering about a whole host of things, only one of which is how much does this cost? An advanced explanation of benefits provides some peace of mind. That document or email at least tells me what I'm getting myself into. Here's what will be done to me. Here's what I'll have to pay. So I know my co-panelists are going to talk about the challenges of implementing this. I hope you will all keep an open mind and remember why the advanced EOB is needed. This is not a reporting burden. It's an opportunity to help people. improve your customer satisfaction, and hopefully lower costs. I thank you for allowing me to set the stage a little bit, and I'm happy to answer questions that come up, but now I'll gladly turn it over to Terry.
Thank you so much, Andrew. 1 second, I'm going to share a screen here. All right, excellent. 1 more second here. Okay. Thank you once again for having me to Weedy, and thank you, Andrew, for and to the other panels for setting the stage. Want to start off by saying the American Hospital Association is extremely supportive of the advanced EOB process, or the advanced EOB. The idea of providing patients with usable details to what their financial obligations would be for a particular care or service they're going to be provided is something that is valuable for the industry, and we fully support this being an approach to get patients that information. As was kind of highlighted or queued up a little bit earlier, we do have a number of concerns that I think what we're seeking is further regulatory guidance. Again, this is not, this discussion should not be taken as a way of us opposing this. It's more of, we're hoping that we can get additional detail so that this is truly achieves its intended result. So with that, I'm going to go through kind of some of the process flow as to how this might work in practice and some of the potentials for hiccups where we're hoping that CMS can provide a little bit of clarity and help the industry answer some of the hanging questions. The first thing that has already been touched on for a patient is when a patient is potentially considering care, where are they going to go for information? There's a lot of price transparency options out there right now. And I think we don't want to have the possibility that a patient is going to have a different number depending on where they go. And then they're not going to, if you have a if you have a number that's going to vary across all these supposed, cost estimators, things that are supposed to give you an idea as to what your financial obligation will be, you're going to ultimately potentially confuse the patient, and it might, and it'll increase the burden for having to support these valuable things. So if you consider, if you're a patient, you've got the option of a hospital price cost, a patient cost tool, an insurer's patient cost tool, the machine readable files we talked about earlier today. You could oftentimes, and I know a lot of hospitals field kind of calls as to what is this going to cost me if I receive this? And then you've got this additional good faith estimate advanced EOB process. I think to align the various price transparency things to sort of identify what a course source of truth or whatever we want to discuss it as, but where you're going to have a number that a patient can truly rely on rather than have a bunch of different figures and kind of say, well, I got this when I looked at the cost estimator. I got this when I looked at the machine readable files. I got this when I looked at the advanced EOB. We need to figure out as an industry, what is the number that patients can truly count on and kind of center around that. The other thing I'll highlight, and I know several have talked about this earlier, is the triggering event. I think there's a little bit of ambiguity in this, but I know there's, and I know Kelly touched on it. In terms of what the triggering event is, our initial read was that it was as requested by the patient. I understand that there's a lot of people who have read this actually as when a service is scheduled. I think clarity in that space is important. And I think due to the potential for, it could require a lot of work. Your coders are kind of going to have to process all of these in order to minimize the administrative burden, the burden on the industry. We would prefer this to be as requested by the patient. If a patient's going to use it, of course, let's provide it, but let's not make it be required for all scheduled services, because that could be extremely burdensome and could be problematic for those who are developing claims, and I guess what you would call good faith estimates and advanced EOBs. Now, let's say the patient, for whatever the triggering event is, right? They've decided that they're going to request that an EOB is required. The next potential issue is there's a lot of different providers who could be involved when there's a particular item or service. And so who is the patient scheduling this service with, or who are they, whoever they're triggering this service with, how are the other providers going to be notified of this? It might seem simple as to whoever is notified, they have to, or whoever is the one on the receiving end of the triggering event, they have to notify the others who are involved. But there's not really a standardized process for this. And given some of the timeframes we've talked about, this could be a hiccup because you've got to figure out a way to rapidly and accurately notify all of the providers who could be potentially involved in care. For example, if you schedule a surgery, you might have the hospital that's going to be at which that surgery is going to be performed. You could have a surgeon who's not billing through the hospital, so they're going to need to be notified. And you could have an anesthesiologist, some other staff that would also be someone that would not need to be notified if an advanced EOB is required. I don't think there's a mechanism for alerting them, and I think it'd be helpful if we were to receive some sort of industry guidance on that to ensure that this can occur in a quick time frame. Moving on to the next box, I suppose it's kind of this one here, is we finally arrived at the fact that good faith estimate has got to be put together and sent to the health insurer. So there's a number of questions that arise at this point as well. Not the least of which is, how is this information going to be shared with the payers? You know, there's a standard way of submitting a claim. It's the 837, X12 837 transaction that's used for claims. It's the standard throughout the industry. And that's achieved enormous administrative savings throughout the industry because there's not this very dynamic different ways in which claims can be sent. The HIPAA administrative simplification, you can look, I'm sure my core colleagues might speak on this greater, but it saves the industry a lot of money each year. And it proves the need for these interactions between providers and health insurers to have some sort of standardization so that a provider is not left saying, right, how do I send it to this health insurer? How do I send it to this health insurer? Instead, you've got kind of a centralized manner of doing that. And so there needs to be a way of figuring out how is a provider expected to deliver this information. I think there's a lot of different ways to go about this. I know we're gonna have several speakers speak on this. My concern with inventing something new is that the ultimate claim is going to be based on the adjudication of the 837 process, the X12 process. So what we want to make sure is if the claim is processed using the 837 process, it would make sense so that you have as accurate, reliable, and consistent of a number for the same type of technology, the same type of adjudication to occur in this, for this advanced EOB, this predetermination claim. Now there is a difficulty with that in the industry, right? The HIPAA recognized standard for the 837 does not, the specific transaction, the X12, does not have the capability of sending a predetermination of benefits. Built out, and this is getting a little in the weeds, and I apologize, but the 5010 version of the X12 5010 version of the transactions, the 837 does not have, the 837 guide that was mandated under HIPAA does not have the ability to conduct a predetermination of benefits. There is a, X12 has identified, and there is an implementation guide on how to conduct advanced, or how to submit predetermination of benefits, but systems aren't necessarily capable of doing that right now, right? You've built to what the HIPAA mandate was. If your system is not up to date, you don't have that ability to conduct a predetermination. So I think there's a concern that there will need to be some opportunity for, I think there's a need to identify what should be used to send this, and the opportunity for providers to implement that into both their technology and their workflows. Some of the other questions that providers will be faced with at this stage is kind of a number of things that could come up. How do you handle when there's multiple providers involved in treatment? And again, I talked about that earlier, but this is going to amount to different people who would send claims, and likely different people sending good faith estimates to health insurer. How is the patient, is the expectation for the health plan to take those in and create an advanced EOB that is reflective of all of the providers who could be involved in care? So I think that's a question that needs to be answered. Additionally, how do you handle when a patient has multiple insurers? You know, there's a process known as coordination of benefits that I'm sure a lot of you are familiar with, but it can take time, and it's a lengthy process in figuring out which insurer is going to pay which part of the bill, and kind of identifying what the ultimately getting to what the patient's obligations are. Given the tight timeframes, I don't know how that's even possible to conduct a typical your expected coordination of benefits and arrive at what would actually be an accurate number for the patient. Additionally, you know, the term good faith estimate kind of gives the impression of this, but it's not necessarily explicitly stated. What do you do with procedures that are not expected or maybe not routine? Like, it's oftentimes during a process, there will be an additional medically necessary procedure that arises when the patient's actually receiving the care. How do we ensure that the hospital is able to submit that claim, and the patient is not, and the health plan is able to offer coverage? How do we basically make sure that the patient understands that there is an opportunity for additional services that could come up because they're medically necessary and they're appropriate for the type of care, and it's just not something that a provider would have known in advance? Additionally, there's certain procedures that are just by nature not routine. They can vary a lot depending on the patient and vary a lot depending on how, the timing, and there's various things that could affect how the claim is ultimately formatted. The concern with this is how reliable is an AEOB if you're sending, if it's not a routine procedure and you've got a number that could vary widely. And so I think it might be appropriate for CMS to kind of limit the scope of this to procedures that are truly the type that this might be a usable number, not just a number that could vary widely. Because again, ultimately what we all want, we don't want the patient getting information that misleads them. So moving on in my chart, let's say all of these are solved, and for whatever format is identified, the good faith estimate is delivered to the health insurer as requested. Now there's a whole lot of issues, and I'm sure we have health insurers on the panel who can speak to this more, but there's a whole lot of issues that need to be figured out at this stage too. Oftentimes during claims, there's kind of a back and forth that goes on between providers and health plans in terms of there might be additional information needed for a claim. There's what do I do? What do you do when there's not, when you receive kind of incomplete information for adjudication as a health plan? You don't have the time to go back to the provider and say, hey, I need this, and there to be the typical conversation that might be used to develop a claim. That's just not, there's simply not enough time for that to occur in this case. So there needs to be some sort of clarity as to how that would work. Additionally, it would be good to have some specifics as to how is a patient going to be truly notified of the utilization management. This is a huge area where there could be patients who get frustrated with the process if they don't truly understand that this number is subject to a prior authorization. So we say it's going to cost you this much, but if a health plan determines that this care was not medically necessary at the time, you could owe more, whatever the ramifications would be for that. So I think there needs to be some more meat put on that bone in terms of how you're going to arrive at how you're going to alert them of utilization management. Another, which is a little bit more than weeds, is what order should multiple procedures be adjudicated? And without getting into too much specifics, the order in which something, especially with kind of the cost sharing models and the varied coverage amounts in terms of tiered benefits and stuff, the order in which incoming care is processed could have a significant effect on what the patient's ultimate fiscal responsibility is. So for example, if a health plan processes a claim that goes completely against the deductible on what would have been 80% cost sharing, on which the patient would have been 20% responsible when creating the AEOB. However, when they're creating the actual ultimate claim, if a different process with a different cost sharing amount is processed, you could arrive at a different number. And again, I think there's just needs to be kind of a little bit more clarity with the ultimate goal is we want this to be reflective of what the claim is truly going to be. And so without a little bit more detail, you have the potential for this to not be as good as it could be. And I think that's what we're pursuing. And then the final thing, and I'm sure some of the others on the panel will speak to this, is how should the information be delivered to the patient? We talk about the EOB process and when we talk about the existing process in which claims are sent in and paid out by the health insurer. And that's typically using your 837, which I talked about earlier, and an 835 transaction, which is an X12 transaction for the electronic remittance advice. The concern with this is that goes back to the provider. The legislation here is calling for the information to be delivered directly to the patient. So there's not really an avenue right now that's been identified as how are you going to deliver this to the patient? You can't really send it via US mail, which is a lot of times when health insurers are communicating with their patients, you're going to send something via US mail, but you can't really do that because of the timeframes I've spoken to. you could consider email, but I know there would be significant security concerns about if you use email. I don't know what the right answer is in this area. And I know Beth said we're not going to have all the answers. I think this is an area to highlight what is expected of the health insurer. How do they deliver this information to the patient? How does the patient get it in a usable format and in a usable time frame? And so when you walk through kind of all of this chart, I think it highlights just a need for there to be additional clarity in the industry so that we can get what the true, the great part about this regulation is providing the patient with usable information and avoiding those situations that Andrew mentioned earlier. And so I think there's a need for some sub-regulatory guidance or some guidance in this, some regulatory guidance, sub-regulatory guidance. There's a need for additional information so that providers and health plans can implement this in the most appropriate, efficient, and accurate manner. With that, I'm happy to take questions, but I think we're probably going to do that at the end. So I will turn it back to Beth. And I'm not sure who's up on the agenda. I apologize.
That's fine. Thank you, Terry. Yes, you really got the questions going. And unfortunately, a lot of them, we have the same questions. So I will save some of these for the end so that we can get through the content. And we might get some answers as we go through it. But next, we're going to go to Heather McComas, who is Director of Administrative Simplification for the AMA, and she'll talk about questions and issues from the physician's perspective. So Heather.
Hey there, everyone, and thanks so much, Beth and Weedy, for having me on this panel. First of all, I will just echo what Terry said in terms of the importance of this provision of the No Surprises Act to patients. The AMA certainly supports patients having access to this transparent information regarding their projected costs for a particular service or procedure. And I think we all agree that's very important. Certainly, individually, I can't speak for everyone on the panel, but as patients ourselves, we realize how important this information is to us when we are expecting to get healthcare. I think that we can see from the myriad of questions in the chat that we have a lot of questions. And so I guess as Terry kind of highlighted, it's not the intent that is perhaps where the concern and angst is. It's the implementation, making sure we get this right, because we do feel if it is rushed and we don't get a lot of these things that are being peppered through the chat and many other issues straightened out before it's implemented, we're going to instead be giving patients incorrect, confusing information, which is actually going to make things worse, not better. So again, the transparency is very important, but I think there are, as everyone's been indicating, a lot of things to be ironed out before this is executed in a way that's meaningful and helpful to patients and get some of the information that they need to make informed decisions about their healthcare. I think that Terry did an excellent job of capturing many of the potential workflow issues and questions from a provider perspective. And I certainly just don't want to repeat everything he said. I will just maybe underscore a couple of the points he made and say that I think they're really important things. And I do think this is one of the potential areas of confusion about the advanced EOB is making sure that it agrees with other tools out there that Terry referenced, the plan estimates and hospital tool estimates out there already, making sure that all these systems are giving patients the same information, right? Because it's going to be very confusing if different sources of information are giving patients different information about their projected costs. So I think that's one thing that's very important that Terry highlighted. I also think that, from a provider workflow perspective, and I would even, certainly welcome the plan folks speaking to share their thoughts on this. I think that my understanding is like Terry's, and my thought is that this would essentially mirror the current claim adjudication process that we have today. And from a provider, you would want to use the same kind of process to prepare a estimate or predetermination request as you would before submitting an actual claim. You would need to code it and submit it just like you would a claim. And then on the plan side, that would enable a kind of mock adjudication. And so it does seem to me that, the workflow and perhaps the transactions used should be similar to what we are using today for claims processing. So that is another important point. We want to keep the workflows the same on the provider perspective. It should, again, kind of mirror the coding and billing processes that providers use for actual completed claim submission. And then also, as Terry hit on, it is really, really important that no matter kind of where we land in rulemaking on how we're going to accomplish this, that it is exactly the same process for every single health plan with which the provider does business. Again, if we do not land on a single way to do this across this industry, we are going to generate a lot more work and confusion for everyone involved. So there really is a need for consistency. And I think Beth hit this early on, that we don't want a bunch of proprietary solutions to kind of facilitate this thing and, do things in such a quick way. The only way to do it is a plan by plan way, because that's going to be very burdensome, certainly from a provider perspective, but may also lead to confusing information for patients. So again, we really agree that there needs to be a standard way to accomplish this across all health plans. A couple of things are highlighted in terms of questions or concerns from the physician's perspective. And Terry got to this too, and I think it's something we will probably dialogue a bit as we get into more of a discussion mode, is what exactly is the trigger for the advanced EOB? And I think that we can already see in the chat, for what others have said already, we have some differences of opinion about what actually triggers it. As Terry indicated, there are already existing tools on both the provider and the plan side to give patients estimates of the projected costs. So there are other ways that patients could try to get this information. Some people are suggesting that scheduling a service is what the trigger is. And that's, I will admit that I think that is something that needs clarified in rulemaking. As Terry indicated, that if this is really going to be for every single service that's scheduled, that's going to be a huge uptick on providers' workflow kind of challenges. I mean, essentially it could be two billing processes per service, one, the pre-adjudication, the predetermination, and then the actual claim, because you might have to recode things if things changed when between the predetermination, the actual provision of the service. And on the plan side too, they would have to process both a predetermination and a claim. So we're looking at essentially doubling our adjudication volume if we assume that this is going to be for every single scheduled service. So I think the trigger is definitely a question. We need clarity on that. And as Terry also indicated, I think that the question of what triggers the kind of other providers involved in an episode of care is another outstanding question. There'd be maybe one central provider knows, okay, we have a surgery that's scheduled, but then what about the anesthesiologist, and what about the lab, and what about imaging, and how are we going to make sure that all those other providers are paying so they're part of gathering that estimate information? So I think there are a lot of questions around what triggers the advanced EOB process, and then how you also get all the other providers looped into the workflow here, so the patient gets a complete picture of what an overall episode of care is going to cost them. Something else I don't think has been raised too much, and certainly from a physician perspective, it's very concerning. The act as written indicates that the EOB will be provided to the patient. And from our perspective, it is critical that the physician or other provider get that estimate as well, because they need to know how the plan indicated they were going to adjudicate this claim. And if they need to have a discussion with the patient about this estimate, they need to have that information as well. So we see that as a real concern about the way the legislation was written. And we hope that as we talk this through and discuss this more and look towards getting guidance and regulation, that there will be a recognition that providers need to get this information as well, so they can have informed conversations with patients about the data that they're obtaining from plans about their advanced explanation of benefits. So again, we think it's very important for the information to be returned to providers as well. And then I think, one final kind of thought on all of this, I think that it's really important for all of us to realize that this is going to require some additional patient education and making, it's kind of Andrew's hitting on it, making sure that whatever is coming to the patient is understandable, and also helping patients realize what this explanation of benefits means and what it doesn't mean. I know from the provider side, everyone jokes about when they get a prior authorization approval and there's a disclaimer, this is not a guarantee of payment, right? So providers are used to seeing that kind of language, but I think we need to do a really good job of educating patients about what this estimate is, so they realize that things could change. As we all know, sometimes in the middle of a procedure or surgery, there's a kind of changing clinical circumstance that necessitates the provision of a different service than was originally expected, and for which, in this case, the cost estimate was provided. So that's going to change the final bill, right? And we know this is certainly a concern in the prior authorization realm when we have, a procedure approved, but then something changed and then the claim ends up being denied because a different procedure code is on the actual claim. So similar situation here with advanced explanation of benefits. And I think that patients need to be educated to be really cognizant of what this estimate means and that things could actually be different at the end of the day. So I think there's going to be a real need to work with patients on explaining this to them so they understand that, this is the best information that's available at this point in time, that things might change in the future. So again, I think there is a lot of value in this. I think from a patient perspective, it offers the transparency that we all really want to bring to our healthcare system. And certainly physicians want patients to have this information, but it's kind of the details of making sure that we do this correctly the first time around, that we take the time to do it the right way so we're not introducing even more confusion into our very complicated billing system in the United States. So I will stop there and pass the baton back to Beth. Thanks so much.
Thank you, Heather. Yes, those were excellent points. I heard a lot of our questions reiterated, and thank you for putting those into great context so that we could get those things out there. So next to speak is Erin Weber, Core Director at CAQH, and she's going to be discussing the challenges, lessons learned, concerns and opportunities for the industry, and the potential role of standards and operating rules. All right, Erin.
Thanks, Beth, and thanks everyone for joining us today. For those of you that are less familiar with CORE, and I know this audience typically is very familiar with CORE, just a quick reminder, we are the HHS designated National Operating Rule authoring entity for the HIPAA transactions. And CORE is a multi-stakeholder group. Many of your organizations are members that has been coming together for almost 15 years now to develop operating rules. Operating rules are defined as the necessary business rules and guidelines for the electronic exchange of information that's not defined by a standard or its implementation specifications. So operating rules can apply to all types of standards, not just the HIPAA standards. And in fact, our rules include industry neutral standards like SOAP and EFT as well. CORE was originally founded because when HIPAA was passed, there was a lot of variation in how the standards were being implemented, making it very difficult for industry to automate transactions between health plans and providers. So if you think about the eligibility inquiry in particular, the standard was very limited in its data requirements and also lacked infrastructure requirements in terms of turnaround time and expectations for system availability. And so the CORE participants came together and developed rules around that. I think there's a lot of lessons learned and parallels that can be applied to this advanced EOB requirement. We've received a lot of outreach from our participating organizations for our thoughts and guidance. Of course, we're very supportive of the intent of letting patients have more awareness of their costs. And we're working on a letter ourselves with where we'll share some similar feedback as to what I'll talk about today. But CORE has really been focused on creating kind of the rules of the road for data exchange using existing and emerging standards. And so some of the lessons learned that I think will be important here, and then I'll touch on some key considerations. First is, engage all impacted stakeholders early in the process. We've heard a lot from provider organizations, I think less from health plans at this point in terms of how this process could work, what standards might be used to exchange information between both the providers and the plans for that good faith estimate, and then also between the health plan and the consumers. I think one of the things that we always think about as we're starting a new rule development effort also is to focus on the 80-20. It's not always possible to solve or address every single detail or component. And if you try to get to that point, you're just going to spin your wheels. So there may be some components here where it's better to stay silent or not address the topic. So if you think about some of our rules around the remittance denial and remittance codes, or sorry, denial and adjustment codes that go on the remittance advice, the core participants took the approach of identifying the most common business scenarios and developing code combinations to use for those business scenarios. So thinking creatively around how that process could be used in this scenario. Another thing to think about is to start with a floor, not a ceiling. Set some ground rules from an eligibility perspective, and I'll use this example kind of throughout. Our rules have identified a minimum level of service type codes that must be supportive, and entities can go above and beyond that. Or from a response time perspective, there's a 20-second real-time requirement. You can go faster, right? So thinking through, we don't want to limit what the industry could do or benefit from with this requirement, but you also want to, as my other panelists have emphasized, there's real need for standardization and consistency here. And I guess the fourth point I'd make on lessons learned is flexibility on timelines and deadlines. January 1st is very, very soon. I think we heard in other presentations also that may not be the end all be all for this particular requirement, and probably shouldn't be, given the amount of work and challenges that we've heard from our other panelists. It's really important to take the time to get something right and not just to meet an arbitrary deadline. Some of the considerations I think we need to make as we look at this advanced EOB requirement are many of the same concerns that the prior speakers noted. So I'm not going to go into detail on those. What's the volume of transaction? That could have a huge impact on both plans and providers if this is for every single service. How to aggregate the provider's good faith estimate. Those are all challenges that others have spoken on. Heather mentioned the importance of a standard way to exchange this information. And I pulled up some of our CAQH index data just to look at the impact from a cost perspective of less standard ways of doing things. So for the eligibility transaction, for example, industry conducts about 21 billion eligibility transactions a year. And about 15% of those are conducted using a portal, and slightly less are done manually over the phone at this point. But if all of those manual and portal transactions were done electronically, the industry would save more than $7 billion annually. So if you think about the volume of transactions we're talking about here and doing them either over the phone potentially or through different portals for each provider or health plan, there's potential to add a lot of cost and administrative burden to the system here. And I think we can all agree we don't want to do that. My next point is that there's a lot of different sources for this data. So what the industry needs to do is coalesce around the best approach to optimize and automate it. We don't want to reinvent the wheel. There's lots of opportunity to build on good work that's already completed or in progress within the industry. We've done a cursory look at the potential transactions that could be used here. Terry mentioned a lot of this information is already in the claim adjudication system, and there is a newer version of the claim transaction that can be used for predetermination. There's a predetermination transaction. So when you're thinking about that health plan provider exchange, you want to be consistent with what the systems are already doing and exchanging. And then thinking about the work that Da Vinci and Karen are doing and the interoperability rule requirements, there may be some opportunity to build on that work with FHIR and some of the more emerging standards in terms of exchanging information with the patients. And I know Vanessa is going to speak on that in a minute. I think it's also really critical that regardless of what standards are being used, that we're thinking about how to make sure that that data content, the information that's being expected to be exchanged between a provider and the plan, and then the plan and the member, is consistent, especially if we're not using a single standard, right? And that the infrastructure expectations around how and when and the availability of that information is the same. And those are things that operating rules have supported for a really long time. So I think, kind of in closing, the industry is really needs to develop an overarching strategy to consider how these requirements can support the advanced EOB workflow without creating unnecessary burdens and building on what the industry has already done. So this is where we think there is a really meaningful role for standards and operating rules, and plan to engage in further discussions with our board and our participants in the industry around how we can support this effort. So thanks, Beth.
All right, thank you, Erin. Yeah, I think mentioning again the short time frame, and we all know the types of interactions it takes to really get either a new transaction or an interoperable solution off. There's our testing, our sprints, our timelines, and all those things that have to be factored in. So I think that the timeline and the lack of a glide path really don't accommodate any kind of testing. So that's a concern that we need to get addressed. So that I think we'll go to our last speaker, Vanessa Candelora. She's going to talk about HL7 Fire Da Vinci project.
Thank you so much, Beth. Can you hear me okay?
Yes, I can.
All right, let me go ahead and share. I have a few slides prepared, and I just first want to say that I am so honored to be a part of this panel. Everything that the panelists have been saying in this session and also the morning sessions is very well aligned with the work that we're doing in Da Vinci. So I'll run through these slides fairly quickly so that we have plenty of time for all of the questions that have been happening in the chat. But just want to give everyone a quick review here of what we're doing within Da Vinci. So my name is Vanessa Candelora. I'm with Point of Care Partners and part of the Da Vinci PMO office. The goal here is to really learn about what the HL7 Fire Accelerator Da Vinci is very quickly, and what our work to date has been on our use case called patient cost transparency. And then I'll also leave you with how to get involved and drive some of that engaging stakeholders early that Erin was just talking about. So our stakeholder membership, this is a little bit about our membership, and let me just move that out of the way. There we go. And you can see that we have a multi-stakeholder membership here. So we have providers and payers and all of these industry vendors and industry partners and EHRs and deployment folks coming together to look at building standards that solve business problems like patient cost transparency and some of the things that the rules that have been talked about all morning are driving forward in the industry. And so what we're really doing here, this is kind of an overview slide, and if you've participated in any Da Vinci calls, you've probably seen this a million times. But these are our different use cases. So we focus on a lot of different areas for how we can apply data exchange standards, HL7 Fire, to solving these different areas. So we have quality implementation guides, we have coverage burden reduction implementation guides, think prior authorization, member access for some of the coming rules on 1.7 for patient access API and others, and our clinical data exchange over on the right. And what we're really going to talk about today is patient cost transparency. So we have a use case called patient cost transparency. And what we're really trying to solve for is not just each of the regulations that have been talked about this morning, the hospital rule, the transparency and coverage rule, and the No Surprises Act as part of consolidated appropriations, but how do we get the data to flow between all of these multiple stakeholders to really have an effective impact on patients? And I've heard a lot of the panelists talk about that now, right? We want to meet the rules. We also want to think about the spirit of this law and the rules and how we can define standard FHIR-based methodology to support real-time requests, as we heard Terry talk about earlier and others, that will enable that, that decision-making and knowledge for the patient. So this is so fascinating. I've been listening all morning, and I think that all of these areas have been touched on, and I'm almost summarizing for what's been on this panel, which is fantastic. So a lot of the discussions that have been occurring with the Da Vinci members on this use case for the past 6 or so months is really kind of, this is our way of sort of summarizing all of the different dimensions. Dare I say the word facets, because I know that that is a product in the industry for payers. But you know, first and foremost, it's perspective, right? The patients have needs, the providers have needs, the payers have needs for transparency with the services. And you know, there has been a lot of talk about what the patients are looking for, right? Is it that they're out of pocket? Is it their total cost of care? And what providers are looking for, and what that information gap is for those different perspectives. So if a patient is more on the shopping experience up front, you know, they may have a lot less specific CPT codes and where they're going to go to be able to provide that information to get to an accurate estimate. So that is one of the big facets that we talk about often, which kind of leads into timing. So where are you in the patient journey, and how does that impact what level of accuracy or you know, narrowing the range of the estimate that gets provided, right? And so, you know, you think about if you go to your provider and you're looking for you know, you decide that based on some symptoms, you may be looking at a total knee replacement. You know, if you're at the point of the consult where the provider is, you know, requesting an MRI or an X-ray, that's very different than being able to be really close to what that surgery is going to look like, what the physical therapy afterwards might look like, to be able to get that full collection of services to be able to provide an accurate estimate. With that said, we want to be able to inform patients as much as we possibly can with the information that we know at the point in time and who knows it, right? So that kind of covers these first three. And then if we look over on the right here, we talk a lot about the technology, and my former panelists have said this very succinctly, which is great. So we are, Da Vinci is an HL7 FHIR accelerator. So we are looking at how FHIR can help solve this industry problem, recognizing that there are a lot of currently available technologies out there today, including what Terry was mentioning, and the closeness to the 837 predetermination of claims, which is going to be really important to make sure that everything is aligned. Right. So we don't want different estimates from different places, as many of you have talked about. So recognizing how can we leverage the technology that is currently available today and look to the future, where are those future opportunities, which leads me to sort of that industry solution readiness, right? What are people using today? How are they implementing, doing estimates today, right? There's lots of tools out there right now. But we need to balance getting something out quickly because of these looming deadlines that have been talked about all morning, but also getting it right, to Heather's point. We want to make sure that we balance the fastness with the future proofing, right? And then this big bucket of the collection of services. And we say collection of services, you know, if you've worked with Viet Nguyen, who is our technical director for Da Vinci, you'll hear him a self-proclaimed terminologist. And we want to get the varied, you know, there's a lot of definitions of what goes into that collection of services. And one of the panelists this morning was talking about this as well, that you know, what goes into it? Do you have the information for the contracted provider versus the provider that works for the hospital? Also, you know, if you're going for a total knee replacement, do you include the after physical therapy and other needs, or is it just for the surgery? And how do we define that so that you can compare true apples to apples as a patient? There isn't really a structured definition for that. And I say collection of services because you know, bundled payments or episodes of care kind of have loaded definitions themselves already. And I think we're still working as an industry to figure out what that looks like. And we want whatever solution gets put in place as a standard to solve the right problem, right? And to accommodate what that looks like without adding burden to the industry. So we went through all of this already, but these are the 3 rules that have been talked about all day today. So I'll just fast forward here, but there's some links in here to the actual rules. And then this, I'll also skim through pretty quickly. This is a visual that, you know, there's a lot of arrows everywhere, right? There's 9 different arrows on this, and all of these arrows and numbers are really opportunities for standardization based on the No Surprises Act. And you can see here, I'll just point out, like, we've got 3 patients on here, patient, member, right? It's at risk for complication here. And we want to provide something that is succinct and simple for a data exchange, but also meets the need of the requirements and solves the problem in spirit as well. So this is a really good representation that you know, we've been looking at for a long time, but may make people dizzy, and I apologize for that. So I'll move right on to a proposed workflow. So this would be kind of where our thinking is at with Da Vinci, sort of a sneak preview here of one of the workflows that really addresses the advanced DOB, which is what this panel is focused on. And this is the trigger of by request of the patient, or upon them scheduling the service, which is what the No Surprises Act is leading to. And so the patient would schedule that service or request, and then the trigger of the advanced EOB would start. And then the servicing provider that they're working with somehow needs to work with those secondary providers to compose that good faith estimate, which is in the middle here. I'm not sure if you can see my mouse or not, but I'm pointing in the middle there, compose good faith estimate. And then that information would be sent over to the payer. The payer would, you know, add their pieces of information, compose the advanced DOB, and return it back to the patient. Now, the topic has come up many times on the panelists before me, which I'm pleased to hear. We are hearing very much from members that this dotted line in the middle here that says return advanced DOB optional, that is listed as optional in a dotted line because to our knowledge, there is nothing in the regulation that says that payer needs to provide it back to the servicing provider. But the industry that we are hearing from, the folks that we're hearing from, is that they really want equity, you know, information equity across payers, providers, and patients to be able to really solve this industry problem. And having that information equity across all of those participants in giving transparency is going to avoid confusion and enable patients and providers to have an informed discussion and provide transparency across everyone and what the costs are in more of a meaningful way. And if we don't do something like that, it could have ramifications. So we're hearing that as well. And that kind of echoes what Heather and Terry were talking about earlier. And I'll also just note that I believe, and I'd love for someone to correct me if I'm wrong, but this is actually how it works in dental and other areas today. So it's not out of the realm of possibility. To give everyone a sense of what we do in Da Vinci, this is a sample project timeline. We call it our Mickey Mouse picture, because if you turn it this way, it looks like some ears. And what we're doing is we're developing implementation guides and reference implementations, which is like the demo or the sandbox application of the implementation guide of FHIR. So we are currently within patient cost transparency right in here. We've assembled the team. We've been doing a lot of discovery, and we are getting ready to launch into requirements, which is a publicly available process. We meet once a week. And we are launching that next Friday. And from there, we will be gathering requirements, performing a FHIR gap analysis with what the data looks like, and creating our implementation guide and reference implementations, and then following the process of the HL7 ballot, which is a voting process. And we're targeting aggressively a January 2022 ballot cycle. So these are the dates that we'll put out there. And I will conclude with just some information. If you are interested in continuing this discussion beyond the next 20 minutes of Q&A, and you would like to be involved in how we may be able to apply FHIR or standards of data exchange, and FHIR working with other standards that are available today or emerging to try to solve this business problem, we encourage you to join us. Again, starting next Friday at 11, and you can check out the HL7 calendar to join us next Friday for our kickoff and beyond. Thank you so much.
Thank you, Vanessa. Can everybody hear me okay? Had a technical thing going on. Okay, so let's start with the questions. So I'm just going to kind of read these out, and panelists, if you could maybe unmute and help answer some of these, because I know I sure don't have all these answers, but there's a few that has some trends there. So I'm going to start with this one that says, who is taking all of these questions to HHS, CMS, or the decision makers? And I don't know if Rob is on, but I can just speak to that real quick and say that our intention with this session is to gather these types of thoughts and the questions that are kind of coalescing as we have more discussions. They kind of group together in more obvious questions that we're all asking. And so WEDI does plan to assemble those along with the questions we've already posed. So we'll be collecting this information and getting this to the decision makers and to those who are setting the policy. Anything any of the panelists would like to contribute to that?
I'll just say, Beth, you're spot on. And the other thing that we anticipate doing is convening the industry to review and discuss any proposed or interim final rules that CMS releases.
Yes, thank you. Another question was around penalties. So we talked about a very short, you heard the amount of clarification that's needed, and that we also want an interoperable solution or a series of interoperable solutions. And we have, 6 months until this goes into effect. And so obviously the question, or naturally the question comes up, is what are the penalties for those providers who are not ready to be able to do either their part or any part of this? Does anybody want to weigh in on that?
So on the plan side of things, this is subject to the 27-23 Public Health Service Act provision. So that would mean the penalties are fairly steep. It's $100 per enrollee per day, right? So that really adds up quite quickly on the plan side in terms of penalties if there's, if the implementation timeline moves forward or if a plan's not ready, right?
Okay, yes, I don't know. I think that's something that we'll need to take away in our list of things is to ask about. I don't recall seeing anything that specifically talked about specific penalties at this phase. All right, so there's a lot of stuff in the question. So there's a lot of. Does anybody want to help me out and repost their question at the bottom? And I will.
And Beth, this is Erin. I just wanted to add one thing that I've been thinking about too. While this compliance date is very soon, I think it's really important for us all to think through that compliance should probably not be the end goal here. right? We need to think longer term about the value of this data, the value of sharing this data. How can we change our systems and the way things are now to better accommodate this kind of information sharing over the longer term? Because the need for this information isn't going to go away. And so the initial date's really important, but as we're working towards meeting the compliance timelines, we need to think more broadly.
Well, I don't disagree with that, and I think that is the ultimately the right answer. But practically speaking, as an organization who has to be compliant in order to avoid significant fines or damage to your reputation or whatever that is, I'm going to do whatever's in my control to be compliant. And whatever's in my control is generally going to be a homegrown design, whether that is, I'm going to put the process out on my web portal, and I'm going to have providers come type in procedure codes like a direct data entry or a phone. And not that any of those are bad or inherently good, just they're not necessarily interoperable. So, I mean, it would help a lot if we could get legislation that makes that a permissible approach. So it says, hey, maybe they don't enforce this for the first year and give us a glide path to have things, start getting it in place. And the dates and compliant dates still might stand, but there's no penalties until X amount of time. And it gives people, because otherwise you're de-incentivizing by giving an unrealistic time frame. And we see that with the development of some of our others, attachments and prior authorizations, some of those others that require so much interaction between systems that everybody just gets paralyzed. And you end up with a bunch of homegrown. And I know we said that many times that we don't want these individual homegrown solutions, which is kind of what you're alluding to as well. But how do you avoid it when you have to have a compliance date? Do you try to design something scalable, or so that you can grow it, or do you go with something you can control all aspects of? So, I mean,
I totally agree. It's a challenge. And I think, to your point, it's probably one of the most consistent comments across all the letters we've seen come from many on the panel and many in our industry to the regulators, because it's really important.
And one thing I want to highlight, because I've heard it in other discussions I've had around this, is that this is very different from the attachments regulation. There's kind of been some people have tongue in cheek said, oh, well, CMS has missed deadlines before. They were supposed to have the attachments regulation years ago. This is very different than that, though. There are compliance requirements that are 1/1/22. It's not like an attachment, well, you can't use it because there still hasn't been a standard name. There is a law that's requiring providers and health plans to actually develop this. And so it's not like something that you could just say, well, they'll eventually release guidance similar to they'll eventually get to an attachments regulation. No, there is a finite amount of time to really get some of these questions answered. Otherwise you do, or to get, as Beth indicated, maybe a glide path with kind of some non-enforcement. Because otherwise you've got these providers and health plans who are very concerned, but unclear as to how they're truly going to operationalize this. And so I think it's an important difference between this and some of the other regulations we've seen in the administrative simplification space, because this has consequences that are not something that can just be, well, we'll start using it once it's built. The law says you got to do it 1/1/22, and without it, people are going to be out of compliance. There's a lot more nervous concern about not having something in place on this versus an attachment where it's like, well, hopefully they release something and we can incorporate it into our process at that stage.
Those are great points, exactly. And a lot of what I'm hearing from the plans that I've spoken with, who are saying, well, we don't have all these answers either, so we're just going to do something so that we can be compliant. And ultimately, we really don't want something. We want something good. We want something that works. We want something that meets the goal, because we've all agreed that that goal is worthy and that goal is worth doing the work for. That did bring up another question about who is funding all of this. Has there been any discussions of financial considerations to involved parties? So great question. Who'd like to take that?
I can't answer that one, but I'd be happy to add some comments to the previous one. If that's okay. I was just thinking about the timeline and the challenges there, and I think all of that's very valid. And I want to echo what one of the previous presenters earlier this morning mentioned, which is this is sort of a long-term journey, right? So we're going to set something up now, whether it's a tool to meet one of the regulations or it's a advanced EOB workflow like we're talking about here. And we're going to need to iterate on that over time, right? I come from a payer provider software background where we worked in agile, and I know that's very different coming to a standards and a policy making world here. But you know, there's an opportunity for this to evolve over time. I think Aaron mentioned or Kelly mentioned that, you know, this may not be the last rule, right? There's going to be more. So I think it only makes sense to balance the goal of having a proprietary solution that meets the deadlines that you're faced with today as an organization, as well as, you know, don't make it all technical debt that you're going to have to throw out when the next regulation builds on top of it, right? So I would imagine that organizations are weighing the pros and cons of that. And, you know, we are seeing interoperability and sort of the four legs of the stool that someone mentioned earlier: price transparency, interoperability, quality, and I forget the other one, but maybe patient focus, right? So thinking about all those things and enabling these regulations to give organizations the opportunity and time to get their housekeeping in order and develop something that is not proprietary, you know, I think there's an opportunity there that I hope people don't miss out on.
Yeah, I think you're exactly right.
I think we're all in.
Yeah, go ahead. Go ahead.
Oh, I was just gonna say, I think we're all pretty in pretty violent agreement at this point that, right, the 6 months time frame is so aggressive, and that there are really serious considerations when we kind of weigh compliance requirements as well as, you know, the reality for consumers of kind of rushing to meet those deadlines, which is why I think, you know, AHIP and a lot of the other organizations in this panel have really urged the administration to you know, provide some signals on what they're thinking in terms of next steps to regulations and timing. The other hat that I wear in my job is have worked on ACA and exchange implementation since before there was a healthcare.gov, and we saw the really you know, significant impacts for consumers as well as for plans and kind of other stakeholders of rushing to put something out to meet a deadline when we, you know, simply were not ready. And there are, you know, in this case would be, I think, real consequences for not taking the time to thoughtfully answer all of these questions from kind of the technical side of it, as well as, you know, the consumer facing aspect. How are consumers going to use this? You know, what does it really mean from an end user standpoint? So, you know, if anyone from CMS is listening, I think that that's the point that we would all urge, is really thoughtfully thinking about, you know, what the end goal is and how we reach that in a thoughtful manner without kind of you know, disadvantaging consumers or disadvantaging other stakeholders by kind of slapping together a process before we're truly ready as an industry.
Thank you. Thank you. Another question that came up was for Terry, and could you help Leon understand what the consequences you were referring to look like?
Sure, and I'll admit I don't have the link, the text of the bill right in front of me, but I believe it's spelled out in section 112, and the potential penalties for a provider who does not meet the advanced EOB could be up to $10,000 per violation on provider or facility. So talking about real money, it's a significant. It's not like $100 a day. This is something it appears to. Now there's a reason that I didn't have that number readily available, because there is a lot of ambiguity still on this, and I think this is another area where it would be great for CMS to truly explicitly say both what a violation is and what the consequences will be. But based on my reading of the regulation, I believe it could be up to $10,000 per violation for a provider or facility.
Thank you. All right, so we're nearing the end of our time. Do we have any other questions? I apologize if I didn't get to everybody, but I think I got the gist of most of them. there's a lot of good information in the chat. I think we'll have that. We'll have this. We'll use this in some manner. I know we'll be getting the information out of it and using that also to help us formulate some specific questions and recommendations back to CMS and the regulators. Rob, is there anything that you would like to okay. Oh, okay. Well, here's one more question. It's how do delegated payers fit in the mix? Does anybody want to take that one? Yeah, I think some of these are going to get harder for us to answer in the 5 minutes. So I'll do my best to go through this, and we'll work to get answers for the questions that we didn't have time to ask here. Rob, is there anything you want to speak to that, some of these unanswered questions in the chat and what we plan to do next?
Yeah, there's a lot of questions, not just in the chat, but I think all the speakers raised a lot of issues. I've tried to capture some, and we're going to discuss them in the last session of the day. But as we've said before, this is sort of the first step of a long journey, not just for Weedy, but for the industry. So what we're going to do is continue to solicit input. And I believe that CMS is looking for this input. I think they're as challenged to answer these questions as we are. It's one thing for the legislators to pass a law, but it's up to the regulators to actually come up with the nuts and bolts on how stakeholders are to implement it. So a lot of work ahead, but you guys have done just a phenomenal job of laying out some of the key issues and raising a lot of the important questions. So just the beginning, but when we get into our next panel here in a minute or two, we'll identify even more issues and challenges. So that one was just basically in regards to the advanced explanation of benefits. But as we know, the law includes a number of other provisions as well. So let me just take the opportunity to thank Beth for her stellar job moderating this panel. Thanks to Terry, Andrew, Heather, Aaron, Kelly, and Vanessa. We thank you for your expertise in this area. And with that, we will move to the sort of second half of our No Surprises Act discussion. We're going to have Stanley Knoxon come back and serve as moderator. And Stanley, if you would introduce your panelists.
Certainly. So this is, I guess, Act 2. We didn't have much of an intermission, but that's okay. I think we've covered quite a bit of information so far today, and if that's not enough, we've got some more requirements from the No Surprises Act that we'll be discussing, getting some comment on. We're fortunate to have a number of folks on the panel that will give us feedback on how these additional requirements will be impacting the industry. Anna Hyde, the Vice President of Advocacy and Access from the Arthritis Foundation. Mark Pratt, the Senior Vice President of Public Affairs for CAQH, and Allison Armstrong, the Director of Public Policy from Anthem. I want to just take a few minutes, share my screen, and talk about some of these additional NSA requirements. And I hope my my screen is being shared. Can I just get a
not so far, Stanley.
Okay.
Try again.
Listening. Still not yet?
Not so far.
Yeah.
All right, let's just double check one thing. Going to Zoom. Here we go. I forgot to click the share button.
That's it.
How about that? Now
Excellent.
I'm sharing. Well, I never was much of a sharer. So Let's see if we can close those eyes. So we'll talk a little bit about some of the additional requirements from the NSA, and then we'll let the folks from the panel talk about the impacts to their organizations and to patients, and perhaps some suggested actions that the industry and WEDI should take to help the industry move forward.
Stanley, you might want to go into your slide view. We're still looking at the preview.
How about that? We still look, do we have the slide view now?
No, not yet. It's still, I see now the slide in the preview slide.
Okay, well, I think there is some issue with PowerPoint and Zoom, so we'll just leave it at this. We've got, at least we're showing the slide. So I've got the first requirement, the ID card, patient ID requirements in section 107, which requires health plans offering group and individual health insurance coverage to include new information on insurance ID cards. Again, we'll emphasize for plan years beginning on or after January 1st, 2022. And on the cards, we've got to include all plan deductibles, including in-network and out-of-network deductible amounts as applicable. Maximum limits on out-of-pocket costs, including in-network and out-of-network, out-of-pocket cost limits as applicable, and a telephone number and web address for consumer assistance information, including information on in-network providers. So a lot of the information on in and out-of-network providers, deductibles and financial limits, a lot more information on our ID cards. I guess our cards will be getting bigger. May not fit in our wallets, but we'll have to figure that all out. We've got price comparison tools, section 114 of the rule. Health plans must maintain online price comparison tools to allow patients to compare expected out-of-pocket costs for items and services across multiple providers. The plans will also need to provide those comparisons over the phone. Health plans will need to offer such price comparisons for plan years beginning on or after January 1st, 2022. So it's not only the online comparisons, it's the phone information also. So more information for your customer service folks. Provider directories beginning for health plan years on and after January 1st, 2022 to resolve some of the issues that we've seen with provider directories. Plans will be required to establish a verification process to ensure accurate provider directories, a response protocol for individuals inquiring about the network status of a provider, and a publicly accessible provider database. And patients that relied on any inaccurate provider directory information would only be subject to the in-network cost sharing amounts. There's an incentive for health plans. Health plans must verify and update provider directory information no less than every 90 days or within 2 days of receiving notice of a change, as well as establish a procedure for removal of providers who are no longer in the network. Again, a lot of work on health plans, and plans are required to respond to individuals inquiring about the network status of the provider or the facility within 1 business day of the inquiry. A lot of requirements there. And then I think the final requirement that relates to these new provider directories, plans are required to ensure continuing care patients receive timely notification of changes in the network status of providers and facilities, and patients will have up to 90 days of continued coverage at in-network cost sharing to allow for a transition of care to an in-network provider. So a lot of changes for health plans and an impact on the patients. Let me now start turning it over to our panel to talk about this. Anna, why don't do you want to go first in terms of the patient impact?
Sure. I'm working on getting my video going here. Can you hear me okay in the meantime?
I can hear you fine.
Okay, wonderful, wonderful. Yeah, I would love to just kind of frame this up for the rest of the panel who will get more into the nuts and bolts. But I want to channel what we talked about in our planning call for this session, which is that sort of all roads lead to the sort of the objective that we're all, sort of going for here, which is for the patient to have a better healthcare experience. I think no matter what side of the healthcare ecosystem we're on, we can all agree on that. So that's sort of the lens that I'm taking here. We, the Arthritis Foundation, we've certainly heard stories of surprise billing, even though my therapeutic area is not one of the sort of higher ones for surprise billing. One of the more common places that we see it is around joint replacement, because there are so many providers who are involved in your care, and often multiple healthcare settings. And so there are opportunities there for that to happen. And we've had heard a number of stories to that effect. And when it seemed as though surprise billing was going to be a big priority in the last Congress, we decided to put our sort of patient committees and advocacy committees together and write a position statement. And the kind of through line for us was to hold patients harmless. And so on things like dispute resolution and how that should work, we didn't think it was our place to necessarily take a strong position there. We just wanted to have sort of the patient in mind first and foremost. We activated our advocates, and we got thousands of patient stories and action alerts, which really kind of spoke to the passion of the issue and the experiences that our patients had around surprise billing. We turned some of them into blog posts and things like that, just to sort of raise awareness about the issue. So of course, when we were nearing the end of the last Congress and weren't totally sure what was going to happen, and it became clear that there was a real window of opportunity, we certainly took a strong role from the patient community and just making sure that the language got passed. And we've remained active with a couple of different patient coalitions on the implementation side, because of course, as we go through this process, we want to make sure that those general principles stand, that patients are held harmless, that there aren't unintended consequences that are going to negatively impact patient care. And a lot of the themes that have certainly been talked about today at great length around administrative simplification, standardization, things like that. I mean, these all, timeliness of, provider directories being updated, things like that. Just general transparency and the ability for patients to kind of know what they're walking into and what they're dealing with. All of those things are things that we've long supported in one form or another. It's nice to see a lot of those themes that we've sort of looked at separately in the past put together in one place, and fully recognizing the difficulty, as is evidenced by the sessions today, and actually implementing this and getting it off the ground in a way that works for everybody involved. We just, our sort of general call to action is to continue to keep the patient in mind. And depending on kind of where we go in the panel and the questions, I can certainly get into from the patient perspective, sort of what we're looking at and the communications that we've sent to HHS. But in the meantime, one thing that kind of wraps around this, and I'll end on this point, is the need to educate the patient. So above and beyond what's in the law itself, making sure that patients are aware and working closely with the patient community, and using us as a resource to help push information out to our patient communities. One thing that we certainly do as a cornerstone of our work is a lot of surveying and focus grouping and things like that. And so we've asked the question of our patient community in the past, how do you want to receive information about changes to your health coverage and things like that? So we have a wealth of data, as do many other patient groups, to help kind of support that, how they want to receive information, what messages are going to land, health coverage literacy. That's something I talk about a lot, because I think often, especially working in this industry, can take for granted that basic terms like step therapy or prior authorization aren't necessarily knowable to the average patient, and working with us to just kind of help make things really easy to read, digestible, all those sorts of things. That education piece I just think is very critical. So I will stop there and pass the baton.
Thank you very much, Anna. The consistency of the comments throughout all the sessions is really striking. The fact that we've placed a lot of responsibility on providers and health plans and vendors to come up with all of these tools. But I've only seen one or two regulations or laws that have to do with patient education. So I think we do have a lot of work to do in assuring that patients can take advantage of all of that. So that's on the patient side. Now let's move to the folks that are responsible for doing this work. Allison, like to give you an opportunity to talk about how Anthem is looking at these requirements and some of your comments on the timing and resources necessary to do this job.
Sure. Thank you, Stanley, and good afternoon, everybody. My name is Allison Armstrong. I work on Anthem's public policy team, and I've been deeply engaged in both the transparency and surprise billing regulation and law. So here at Anthem, obviously, it's keeping us very busy. But I think we've had a long-standing priority to improve our consumer transparency tools, to give members information in the context of where they are in their health benefits, and to make services available to shop, see have our provider directories as accurate as they can be, have consumer shopping tools so they can compare their costs. And so that's been a long-standing priority for Anthem. And so as we see these rules take effect, we've been trying to improve these things already, right? And I think some of the challenges that we're trying to think about, and building on Anna's point around the education aspect, is so for transparency tools, for example, we as a payer have a great transparency tool in place. I use it. I'm covered by Anthem. It's really easy to use, and you can get great information from there, but you have to know to use it, right? And you have to have the forethought when you're going to get care to think, maybe I should shop this MRI, see if there's somewhere I can get this, for less expensive. Consumers, that's not necessarily the first behavior they're going to do when they're getting care. And so I think at Anthem, one of the things we want to see is for consumers to rely on the health plan who is putting together all this information and has all of these tools, have consumers rely on their health plan when they're going to get care, because we can engage them for care management. We can look across their conditions that they have and direct them to providers that are going to be best suited for their conditions or their complexity of conditions. But the first step is getting the consumers to use it. A lot of the efforts that we are currently working to implement, the scope of these requirements, build into all items and services, whether you're talking about the transparency tool piece in the transparency regulation, or you're talking about the advanced EOB and, creating these. That scope of services is so huge, yet what we see as a payer who has a robust transparency tool in place is that 80% of all of the searches that are happening in our tool are for the same 50 services. So we really question the value, especially in the near term, of adding, 20, 25,000 covered items and services on a line item to build out those capabilities when we know consumers are shopping for a handful of shoppable services. And we can target and identify, at least maybe initially, to roll out, let's, create a manageable scope here. We're putting a lot of effort trying to encompass the entire world, whether it's a machine readable file or the advanced EOB or the provider directory. There are so many huge undertakings across the spectrum related to these transparency efforts that I really think we need to pause for a minute. Think about, what is the goal here? It's for consumers to shop for care, consumers to be able to get in-network care, identify in-network providers. So what we want to see is really that consumer being held to the utmost focus. So let's have consumer education and engagement as a consideration in this process. let's focus initial implementation efforts on the tools and provisions that are going to be most impactful for those consumers and help them actually shop for care. So, with all the complexities around the ID cards, the provider directories, the transparency tool, I think the overarching message and theme, here at Anthem and from an advocacy's perspective has really been, let's keep coming back to the goal. It is to get information to consumers, to allow us to shop for healthcare, to understand where there's variation in costs and price and be able to figure out why. And let's structure implementation in a manner that's going to prioritize those efforts first. So I'll pause there.
Yeah, Allison, thank you. And the term priority always keeps popping up, at least for me. If you had your choice of at least some of these items in the No Surprises Act, what would you consider the most important ones? And what would you consider items that perhaps we should slide a little bit on from a timeline basis so that we make sure we're doing this correctly?
Yeah, I think, aligning all those consumer facing tools. So the harmonizing the transparency and coverage and the CAA transparency tool and cost calculator requirements, harmonize those, narrow the scope, and get information out there that is meaningful to consumers. As far as things that should be maybe put on the back burner or narrow the scope or push out and delay the implementation, we see that especially around things like the machine readable file. And I know that's not the topic of today's discussion, but from a plan standpoint, the same teams are having to look at, these pieces all intersect somehow, and they're going to work with the same business units to develop implementation processes and compliance for these items. So, when you have the competing priorities, we would definitely say, let's stand up those consumer facing tools first. Anything that's going to be helping the consumer make an informed healthcare decision is where our priorities should be. And if we're going to be focusing that, then we need to have that consumer education component as well, because we can build it, but will they use it? And that really needs to be an emphasis focus as well.
And at the same time you're doing these, I believe there are requirements on health plans to make claims data and some clinical data available to patients. So we're really putting a lot of information out there for the patients, and they're going to have to figure out how to use it, correct?
Absolutely. And so I think, again, that's why, at Anthem, we want our members to come to us first. You have to go get a service. Let us help you find the right provider for us and for you. And let us help you find, the highest quality care that's going to be at an affordable price and going to, be within provide that information relative to where you are within your health benefits for the year and your deductibles and your out-of-pocket maximums.
Great. Let me include Mark in on this discussion. Mark, I've been familiar with CAQH and CORE probably since the organization was formed, and you guys do a great job of aligning requirements among health plans and helping to standardize some of the business processes, which is, I think, something that we're all looking forward to, since these are requirements that all plans, all types of providers have to follow. So let me turn it over to you and to talk about what CAQH is doing to help the industry move forward.
Stanley, thank you. And thanks to Weedy and the team, Michael, Rob, and my good friend Charles Steller for the opportunity to join my colleagues on the panel and for hosting this important and timely forum. I've only been able to catch a portion of the program, but I look forward to listening to the recording in its entirety later on. And it is my first time on a Weedy panel, so I know folks are going to be gentle with me today. By way of brief reintroduction, CAQH is a nonprofit collaborative with a mission dedicated to reducing administrative costs and burden in the healthcare system. As part of our work, we routinely engage more than now about 1.6 million healthcare providers across the country to keep their demographic information current, and more than 900 organizations that participate with us rely on us for that information. I am delighted to spend just a few minutes chatting specifically about the provider directory provisions in the No Surprises Act. Certainly the Act writ large has significant implications for for patients, providers, and plans. Many I know have been highlighted here today. For our part at CAQH, we have focused on a couple of the perhaps relatively lower profile parts of the law, but that we believe are nonetheless consequential and certainly in keeping with the work that we do on behalf of the stakeholder community. And one of those, of course, is related to improving the accuracy of provider directories and to reducing the burden associated with maintaining them. Why is accurate directory information important in the first place? It's been alluded to, of course, already, but it's of course ultimately an access to care issue for consumers. They rely on us for information in the directories to be accurate so that they can access quality, affordable care through their health benefit plans. Unfortunately, as many of you know, despite considerable efforts, directory information continues to be a challenge to get right. In fact, the most recent reviews of Medicare Advantage plans by CMS indicate error rates approaching 50%. And that, I think we can all agree, frankly, is not good enough for the patients that we all serve. Moreover, some of the, what I would certainly say are well-intentioned efforts to try to improve directory accuracy and move the needle on it have had the unintended consequence of actually adding to administrative burdens for providers and their office staffs. So I guess, not surprisingly, this has garnered the attention from both state and federal regulators and policymakers, which brings us to the No Surprises Act. Stanley already covered some of the key provisions for health plans. I've got them up on this slide, so I won't review them again. I'd point out, though, that as I think I've heard already, even in this panel and in the earlier discussion, many of the provisions are somewhat open to interpretation, and we're all awaiting rules from the federal agencies. That being said, we don't know whether forthcoming rules are specifically going to address the directory provisions or not. More on that in just a minute. I also wanted to highlight that notably the No Surprises Act breaks relatively new ground in placing requirements on providers relative to provider directories. This is in recognition of the fact that having accurate information in directories is ultimately a shared responsibility among plans and providers. So again, by January of next year, providers will have to have business processes in place to ensure that they are submitting timely information of directory information. They will have to submit directory information in a number of circumstances: when they begin a new contract with a plan, when they terminate an agreement. Importantly, whenever there are any material changes to the content of directories, because as you all know, directories are only as good as the information that's provided to the plans by the providers, and then a sort of a catch-all, any other term, time determined appropriate by the Secretary of HHS. I do want to briefly call out that compliance with and enforcement of these plan and provider requirements are an issue that bears watching. The No Surprises Act, including the directory provisions, generally makes clear that states are the primary enforcers of the law, and that is similar to the framework in the Affordable Care Act that we're all familiar with. So resulting from that, some of the key questions for the states are, and for the feds, will the states enforce the Act's provisions? As folks know, under the ACA, some states have chosen not to enforce selected provisions of the law. And in those circumstances, including in the No Surprises Act, states will not or cannot enforce the law's provisions, then the feds will step in and do it. Second question, can the states enforce them? Sometimes we forget, but they need to have the authority to do that. And regulators often insist upon explicit authority to enforce a law, even if it's a federal law. So if that does not exist, will policymakers give them that authority? Three, how will the states enforce the various provisions? In other words, what mechanisms will they employ? Which agency or agencies will be responsible? For example, state insurance departments have not traditionally enforced requirements on healthcare providers, and I alluded to some of those new requirements in the last slide. And last, and importantly, how, if at all, will federal and state requirements and regulations be coordinated? We know that one of the issues presented by the law is this sort of potential bifurcation of approaches in a given state, with the fully insured commercial market being addressed through state law and oversight, and a different approach being utilized for the self-funded ERISA market through the No Surprises Act. And so will states and the folks they serve be confused if there are, in effect, two sort of parallel approaches in a given jurisdiction? So I think a final point here, over the coming year or two, we expect that this will all be a bit of a moving target, as we think many states will either be enacting surprise billing provisions for the first time, or in some cases tweaking their existing laws and regulations to provide a bit more consistency in their markets in light of the No Surprises Act. And in addition, we think it's likely that some states may choose to wait a bit to draw on the experience of how the law is working to meet its goals in practice before they move forward with enacting new requirements. So from our perspective at CAQH, we really believe that improving directory accuracy is indeed a shared responsibility among the plan and provider communities, and that working collaboratively, and that means among the plans themselves, working together with providers and their representatives, and also with regulators at the state and federal level, is really crucial to move the needle. To illustrate that, we commissioned research, I guess now a couple years ago, to examine the impact of directory maintenance on healthcare providers. We found, not surprisingly, that the typical practice participates in some 20 health plan networks, and to then respond to requests from plans to update their directory information. Practice, on average, basically has to dedicate one staff person spending about a day a week in the office dealing with this from an administrative standpoint. That adds up to the cost on average of nearly $1,000 a month per practice, and extrapolated nationally, that means that physician practices could spend about $2.75 billion a year on administrative issues associated with updating your directory information and responding to plan inquiries. We know from experience that the burden on providers can be substantially reduced if they don't have to respond individually to each and every individual plan that they contract with. So that's one point. And a second point in terms of minimizing burden that we would encourage folks to look at is that we believe that group practice administrators should be able to update their directory information on behalf of the providers. So in sum, just a few conclusions. Although the No Surprises Act directory provisions aren't understandably getting the most attention relative to the law, they are highly consequential. We think stakeholders should remain focused on the fundamental goal that's been, I think, reiterated by every person I've heard today: improve the lot for consumers. This ultimately is about patient care. And then finally, stakeholders should collaborate to drive improvements in directory accuracy and to minimize administrative burden, particularly on the provider community. So that's Stanley. I will stop there and look forward to the Q&A.
Great, Mark, thank you very much. Just one or two questions for you. Apparently in the law, there were some deadlines for the updating of information by both providers and plans. Does that match the operating procedures that you have, or will you need to upgrade or change your operating procedures?
Yeah, it's a good question. I think you're probably referring to basically the requirement that they verify the information every 90 days. And that does essentially track what we're doing now. It's something that many of the plans have followed in accordance with CMS Medicare Advantage expectations. So we have been doing that for a while. The community is generally comfortable with that. On the plan side, obviously, this is being extended beyond Medicare Advantage to the commercial market in the States. It's being extended to providers who haven't had to do that before. So there are some new wrinkles relative to that. And as I mentioned earlier, state laws that are more consumer friendly, if you will. So I suppose you could say that a requirement that they be updated every 60 days would be more favorable to consumers, arguably. That if the state has those requirements, and there are a few that have shorter than 90-day periods, then those would supersede the federal requirements. We don't think doing that more frequently than quarterly probably nationally makes a lot of sense right now. And I go back to the provider burden issues we raised earlier. There is a significant burden that if this is not done well and done thoughtfully, especially since the ante is going to be upped on compliance. So plans are going to need to take this very seriously. And so they will be reaching out to providers, and we don't want provider offices inundated with requests to confirm their directory information, too often.
Thank you. Appreciate that. I'm going to turn to some of the audience questions. There is a question about whether the card information is going to be that helpful in regards to the in-network or out-of-network maximum, because providers are still not going to know from the card whether a patient is past their out-of-pocket maximum. My understanding is that's something that they could possibly get from an eligibility inquiry. But from the panel perspective, anybody want to comment on the information that's going to be on the cards and really how helpful it is versus knowing what the patients actually have to pay?
Sure, I'll take a stab at it.
Thanks, Allison.
Things we're thinking about ID cards is, there's, in addition to these requirements, right, there could be other state requirements for things to be contained on ID cards. And so how big are these things going to have to be? Is that really the best place to keep the information? So one thing we'd like to see is a QR code to, we're building these tools for them to use on the web. Let's direct them back to our website for their information, where they can also access the tools to compare prices and look for providers, and also have all of their up-to-date benefit and claims information along with where they stand within their benefits for the year. So how helpful will it be? I think, to your point, it is a stagnant number that will be placed on an ID card that is not going to be relative to where they actually are within that range. If it's, if they've hit their max or not, nobody's going to know that unless they call in or go to the website and find out that information. So we'd really like to see, a focus on directing them back to the tools we're building, directing them back to the capabilities that we are required to have, and get consumers used to going to their health plan for their information. ID cards can become outdated. It's costly to mail them out. And especially now, folks can have that if it's digitally. If you can have it digitally, that would be better, as opposed to having a ID card printed and mailed every time there's a change or in their benefit plan.
Yeah, and this is interesting as long as we're on ID cards, because frankly, for the most part, patients seem to rely on their providers to give them all that information, whether they've met the deductible or not, what their what their out of pocket is going to be. And they're just assuming that the provider gets it right, which for the most part they do, but that's placing a burden on the provider. Do you see this being a shift from the provider getting all that information and giving it to the patient, to the patients being required to get that information and have that knowledge? Anna, is that something that you guys have thought about?
Well, I think the shift is going to happen, but I think more so because of all of the other activities in place with the provider putting out their estimates, the health plan doing an advanced DOB. There's a lot of other activities that are going to start taking place that are also going to shift the behavior in which people are seeking that information and the way in which it's being delivered.
I think that's right. I mean, I want to double down on that comment about, I mean, the idea of having just like a QR code. We're also used to those now, right? From the pandemic, anytime you go to a restaurant or anywhere, it's like, oh, okay, this is how I'm looking at menus now. When many of us, myself included, had never done that before. We certainly have our split of patients who just really want and rely on paper versus digital. And certainly just because of the fact that providers are their main point of contact in the healthcare system, oftentimes they are used to going there. But I do think that that behavior shift will happen. You know, patients will follow the simplicity, for lack of a better way to say it, you know, whatever is going to make it easier for them to find the information that they need, they're going to follow that, and that will become their living, breathing document or source of information. So, I mean, I do think that that behavior change could happen, and if the health plan website is the best way for them to keep up with that, and it's following all of the sort of principles that we've outlined here, then I think they will use that more often. I think in the past few years, patients have really relied heavily on on portals from their provider offices to find a lot of information. So I think there's a lot of best practices that can be learned from efforts previously to deliver information to patients, and especially digitally.
Excellent. There was a question about, the use of blockchain work in directories and items like that. Mark, I don't know the technology behind the provider directory. Are you guys using any sort of a blockchain approach, or is that not what's being used, or can you even answer that question?
Yeah, well, I appreciate that, because I am a government affairs kind of guy, not a technology guy, so I'm not the best qualified to do that. I do know that we have taken a look at it. We're not sure that there's a lot of traction just yet to use blockchain for this purpose. I know folks are looking at it as of but I think I'd probably have to stop there. I'd be committing some sort of malpractice.
Well, we wouldn't want that to happen. I'm sure there's an attorney or two on the call that might be jotting a few things down. So we'll be careful. So this is an interesting shift from relying on the providers for information to potentially relying on the plans for information. But then thirdly, I guess the third leg of the stool, requiring or hoping that the patients gather that information. And again, this leads to the question about the patient education process. So I was curious, again, Allison, what are some of the things that you guys are doing to help educate your members on these types of requirements and these types of tools?
Sure. We, for depending on the type of account, but are fully insured, we communicate to members that the tools are available. As an Anthem member, I can get a mailer that will tell me, go shop for your care. Here's a tool. Did you know Anthem has all of this stuff available for you at your fingertips? And I engage on our website, which I think might be called Engage, all the time whenever I need healthcare. So my behavior has shifted to using that as my one source of information. But on the consumer education piece, I think one thing I just want to highlight is not only is there going to need to be consumer education around using the health plan tools, going to the directory, making sure they are aware this information is out there, but also having to mitigate consumer confusion from what may happen in the third-party app space, right? So, all of this data is going to be put out there from other sources. You're going to have the hospitals with information, you're going to have and providers, and you're going to have the health plans with information. But then you've got these third parties now coming in to pull health plan and facility information and create estimates and analytics for consumers to use. And we're already seeing that like on the hospital side, and you know, there's websites out there that you can put in and it will estimate your costs. We're really concerned that our members will go to those third-party sites, get bad data, rely upon that, and have serious concerns on the backside when their bill doesn't reflect what a third-party estimator tool may have said they would be responsible for paying. So I think it's not only consumer education about using the health plan tools and making sure their members are aware that those are available, but also making sure that there is some way for consumers to know that that third-party information out there is not necessarily the most reliable.
And yeah, it's an interesting point because there have been certainly. I go back to the you know, the vacation planning or the airline websites, and there have been a number of articles that say depending on the website you might get a different piece of information, or if you go on a Monday and you do a search on Tuesday, prices have changed. So we have to make sure that we get some consistency and accuracy out there from the third-party apps. And I don't know if there's anybody that's going to be in a position to say, hey, this app is accurate and this app is not accurate. So I'd say that is a concern. Somebody also raised the provision that there's some requirements we haven't yet discussed, like the requirement that all emergency services get charged as if they're in-network, and out-of-network providers located at an in-network facility must charge the network rate. How are health plans going to monitor that? And you know, how are providers going to keep track of that? Any comments from our panel?
Well, I would note that those determinations are going to be based on the qualifying payment amount. I think they're referring to the cost share methodology for out-of-network services under the no surprises provisions, and we're awaiting regulations. So it is, you know, there will have to be some determinations made as far as how that's going to happen. I think it's determinant upon what's defined in the rule. For instance, they say a qualifying payment amount that the cost share will be based on is going to be the median contracted rate. But stakeholders don't have the information as to, well, how will that rating area be defined? And will that median contracted rate be based off of the provider group level or the provider contract level? So there's a lot of specifics that we're waiting for in that regulation, which will help us understand what that median contracted rate will be calculated to be. And then we can determine the patient's cost share based off of that QPA. So I think that's just a work in progress right now, and it is going to take, you know, some work on both the provider and health plan side.
So let me ask. We're not exactly sure when the regulation is going to come out. Sometime, hopefully, in the next couple of months. With a January 1st, 2022 date looming, from both the patient perspective and the provider and the health plan perspective, do we really think that we'll have enough information that this will be able to work effectively, or are you concerned that we really need more time?
Well, we are hearing, first of all, the qualifying payment amount regulations are due out by July 1st, and they're currently at the Office of Management and Budget, and it's an IFR, an interim final regulation, so it'll take effect. And it's titled Part 1, so we know hopefully there's Part 2 coming. We've also heard from CMS during listening sessions that getting the surprise billing protections specifically and that IDR process stood up by the 1/1 effective date is their top priority. So much so that they haven't been willing to engage in more detailed conversations around transparency and coverage or other things that we really need them to focus on as well, because they are working vigorously on getting those regulations out. The IDR regulations aren't due until December 27th, but we have heard they understand those are needed and they will get those out ahead of time in advance of that 12/27 date. In fact, I think CMS is meeting with stakeholders next week to talk with folks about how they manage their IDR processes in states that have them currently in existence. So they are actively, drafting and thinking about those rules. So as far as the likelihood of us getting the information and being able to put those protections in place. That is the expectation. That's what we are moving forward towards as an industry. I think, everyone I've talked to from a payer perspective intends to be fully compliant with those provisions on 1/1, and we do anticipate we'll have the guidance we need to implement them. It's just a lot. And so with those competing priorities, knowing that CMS's priority and our priority for our members, we'll get that in place. But we want them to understand we have a lot of other things we're having to do towards that same date. So maybe the advanced DOB that goes into effect 1/1, that's probably not very realistic to get technical standards out, implement all of that, and turn it around and have it effective by 1/1. We think that's where we should see CMS give us some, grace periods or safe harbors or something around that. But the surprise billing protections, everything I hear is those will be in effect and stood up for consumers on 1/1.
That's interesting. So we're, in some sense, we're letting the regulations set some of the priorities, or at least listening to CMS on the priorities. So Anna, from your standpoint, does that seem like the right first step, and leaving some of these other things for later from a patient perspective?
Yes. I think that's where it has, because some of this gets into territory that's certainly beyond my scope. But I mean, I think somebody made a point earlier that I very much agree with, which is, that we would want to work towards getting it right, as opposed to just expediency, right? I mean, it's just, I think, better for all involved to do it that way. So to the extent that it's feasible and reasonable, as much as can be done by that date, the better. Most certainly. I mean, I think that would be a driving principle for us going forward. And, I don't think that patients generally expect perfection. They just want some modicum of consistency and just expectation with what they're going to be getting within a sort of reasonable range. So, and I'm hoping that a part of our role moving forward can be to work with all sides around how we can educate the patient community. I mean, we've struggled with how and when, when the bill was first signed into law, we did a big, statement and an FAQ, but that's a full year ahead of implementation, right? And the average patient isn't going to remember that necessarily. So like, when do we start kind of ramping that up? How do we sort of re-engage them around that? When it's one piece of so many things that they're dealing with in their healthcare and their health coverage. So that, I think, is a bigger concern, is just ensuring they know, to the points that have been made before, to look in the first place, and then where to look second.
And just for informational purposes, in case anyone does not know what an interim final regulation is, that's a regulation that CMS, the government, publishes. It goes into effect on its effective date as it's written, but included in the regulation is the opportunity for the public to make comments on it for a certain number of days as a comment period. And if the agency chooses, it can make changes to the rule. It's not obligated to, based on the comments that it gets. So those are usually held for unusual circumstances. I think CMS would definitely say that this is a circumstance where the rules need to go into effect because of the fact that the deadline is coming up so quickly, that the industry needs some certainty in enough time to do the due diligence and get the work done. That does not preclude the industry from making comments, and it will be interesting to see if there is enough detail in the regulation so that it satisfies health plans and providers and patients so that they can move forward. I think another thing that we want to think about in this discussion is how do we move towards sort of continuous improvement of these tools. We've got deadlines that we want to meet. I think people are going to try their darndest to make sure we meet the deadline in whatever way they can. But I'd be interested from the panel, how can we make sure that there'll be continuous improvement in these tools and requirements? Not just, all right, we've met the deadline, now it's time to move on to something else.
And with respect to the relatively narrow issue of provider directories, I mentioned earlier that really collaboration is key among the various parties. I think if every plan tried to do its own thing, required every provider to do things their way, we'd have a lot of frustration and not a lot of improvement in directory accuracy. And now that we've got patients with more opportunity for more engagement among the patient community to deal with this because of the way the No Surprises Act is written, really, I think it's a tremendous opportunity to come together again on this relatively narrow part of the bill anyway, to really drive the ability to get that information to be more accurate while also hopefully not adding to burden, but over time reducing burden. So I just point Stanley to hopefully an opportunity for collaboration. It's maybe ironic to say that about a bill that I know was the subject of fierce debate among the stakeholder community, but at least on this issue, in our experience, we think that coming together collaboratively is really, really crucial.
I would just build on Mark's point. It's in the plan's best interest to continue to innovate these tools and make them as user-friendly and meaningful to our members as possible, because then we can help to really have a meaningful difference in the care that is being provided to them by connecting them with the right providers, by connecting them with affordable healthcare. And so, that's why I think, Anthem has had these tools in place and has been continuing to refine processes, has been, participated in different provider directory pilots over the years as part of collaboration to, come up with an industry or, stakeholder wide approach that engages everybody. So I think that the motivation and incentives to continue to improve these tools is self-inherent for the plan. We've been building these resources and working to refine them absent any of these regulations, because it's in the best interest of our members. So I'll pause on that.
I mean, that's great, Allison. Are there opportunities for Anthem in collaborating with other health plans to build similar tools, or to have some sort of a standardized tool, or have you shared the things that you create with other plans?
As a Blue plan, there is a lot of collaboration on the tools, but as far as sharing, but that's just more of the Blue plan issue, the fact, that we'll have home states and host states and have members who may receive care in other states. And so we really need to be able to connect and extend that Blue plan network to members outside of states in which we do business. So there is collaboration on that front. I think right now, we're still really focused on ensuring that our tools are the best they can be for our members with the information we have in our system in real time to connect them with folks. Probably because of all the competing priorities, we haven't started working on cross-stakeholder tools just yet. But I did mention, there's the concern about these third-party tools. And so, maybe that would be a better alternative to have the health plans create, some Expedia type of site compared to having a third party do it that doesn't have any control or insight into any of that information. But let's not put those ideas out there just yet, because we've got a lot to do. So
understood. At some point, we should try and put together at least some best practices for these kinds of tools and websites. And Anna, from your standpoint, how do you collaborate with other sort of patient-focused groups to work with health plans and providers? Is that something that you spend a lot of time on?
Yeah, absolutely. Both individually and in coalition, depending on what the issue is. I mean, I definitely think that to the extent that we can sort of combine forces here and build some infrastructure or use some infrastructure to help keep it from becoming a siloed sort of one-off. You're talking to this person over here and you're talking to that person over there. I mean, I think that's one place certainly for Weedy to play on, you know, from its sort of umbrella standpoint. And then for us, I think like the National Health Council is certainly a good sort of already built the coalition that most major patient groups and a lot of health plans as well are members of. So yeah, I mean, it's something that we do. It's something that, you know, we're involved in a lot of different efforts and have a lot of conversations with members of the entire ecosystem, and would certainly raise our hand to kind of help facilitate any sort of coordination in the future.
And you know, that's a voice that I think is absolutely critical to be heard now, the patient voice. We haven't heard a lot of it because of I think the fact that that's plans and providers have done most of the work, the data exchange, and the focus has been on that type of interoperability. But as we move towards making data available to patients, making both quality and price data and clinical data available to patients, we really need to make sure that we're giving the patients the information they need, the content they need, in the form they need, and give them the tools they need. And that's something that we're going to have to rely on groups such as yours to provide. So I'm glad to hear that you know, you're involved in situations like that, and there are ways for patient groups to come together and work within the industry. I think that's something.
I appreciate you're asking the question, because you know, it's fun to talk about sort of the nuts and bolts of the law and, you know, whatever, but the tactics of how you're going to work together with other stakeholders is super important. And I, you know, certainly think a good first step would be for some of these umbrella groups to get together and sort of compare notes and start that work now, rather than waiting until, you know, until later. So I appreciate you raising that.
You're quite welcome. You know, and I think having those groups work with our provider and plan organizations collaboratively would be of benefit to everyone. So we'll see if and how we can make that happen. Any other questions from the audience? I think I've handled most of the chat questions. We appreciate the comments that people are making. There were some discussion about you know, some of the Fire apps and how all of that new technology can be used. It'll be interesting to see, you know, as we move forward with as technology changes and as requirements change, how we can build better apps and better tools for everybody. So I want to thank our panelists, Anna, Mark, and Allison. Great discussion. Once again, I'm always afraid that we'll run out of things to talk about, but thanks to you guys and thanks to the audience, we had plenty to talk about. So I appreciate all of your participation. And Rob, I will give you a couple of minutes extra, perhaps 3 minutes extra, to do our summary on industry perspectives.
I appreciate that, Stanley, and thank you. And thanks to Anna, Mark, and Allison for, again, a wonderful discussion of these key issues. But the fun isn't quite over yet. We have the next session, which we're going to summarize a lot of what we've heard and then sort of discuss some next steps. And we're very pleased to have, again, a wonderful group of speakers for this last session. Stanley is going to stick around. And for those who don't know, Stanley wears a number of hats. One of them is a former regulator. He was instrumental in the development of many of the HIPAA regulations. So he bring a lot of experience to bear with that. As well, we're pleased to have Viet Nguyen. Dr. Nguyen is a pediatrician and informaticist with Strata Matrix, but you'll know him as the director of the HL7 Da Vinci project. So thank you, Dr. Nguyen, for joining us. And we have Matthew Albright. Matthew is a Chief Legislative Affairs Officer for Zealous Payments. So we've got a wonderful group of folks, I am going to share my screen. And we've talked about having disclaimers on the advanced explanation of benefits and on the good faith estimates. Well, here's my disclaimer. I no doubt missed many major points today. I did my best to capture as many as the key issues as I could. So I want to walk through them. And a lot of them, as you can imagine, are in the form of questions. And I think that's part of what we wanted to do today, was to identify some of the key outstanding issues and questions that the industry had, and sort of compile them and start to potentially work on some of them. So I wanted to just go through a few slides. What I captured in terms of patient issues, I think there's a clear agreement on the need for consumers to have access to accurate and clear pricing information. I didn't hear anybody say that patients shouldn't have access to this information. I heard a quote, how often do we actually buy something, use it, and then later find out the price? I think it was Andrew who said that. Very important, I think. We heard also that we don't want to make it too challenging for patients to actually get the information. Too many clicks are needed to get the information that they want. Agreement, I think, that increased standardization in how the information is displayed will assist consumers in better understanding the data. Also, price transparency will probably not help in emergency situations. I think the peanut allergy example is a good one. However, I think the surprise billing provisions, which will hopefully prevent an out-of-network charge from arriving on your doorstep later, certainly will help.
Yeah, but Rob, just one comment on that, and that's for consumers to do some advanced shopping. I mean, if you can take a look ahead of time, and if you can see prices on emergency rooms and things like that, you can get a sense of, well, if I go here, it might cost a little bit more. If I go here, it might cost a little bit less. Price transparency. I know we've started out with shoppable services, but it's something to think about where folks want to be able to prepare and gather that information, not only price information, but quality information to help make the right decision.
Excellent. That's a great point, Stanley. So a few other issues, certainly on the patient side. I heard loud and clear on a number of the panels that patient education is going to be a challenge. The first issue is, of course, if we go through the trouble of building it, will the patients actually come and take advantage of these tools? So that's a question I think that we'll see what the answer becomes. I heard also, how can sort of a non-techie consumer navigate this online world of pricing? There's clearly not been public service announcements educating consumers on these new rights. But we did hear some suggestions. One, signs in hospitals and easy to navigate hospital websites to make it a little bit easier for consumers to gain access to hospital data. And then a lot of discussion about third-party apps, and will the data that they supply the consumer be consistent and accurate? Who's going to vet these apps? And there's a lot of concern. They're going to have access, as they will through the ONC and CMS rules, to PHI, protected health information. And who's going to protect the privacy and security of that information? And is it a question of when the information will be disclosed, not if? I think that's a big issue for the industry. As well, as we heard, cost is not the only factor in determining treatment. Quality has to play into this as well. And so the question is, how can we sort of merge cost and quality together? We heard that out-of-pocket costs are critical to the patient, but it's not the only piece of data needed in this environment. I think if we have better understanding of the overall cost of care, that would be effective and valuable to employers and others, and could serve as a driver to lower overall healthcare spending. Will price estimate tools be helpful? There's some debate on that. We heard some folks that say, no, they're probably not going to be accurate, so they're probably not going to be worth much. But again, I think the jury's out on that one. In terms of hospital transparency, clearly there are some compliance challenges. The pandemic, which we can't overlook, it has dramatically impacted every provider sector, and is certainly, as pointed out by Terry, it's diverted a lot of key IT resources that could have gone towards this, now focus more on dealing with the pandemic and things like telehealth. There's been somewhat of a lack of guidance from the government to really help the industry understand exactly what they need to do. And this is not the only regulation that providers are and plans are dealing with. So there's a lot in the mix, a lot going on. And although everybody tries to argue that healthcare should be just like Expedia and Kayak, it's not. As a former president once said, healthcare is complicated. Who knew? And so, it's not like other industries. It is more complicated. We don't speak the same language. It's not standardized. It's not like the banking industry that deals with dollars and cents. So it's going to take time. And I quoted Stanley here. Change takes time. We need patience to get to where we want to be. A few other points in the hospital and plan transparency world. Obviously, we've got sort of two formats, more of a human readable, and then one aimed at third-party app developers. We'll talk a little later about maybe a phased approach towards that. Obviously, price and cost sharing tools. Has there been sufficient guidance from CMS? There was some discussion of drug costs, and will pharmacy benefit managers be impacted? On the ID cards, the out-of-pocket costs are important, but patients rely heavily on the provider to identify the costs through the eligibility transaction. But that information, including potentially information on a static card, could become outdated, and then it's not as valuable for the patient. We heard that maybe QR codes could be leveraged as they are now in so many ways. Patients could simply scan the QR code, and that would send them directly to the payer website where they could get the information they needed. We talked about provider directories. As we all know, patients rely heavily on these, yet, as we heard from Mark, perhaps there's a 50% or more error rate. So the question is, can providers and payers work together to solve this problem? We've known it's been a problem for decades, but the problem is we haven't been able to solve it. Now there's a little bit of sort of government pressure to do so. As Mark said, the states are in line to enforce this, but how will they enforce it, and will they enforce it? And as Mark said, there needs to be coordination between states and the feds on this. And of course, throughout the day, we heard multiple workflow challenges. First of all, back to the quality issue, is there an opportunity to combine the two data streams? So you've got cost and quality pushing to the patient. But again, as the age-old question for providers, what is quality and how is it best measured? For example, the patient satisfaction surveys versus outcomes, very different. We heard also that this whole issue might be an additional rub between providers and payers, or could it be an opportunity to improve the communications between the two stakeholder groups? And yet again, is this an area for more guidance from the agency? We also heard in the chat, I think Dr. Wen brought up the issue of, if you have this in the mix, this discussion of finances, is that now another burden on the providers, and are they empowered with the information they need to have that conversation? And the FP, the American Academy of Family Physicians, have often said that the average family care visit is about 12 minutes long. Well, how much of that is now going to be taken up discussing the financial side of it? So again, a lot of workflow questions there. Will and can providers and payers aggregate estimates from multiple providers? I put here like a total hip replacement, and present one estimate to the payer and the patient. It could involve multiple facilities. It could involve multiple DME and different physicians. Think of the challenge of trying to coordinate that to provide the patient at a minimum with a list of the different elements, let alone the cost for each. So certainly an issue. And of course, will the providers need to sit down and explain all of the different components within that total hip replacement? Just the issue of getting the billing and diagnostic codes to the payer is going to be a challenge. And of course, how will that information be communicated, provider to payer, payer to patient, payer to provider, which of course could be optional at this stage, but we heard, I think, loud and clear that there's a need to have that information. I know Heather emphasized that, to have that information flow to the provider as well. And then the question is, do patients even want an explanation of benefits for a zero copay service? Do they really want to focus in on the out-of-pocket expenses? And if that's zero or minimal, do they just don't want to be bothered with the information? And of course, will patients know what to do with this advanced explanation of benefits? Will it be in a format and a form where they can make informed decisions about their health? And then we talked a little about bundled services as well. A few more, of course, it's almost endless, but and we heard this again loud and clear. What's the trigger for all of this? Is it the appointment itself, or does the patient need to request that they have this information given to them? If it's the appointment, you can imagine the increased burden, and of course, a burden even on the patient who said, I never asked for that. Multiple estimates in multiple formats, will that be helpful or confusing? Who's responsible for alerting the other providers when a good faith estimate or explanation of benefits has been requested? As this came from Terry, how will non-routine services be handled? What if the patient presents with multiple insurance products? That becomes even more complicated. And inevitably, as we've seen with every HIPAA transaction, what happens when the payer doesn't receive all the information they need? Now it's a back and forth. It's a back and forth communication, which takes time from both entities. How will a prior authorization play into this transparency communication? And of course, how will patients themselves receive the requested information? In terms of standards, again, could payers direct patients once they receive their billing and diagnosis codes? Could they sort of steer them or force them to go to certain facilities? For example, there's certainly pros and cons to that. It could be a money saver, or it could result in things the patient does not want. So a huge opportunity perhaps, but it has potential downsides as well. Providers would certainly benefit, as Heather said, getting the EOB from the payer. And again, it allows that conversation to take place between the patient and the physician to make the best choices in terms of healthcare. And obviously there's a lot of concern that a lot of these processes will be manual. So the question is, can we automate them? We heard that we should start with a floor, not a ceiling. There's a real need for standards and consistency. We also heard there's multiple sources for the data. There's a lot of options, one of them being the eligibility transaction, but as we heard, eligibility is more of a conversation and it might not be the best way to convey the information.
Rob,
yeah,
just on the previous slide, I believe I read that the advanced EOMB also has to include information that if the patient has been dealing with an out-of-network provider, the advanced EOB is supposed to give them information on in-network providers. So you talked about, can the health plan direct a patient to other providers? They can certainly mention that there are in-network options. So I think that's something that is already part of the law.
Excellent point, Stanley. Thank you. And I know Dr. Wen is going to talk about fire use, so I won't spend too much time, but I did want to highlight the URL if you want to get more involved. But frankly, will any solution be available, implemented, and fully tested by January 2022? I think that is a big question mark. Are we looking at multiple solutions, including some manual ones, mail and phone? And how can we, Stanley, I think you brought this up, how can we ensure continuous improvement in tools and workflow in solutions? And again, I think one of the things that we've learned from the past 4010, 5010, ICD-10 is, boy, it's sure nice to have a testing period. These things are all new. It's a new way of doing business in healthcare. There's a strong argument that the first 12 months, 24 months should be a testing period, much like the appropriate use criteria program implemented by CMS. And we heard that maybe we should be moving forward in phases, maybe focus on consumer-facing solutions first. Second would be the machine readable files. So put the priority on getting what the consumer needs, not so much what the app developers need. And of course, it's all comes down to enforcement. What are going to be the penalties? When will penalties start to be implemented? So lots of discussion. So with that, I apologize. I went a little bit long, but I wanted to turn it over to Dr. Wen to give us a little more information about fire and the work that Da Vinci is doing and provide his insight.
Thank you very much. Just a sound check. Are you able to hear me okay?
You sound great.
Awesome. Rob, I think that deck you just created over the course of the day, along with the other ones, will be extremely valuable to those of us who have to go back and report the events of this meeting to our superiors in our community. So I hope you're able to share that. I'd like to take a moment and take a positive spin, because a lot of these concerns and challenges, I think, are making everyone lose sleep at night. So I recognize that I'm very close to a street corner fire evangelist, so I am a realist. And I want to put a positive note on some of the things that are in the act that were discussed today. One is Mark from CAQH talked about provider directory. There's already work that CAQH has done and work that's done in fire around that Da Vinci PlanNet. And so there's work going to be implemented in just a few weeks by payers. There's already work with Karen and starting some work on the patient ID cards. And overall, the foundation for the health IT community moving forward in interoperability in general has been established through the CMS and ONC rules around the patient access API and IT certification. So if you had had any doubts about where fire is going, it's pretty well established now. But I've also realized that we have a lot of legacy technology and data that needs to be supported going forward, and that organizations are right now even building up their fire capability, and we're looking at all the work around scaling fire and interoperability through ONC FAST and the other fire accelerators. But I still feel very optimistic, and for the same reason I think all of us are as patients ourselves, as caretakers for others, that this cost and price transparency is very important to the work we're doing. I think of interoperability as a vertical through the whole health IT stack. So we have to address the policy aspects and the process aspects and the apps, and of course down to the data. So you mentioned in your slides that change management is a really important aspect of this. And so we recognize that in our work with Da Vinci. And so we've always felt since the beginning, when we first formed 2 years ago, that price cost transfer was an important use case for our memberships and value to patients. And that's why it was identified. And it just happened that we, with the other work that we were focused on, it came to even more prominence with recent regulations. So we've started on this work. So someone mentioned we should start right away. Fortunately, work is being done. We've brought together our members of payers, providers, vendors to look at the complexity. And as Vanessa showed in that earlier presentation around the work we do, we have this slide of what we're calling the dimensions of the complexity, many of which you've identified in your summary and folks have talked about today. So I won't dig in too much on those, but really for us, in order to develop a really good standard, we need a few things. We need to answer some of these workflow questions and the requirements that, from the policy side and trickling down from the regulations. So that's something we really need that help, as you do, to know where the triggers are. And then the gaps in information, that's one of those dimensions she pointed out. So a patient may know they need a total joint, but what does that mean? They won't know the details. So how do we help providers who may know how they deliver it within their own organization, create a set of a collection of items and services so that it can be compared for the patient and that they can send that on to the payer to get that AEOB. So understanding these gaps and where we can benefit from existing technologies, whether it be X12 or others, and existing knowledge that the payers and providers have around their negotiated prices and these services. And then we can then look at how do we combine these. And we've done this in Da Vinci already around our prior authorization work, working closely with X12 to kind of combine the existing capabilities in X12 and the kind of the future view and capabilities of FHIR. So I feel like we're moving towards a hybrid approach to this, given the speed at which we need to develop some standards. And the other aspect is really getting a good understanding of the data elements that we really need to share. So our Da Vinci community has been working on that. We've gotten a good scope. We are focusing on the subset of what's in the No Surprises Act. We were thinking we were going to do something more broad, but given the urgency of and the need to help the community with a standard, has put that at the forefront of our focus. So we want to invite the community to come participate with us, help us find out where our unknowns are so that we can make good standards. And that's really the challenge. Trying to make a high quality standard that takes into account everything that we can know is challenging to do in a short time frame. But we're going to certainly do our best to develop in collaboration with the community something that is useful, that takes into account the legacy components, and hopefully make guides that allow us to future-proof and reuse what is being built around FHIR and interoperability, so we get to the point where we can meet the goals of the No Surprises Act, as well as support the implementer community in implementing our guides. So with that, I'll hand it back to you, Robin, and look forward to questions from the community.
Oh, thank you, Dr. Wen. That was excellent. I wanted, before I turn it over first to Matthew, then to Stanley, I wanted to urge all of you, if you could put in the chat the types of actions that you would like to see WEDI take. So for example, would you like to get involved in one or more of our work groups? Would you like us to have additional educational sessions on this topic? Please let us know how we can best help you meet these challenges. So with that, I'll turn it, Matthew, over to you. You are an expert in these areas. I'm very interested to hear what your thoughts are about the summit and about going forward as an industry.
How's that? Can you hear me?
Yeah, perfect.
All right. So what struck me, I guess, one thing that struck me when you were talking about, when you're wrapping up the whole summit were some of the concerns about, and I heard it through multiple of the sessions, some of the concerns about educating the patient and how are we going to, once we build all this transparency tools and the advanced explanation of benefits, we figure out all the transactions, how are we going to, have the patients use it? And it struck me, and I'll turn to Viet and Stanley to get their perspective on there. But certainly reading the transparency and coverage rule, that preamble, a lot of it was like, this is not so much about the consumers. Like, yes, the downstream effect of this will be that the consumers will be helped. They'll have all the price information. But I think one of the regulators' intentions here and in the No Surprises Act is to get that information out there and create a whole new sub-economy of these entities that are scraping the data, that are doing the analytics on the data, and they're going to have multiple customers. And some of the customers are going to be health plans to help provider negotiations to figure out reimbursement rates. Some of them are going to be hit towards providers. Again, contract negotiations, what should be the pricing? How do you package this stuff? In both cases, these transparency requirements are a burden, but they're also an opportunity both for the health plan and for the provider to tell their story. And I think we saw that especially with the advanced explanation of benefits, where for the first time, the payer is going to get in front of the patient before they go to their service. And there's a great opportunity to tell the story, whatever that story is. And so I think there's this whole kind of economy that's going to be built up that's going to solve a lot of these problems. And the winners are going to be those that monetize it. And so I think there's going to be a great opportunity, and there's going to be lots of companies, non-healthcare companies, right, as Allison warned, non-healthcare companies rushing into the space of figuring out how to monetize this data and present it to patients. So I do feel that at the end of the day, one of our least of our worries maybe is the patients, because I think there's going to be a whole bunch of entities rushing into that space and doing the pretty thing on the mobile phone and using those interoperability rules to get the clinical data there and using the transparency rules to get the administrative data there. And there's going to be money in there, right? Because you got an advertisement right on that mobile phone when you use that app. So I don't think that's January 1st. I don't think that's 2 years, but I think 4 or 5 years, we're going to see a whole new group coming in. And of course, those analytics are also going to change the whole shape of how healthcare is priced and cost, not just from a consumer basis, but because there's all these entities that are going to be studying it and chopping it up and reporting who all the bad players are. And so I think this is a major shift, and the patients will be ultimately, the information is going to be shoved in front of them, whether they like it or not. I don't know, Viet or Stanley, do you have any view on that?
Yeah, actually, I totally agree with you, and I recognize that the travel industry is there is no good metaphor. But the travel industry is a decent metaphor, and Expedia is more than 25 years old. We didn't get to all these different platforms overnight. It took time, but when they were able to do that, it lowered the cost for consumers, and they had better information to make decisions. So I believe that the work that we're doing here and all these other aspects of interoperability are helping to make better informed and better engaged patients, and that making the data not the place where you're trying to maintain control. We got to raise the value, go up the value chain to where can you provide better care, where can you provide more efficient care, and provide better patient member satisfaction by making the data more transparent. So I agree with you.
I'll take the sort of a little bit of an opposite tack from the other two gentlemen on the panel. You scared the crap out of me when you talked about monetizing the data. If it doesn't cost the patients anything, maybe that's okay. I'm a little scared about the fact of monetizing the data. I think the trust factor is important. Is it better off for the patient to get the information from their health plan or from their provider directly, as opposed to going to a third-party site? And I think that's a question that we're going to have to deal with. Airlines, I'd like to think of flights, autos, other items as commodities. I mean, they're pretty much the same. I hate to think of a knee surgery, a knee replacement as a commodity. One doctor is the same as another doctor, is the same as a hospital, the same as a surgery center. I'll just go where I can get the best deal. I think certainly healthcare is a lot more complicated than that. And there is the trust factor involved. On the other hand, I think that we really have to do a big job of educating the patients. I don't think you can just throw all this data out there. There's still a lot of work to be done. I mean, even in explaining to patients what some of these codes mean, what some of these terms mean. I mean, I know that a gallbladder removal is a cholecystectomy, I believe it is. Well, you can't throw the word cholecystectomy out there to somebody and they don't know really what it means. You can't have lab results flying out to people that they don't understand, that can scare the crap out of them, unless it's clearly explained what they are. So they have, so I think we've got a lot of work to do in educating patients and not leaving it to just the app developers. So I have a slightly different viewpoint on that. And, in general, I think what we've done here is the act requires a lot of work by the usual industry players, health plans, providers, vendors, third-party networks, all kinds of people that we're used to deal with. But this is the first time it's really for the patient. Under HIPAA administrative simplification, it was plans, providers, and clearinghouses basically exchanging data. For the most part, the AHR interoperability requirements used to be for providers to exchange data, maybe for providers to exchange data with health plans. Now we're starting to involve the patients, and that's a whole different viewpoint that we're going to have to keep in mind. Enabling patients to use the data, to understand the data, to use it effectively and efficiently, and make the right decisions.
Stanley, to your point around we're not commodities, I agree with you. As a physician, I'd love to think I'm not a commodity. I think the areas that we have the most opportunity in my mind are areas where best practices are fairly well established and where there's a volume of services that we can start to compare. For example, the ophthalmologist, early days of cataract surgery, things like that, they were still kind of getting to the point where they knew what the best practice is. But now my stepdaughter recently had some eye surgery, corrective surgery, and she was actually able to go around to the different providers and get a sense of what their cost was going to be. And so I don't think we should try to lump uncomplicated total knee replacement, which is kind of medium complexity, with complex cancer care, because we don't necessarily understand best practices to the point where it's a predictable course of care, and that we may even have enough information yet to get the range and a good estimate. But I think these kind of activities that are high volume and are well established best practices, these are good areas for us. I don't know that at least for the TCR, I think they did address those 500 kind of most common. If we had something similar for this, that would certainly help.
Yeah, I'm sorry, I had to turn the volume down. My next door neighbor is an ophthalmologist, so. But,
I don't think they're having much of an issue around reimbursement.
Yes, but even simple procedures, and there's differences. And my understanding is there's differences in the way that you treat cataracts. Some with laser, some without laser. It depends on the complication, the size of the cataract, all kinds of things. So I think there's always going to be a bit of a tug of war between relying on your provider to give you all of the information that's necessary and relying on a site like, let's say, a website that says, well, here's the best care and here's the price you should pay for it, without really enabling a patient's very specific information to be input. And I think that's where we're going to start having some issues.
Yeah, and
I just want to reiterate. Go ahead. I'm sorry, Stanley. I totally appreciate you disagreeing. I think it wouldn't be no fun if Stanley didn't disagree. But I think the warning here, if it's a warning, is the data is now free, or the data will soon all be free, and anybody can snap it up. And so the monetization is who can take that data, make it usable, digestible for the consumer, and make a buck off of it. So it's already out there. And the warning, perhaps, and I think Allison was talking about this too, is there's going to be a lot of non-healthcare people are going to rush into that space, good or for bad.
Yeah. And with respect to the information, I would like to reinforce that what's the famous quote from our former defense secretary, the known knowns, the known unknowns, and the unknown unknowns. And you can only make an estimate on the known knowns. So we need to do our best to improve the known knowns so that we can, and we're likely to have to do a fair number of disclaimers and caveats that this is based on knowable, complications or underlying conditions, but that during the course of your care, the surgery, the procedures, we may encounter additional complications that are outside, that were unexpected. But that puts a lot of responsibility on the healthcare community to know our information the best we can and to deliver care even better to avoid complications.
And I'd like to figure out a way to have our continuous improvement loop that includes both patients and other entities. That we'll have our first set of items out there in January 1st, 2022. Something will be out there, and in July there'll be some more improvements, and the following year there'll be some more improvements. How do we get the feedback back to the regulators, back to the app developers, back to the providers, back to the health plans from the patients to make sure that we are making things better for them, rather than worse? That patient voice, I think, is something that we've been missing in many of our organizations. And we've tried to include in this a number of patient-facing organizations, which I think has been extremely valuable for this whole discussion. So we need to make sure we continue to raise that voice up.
I agree. It's challenging to because the patient is essentially the last mile, and we're all patients, and so I think it's incumbent on us to keep that perspective in mind. Because as I think about the complexity of what we're trying to do here, I'm thinking about my retired in-laws, and are they going to be able to engage effectively in this ecosystem that we're developing? But then I'm also optimistic about my young children, who technology is their first step. Find it on my app, find it on the web page, and then I'll talk to a human if I have to talk to a human.
So go ahead, Rob.
Let me ask a question that hasn't been asked today, and it's a tough one, but it's a good one for the end of the day. We talked about the transparency in terms of patients. What does transparency do to the industry when all of the negotiated rates are now available for everyone to see? All hospitals, all health plans. I don't know if you three have some observations on how that could potentially transform the healthcare landscape beyond the patient. I don't, maybe Matthew, I'll start with you.
Yeah, I think it's huge. I think it's huge. We've already seen new companies spring up from the hospital transparency requirement. That's only been there since January, and everybody knows that only about 20 to 25% of the top hospitals are even compliant, and yet industries have popped up, and they're in bidding wars for certain analytics, so that analytics is going to be fed back to hospitals for their repricing, for how they think about things, how they think about bundling things, how they think about how they're going to sell things, right? And it's notable that in the Transparency and Coverage Act, rules, they said, yes, quality, we know we're going to have to fold that in sometime, but let's get this out first and we'll think about quality later. So it's really going to be prices first And frankly, I think it's going to be who's got the better tasting espresso in the provider office and the bigger TV that you can somehow advertise and tell that story, right? So I think it's going to have a huge shift, certainly on pricing. I think a huge shift on networks, because now out-of-network providers are really going to have to make their case, because if this advanced explanation of benefits works like it's supposed to, there's going to be a lot of sticker shock when patients see that right away. And that sticker shock is going to be followed by, as Stanley said, a line that says, hey, you know what? You should be using an in-network provider across the street. Use this link. And again, not talking about quality yet. It's all getting ahead of quality before even quality is there. So I think it's going to be a big shift, and we're going to see a lot of changes. There's groups right now who are scraping the hospital transparency stuff, and they're planning on hitting that arbitration that we didn't quite get to right today in the surprise balance billing things, hitting that arbitration with all that data to figure out how to game the system. Game the system, I'm sorry, work the system.
So adding on to Matt's point, I think that what's going to happen is provider organizations are going to have to sharpen their pencils and really be able to know process-wise how do they get to the efficiency on one end, and understanding how do they deliver efficiently and the cost for personnel and items, machines, medications, and such for a total joint replacement. But when we add value, then they can say, we're an academic medical center, we're dealing with more complex, more difficult patients. Our negotiated prices are higher because in general, our population is more complicated, and we have data to demonstrate that. And then when we add the quality components, and there's always ways to improve quality measurements, they can start to demonstrate that by their quality, so that when a consumer, patient, member, and payers go to work with a provider, they take that all into account. And certainly it wasn't part of this, but CMS 123, the one around inpatient prospective payment program, there's a whole RFI in there around their roadmap and goals towards digitizing and doing digital quality measures, and they've been working in the fire community for a very long time to digitize those quality measures and develop the methodology to minimize the administrative burden of collecting them. And so we're going to have better, hopefully in the future, quality measures to look at not only how well you do processes, but outcomes as well. So we'll bring this all together, and as to Matt's point, prices start because everyone can understand that number, and then we have to layer on top of that delivery of care and the quality of the care delivery.
And I can see consumers dealing with their doctors and asking, why are you not in network? Why do I have to deal with you as an out-of-network provider? What's the explanation for that? Or looking at, if they look at the hospital price transparency, sort of calling up their health plan and say, how come you pay this hospital more than other health plans pay the hospital, or vice versa? I think there'll be lots of questions raised, and the explanations, whether it's I'm a more complicated hospital, I do a better job, I have sicker patients, I don't have sicker patients, I don't want to deal with the administrative burden, that's why I'm out of network and I make you do it. So I think there are going to be lots of questions asked, and some of the answers I don't think people are going to like, and that's where we need to do some better patient education.
Matthew, you used the word sticker shock, and I think that's so important. The question becomes, though, is what can they do about it? So, for example, if they're in a rural area where there's not a lot of options for care, they may find that their nearest in-network option is hundreds of miles away. We hope that telehealth will help to fill some of the gaps, but you can see here that it's a broader issue than just making the data available. And I wanted to get your opinion. It's a little we've talked about analogies with the travel industry, but there's a healthcare analogy that I wanted to get your thoughts on, and that is the CMS, the Medicare Open Payments database, where the idea was they would shine a bright light on providers receiving monetary benefits from suppliers and pharmaceutical companies would all be available in databases, and consumers